4th National Safe Motherhood Conference officially opened for God and my country.
Well, let's appreciate the technical team that put together that breakout. Once again, ladies and gentlemen, you're very welcome. I don't need to have extended that warm welcome to your neighbor. Let's do it like when we started, in your native language. So greet that person, wasuzotia, waramutse, habari ya asubuhi, and make them welcome. To the Spanish speaking, hola. Buenos noches, amigos and señorita. Mi alamo oye, les escucho en meses ananta, despacito. That is a little Spanish I know.
Yes, I don't know. So, I wanted to talk about something more about our poster presentation. Yeah, as you notice, there's been some bit of innovation, and we wanted to save our participants some money, that they don't have to print their posters. And we opted for the e-poster version. So those screens that you see out there have poster presentations for our participants. So I urge you to walk through that arena where the posters are, and we also request our poster presenters to pass by there, and when you see your poster, there stand by the side of the screen, and then take us through what your poster involves. Yeah, so I think that's what that I want to clarify. I know it's new technology, but yeah, we will be aware. Yeah, thank you.
Let's appreciate Dr. Kenneth Mugabe. He was meant to do the first presentation, which he has already done. So if you're looking at our program, we're so far into the program as planned. Dr. Kenneth Mugabe was helping us do the recap of what happened yesterday, and also do some little bit of reaction, and then we also happened to watch the video. Now, this very first session this morning, we're going to be looking at amazing discoveries as well. We'll be looking at newborn mortality, we'll be looking at community financing and model, and then later on we'll have a panel discussion. And to help us moderate this morning, I'm pleased to invite a very interesting lady. She's a health specialist at UNICEF, Uganda country, for over 15 years. She has experience in public health, and she has had significant contribution in maternal and newborn health. She has worked with Canadian physicians for aid and relief, and she has managed healthy programs focused on improving healthy care delivery. Ladies and gentlemen, please put your hands together, and we invite the one and only Ms. Grace Latihi to come and lead us to the very first morning session. Let's do it the chat version. Keep clapping until she arrives.
Thank you, MC. Ladies and gentlemen, protocols observed. Good morning. Just give me a few minutes just to go through what we will be looking at in this session. So this morning, we are privileged to look at something that is very pertinent to all of us. And we shall be looking at issues around maternal and newborn health with a special focus on newborns. And this morning, I think the MC has already talked about, the recap has already been done, so we're not going through that. So we will start with the keynote address from our very own, one of the most experienced experts in maternal and newborn health, and he's from UNICEF, and that is none other than Dr. Gagan Gupta. You're welcome, sir. I think you can see him. So I will quickly introduce Dr. Gagan. He is currently the senior advisor and the team lead at UNICEF for maternal and newborn health, and he is based at headquarters, New York. Dr. Gagan is a pediatrician, and he started his career teaching pediatrics, neonatology in the University Hospital in Mumbai in India in 2001. So you can imagine the wealth of experience he's going to share with us today. He brings 20 years of experience working in the field of maternal and newborn health, including working with governments, academia, professional bodies, and the UN, having worked from the sub-national level, national, and now he's at the global level. Dr. Gagan has strong experience in program design and development, policy influencing, and program implementation. I think most of you, if you've read some of the works on newborn health, maternal publications, you've seen the name behind it. He represents UNICEF as a co-chair of every newborn action plan. This is one of the action plans that is embedded within our RMCA shopping plan. And he has played a pivotal role in shaping the global newborn health agenda, aligning it closely with maternal and newborn health. He has been part of various global technical advisory groups. Allow me just to go through it so that you understand, especially if you've not met him, who is speaking with you, so that you can appreciate, but I'm nearly done. He's been part of various task forces for key areas related to maternal and newborn health, co-chairing them alongside WHO. He is well recognized for his work in India on scaling up newborn, small sick newborn care at district level, setting up 24/7 transport system for pregnant women and newborns, and pioneering online data systems for newborn care units. I think some of our work, especially in the standards, have been informed by the work that Dr. Gagan has done in India, leveraging on his experience. So learning from this work has helped him shape up a small and sick newborn implementation in Southern Africa as well as Sub-Saharan Africa. So Dr. Gagan, we are very pleased to have you here, and I would like to invite you to deliver your keynote address to this congregation that is ready to listen to you. We have with us over 900 people from different fraternity, academia, government, and also implementing partners, including our own frontline health workers here. Dr. Gagan, you're welcome to deliver your keynote address, please. Over to you. Thank you, sir.
Thank you so much. Am I audible?
Yes, you are.
Thank you. Thank you, Grace, so much, and to all the champions who are there for public health, and especially for the mothers, newborn, and children in this region. A very warm greeting to all of you from UNICEF, and I'm humbled by the introduction which Grace gave. But over the next 25 minutes, I will try and take you through the global landscape of the maternal newborn health program and what are the challenges that are acting as a headwind for us, but also more importantly, what are the opportunities to act and intervene. And already your country is doing an amazing work, something which is really appreciable. So, are the slides moving? I think there is a... Yeah. So if you look at the global landscape in the last 10 years has started to show some major shifts. The first and foremost is moving from standalone survival to both survive, thrive and transform. And this was largely driven by the SDG agenda. The second important shift which has happened is there is an increased realization that just access and coverage will not be enough. We need to ensure equitable, subnational coverage with quality. And the third important shift which has happened is, rather than talking about the silos of the mother and newborn, we are now more looking at a life cycle approach across the whole spectrum. Also, as UN agencies and global partners, we have started to balance our role, just moving from the global agenda setting to also making sure we provide the right support to the countries and the region. And there has been a strategic shift from moving away from the partner-driven projects to more of government-led programs, one-size-fits-all approach to more of a country-focused approach. What might work in India might not work in Uganda, what might work in Uganda might not work in Democratic Republic of Congo. So we need to adapt according to the local context. And last but not the least, there has been an increasing focus on care around birth and care of small and sick babies, given the amount of benefits we achieve from them. The second important shift on the program side is the newborn program needs have evolved a lot in the last 15 years. And we are moving beyond just essential newborn care and sepsis management to also focus on small and sick newborn. And when I say that, the essential newborn care still remains a very important pillar. But in isolation, essential newborn care will not give you the magnitude of the results we need to accelerate progress. And this realization has come from two things. One is, in the last 2 decades, there has been an 80% increase in the women who are delivering in a health facility globally. And also there is a subtle but definite shift in the causes of newborn death, with increasing share of prematurity and congenital malformation, which requires care beyond the essential newborn care. The last major trend which has moved in the few years is the increasing focus on primary health care. The things which are very much related to the newborn program, one is the focus of the immunization group on the zero-dose children. So we call them as zero-dose communities because these are the same communities where women deliver at home, and they are the markers of inactivity for our programming. Community health workers as levers of change. There are also common links across programs, be it the health program, the nutrition program, or the WASH program. They have an important role in birth preparedness, to the social mobilization for antenatal care, to the postnatal care. And lastly, which I always tell to my primary health care friends, that primary health care is critical. But again, without seamless linkage with secondary care and district hospital strengthening, you will not get the desired result. Now, as we sit here, what are the big challenges which face the MNH program? The first and foremost is, in spite of enormous progress, 25 million women still deliver without a skill attendance at birth. 1.9 million babies are born dead, and half of them were alive when the labor started, and that reflects on the timely access and the quality of care. And third is 2.3 million newborn deaths in 2022, with 64 countries off track to meet the NMR target. And more importantly, 43 of them are in sub-Saharan Africa. So in spite of a lot of good work which has happened in these countries, still we need to do a lot. Now, I made a brief mention of the change in the causes of newborn death. And globally, if you look, the share of prematurity is increasing. It has increased now to 37% at the global level, but this shift is more pronounced at the regional level, where if you see in South Asia, it increased from 34% in 2000 to now 39%. Same is with congenital malformation. Globally, 10% of the newborn deaths are because of congenital malformation. But again, you can see in South Asia, nearly double as a cause of death in the last 20 years. Now, it's not only about survival. We also have a huge challenge for thrive. If we save these small and sick babies, are we also ensuring they reach their full potential? If we treat a malnourished child, are we ensuring the child is reaching the full potential? Or the newborns who grow up are just not subjected to climate change, air pollution, lead poisoning, and the NCD. As a result, you have 250 million children younger than 5 years who are at risk of falling short of their full potential. Now, as we move to the second half of the SDG, with 6 years remaining, what is the big headline? The big headline is the progress in the SDG era is slowing down. With 6 years to 2030, we need to run faster and smarter. If you look at this graph, it shows on all 4 indicators, maternal mortality, stillborn, neonatal mortality, and the postnatal mortality. The first bar is the progress which was achieved during the MDG period. You can see for all 4 indicators, the annual rate of reduction was much higher in the MDG period. But when you move to the SDG period, the second bar, you can see the progress started slowing down in the first 7 years of the SDG. As a result, we need 7.7 times acceleration to achieve the target for SDG. Now, in context of Uganda, Uganda also is off track for all 4 indicators. But the good news is, because of all the good work which has gone through in the last several years, the rate of acceleration needed for Uganda is just 2 times. So instead of a 7.7% rate of reduction, Uganda just needs to accelerate by double, but that will also take a lot of effort and investments. And all this is compounded by what we call as the 5 C's. The COVID, the escalating conflict, the climate change, the increased cost of living, but to me the most important is the 5th C, complacency. If we think that maternal newborn health is a done and dusted agenda and we can take our hands off, that is the biggest mistake we as development community are going to make. So just to give an example of how these keys combine together, and if you look at the example of LMN, the decline between 2002 to 2015 was 30%. But then started coming the economic slowdown and the conflict in Syria, which led to a huge refugee population coming to Lebanon. And not to even count on what's currently going on there, but just the cost of living crisis and the conflict in Syria with nearly 1.5 million Syrian refugees, which now nearly constitute 1/3 of the Lebanon's population, has pushed the mortality rate where it was 20 years back. So we cannot be complacent. We need to be on our toes to make sure that even if we achieve the gains, we don't slip down. Also, to look at the humanitarian crisis, if you look at the neonatal mortality in the fragile and conflict settings, it is 2 times higher as compared to the non-fragile settings. And also what is important is that these countries account for a much lesser number of births, but in terms of the mortality, they account for 39% of the mortality. Now, there are some countries which don't have the fragile contact setting as a country, but you will have some provinces or some districts which might be affected, and this needs to be taken into your planning when you are doing your district level planning. Now, as I said, you need to run faster and smarter. But to run faster, you need fuel. But the funding is not matching the required need for acceleration. If you want to look at what countries reported in the ENA e-payment tracking tool, and we had this data last year from 106 countries, where we asked the government what has happened to the MNH funding after COVID in terms of the domestic resource allocation. And 40% of them said that the funding has gone down. But what is more important is, in the countries from conflict areas and from sub-Saharan Africa, nearly 80% countries said that the domestic allocation for maternal newborn health has gone down after COVID. Now this is based on the self-reporting by the countries, but it still gives some indication. Also, overall, the budget for health increased after COVID, but not for the maternal newborn health component. And if you look at the development assessment, reproductive and maternal health, and the newborn and child health, the blue bar is the MDG period, the orange is the SDG period till 2019, and the yellow bar is the COVID period. So you can see that the annual rates of the funding were much higher in the MDG period as compared to the SDG period, and they went further down in the COVID era. So on one hand, we need to run 7 times faster, but on the other hand, the domestic resources are going down, the development assistance is going down, and when we have funding, we are not using it for the right interventions. Just to give an example, if you look at the two most high impact but also high cost interventions, the emergency obstetric care and small and sick newborn care, only half of the countries have a national strategy for it. And when you look at the budget lines, only 28% countries said they have a budget line for emergency obstetric care and 22% countries for small and sick newborn care. So when you are short of funds, what is important is whatever limited money you have, you need to invest it in the right investment and right interventions to get the most results. Now, having talked about coverage, we need to also think about quality, because coverage alone is not enough. And I want to reflect the data back from Uganda from the beautiful MPDSR report which was released yesterday. You have 86% of the facilities birth, but asphyxia accounts for 59% of the newborn death. Now this is very unusual. Normally, asphyxia will account for 25 to 35% of the newborn death, and prematurity is the number one cause. But in context of Uganda, asphyxia is accounting for large number of deaths. But it also gives us hope that asphyxia deaths are more easier to prevent as compared to the premature death. So there is also an opportunity to intervene. And this reflects on the timeliness of care and the quality of care. Now, if you look at the strategies which are highlighted, are largely around neonatal resuscitation. But by the time you start neonatal resuscitation, it's already too late. Asphyxia is best prevented rather than treated. So ensuring a woman reaches a health facility in time, and in case of any intervention, including cesarean section, the time is very, very important. And I will come later on that, on the need for establishing a transport system for bringing women to health facilities and for referrals. Even if you look at some of the countries which have done very well in terms of their institutional delivery and the neonatal mortality, I was in Serbia a few weeks before, and Serbia has achieved 100% institutional delivery. But if you look at the early initiation of breastfeeding, it is just 8%. And one of the reasons is they have a nearly 40% cesarean section rate, and all babies after cesarean are kept away from the mother for 24 to 36 hours. And that affects the skin-to-skin contact and the early initiation of breastfeeding. If you look at the data from Uzbekistan, from the mix, again the same story. Very high coverage of still attendance at birth, but very low early initiation of breastfeeding. So still attendance is not still attendance unless you also ensure an early initiation of breastfeeding, the skin-to-skin contact, and zero separation of the mother and baby. Similarly, if you look at the antenatal care, many countries have achieved high levels of antenatal coverage, but the blood pressure measurement, the HIV testing rates are much lower than the AFC coverage rate. So coverage alone will not be enough. This is another example from Lebanon. I was there earlier in the year before all this recent crisis started. And you can see all the babies are being separated. They are just awaiting for a pediatrician to come and clear the babies for several hours. And you lose a very critical window of early initiation of breastfeeding. When you go to the newborn care unit, you hardly see any mother. And when the mother is not near the baby, then the care suffers. And very important thing is, parents are not visitors to newborn care unit. They have to be the part of the care. So having said all this, what will it take to accelerate progress? And for that, we will need to see where the most returns will come from. And if you look at the times of intervention in the pregnancy cycle, all periods are important, but the most gains for reduction of maternal death, newborn death, and stillbirth will come from two places: care during labor and the care of small and sick babies. And then ensuring that these babies are followed up in the community when they go back home. Now, there is always a dichotomy where should we intervene, either in community or in facility. But it's not about either or. It is about both community and facility. Now, if you look at this graph, the yellow bar is about the child health intervention. For child health interventions, working in community and primary health centers will give you the most results. But when you look at the gray and the pink bar, which is about the stillbirth and the newborn death, the most gains will come from working in the primary as well as the hospital. So when I say that whether it's community or facility, this picture depicts it best. It's not about home or hospital. It's about community seamlessly linked with the health facility and a follow-up care at home. And you have packages which can be well delivered near to the place where the patients are living, and there are interventions which are more delivered at the level of the health facility. And these interventions ultimately became the targets of the ENAP EPMM, which is we call as 90-90-80-80. That is 90% ANC coverage, 90% SB coverage, 80% coverage for PNC, and 80% coverage for small and sick newborn care, as well as EMOC. But what is important in these targets is the subnational component, and I will speak on it in a bit. So as I said at the beginning, we need to adapt to the changing landscape. So what are the few adaptations which are in the pipeline which I would like you to know? The first is the EMOC signal functions are undergoing a strong revision. If you recollect the 2009 framework of EMOC, N was just a neonatal resuscitation. But now you have a much stronger N component. For the basic EMOC, if you see on the right side in the red font, administration of parenteral antibiotics has been added. This is largely related to the work which we have been doing on PHBI in communities, the IKMC, and oxygen for stabilization. So for the newborn component at the BMOC level, in addition to resuscitation and early initiation of breastfeeding, the three major additions are administration of parenteral antibiotics, IKMC, and oxygen for stabilization. When you go to the next level, the whole package of level 2 newborn care has now been added. Because at district hospital, even if you resuscitate a baby or you stabilize a preterm baby, you need a full package of level 2 care including CPAP. And that has been now added into the revised signal functions for newborn. And the third level which now has been added is intensive EMOC. So comprehensive EMOC will have one more layer for medical colleges and tertiary hospitals, which is the intensive EMOC, and for newborn it includes the mechanical ventilation. And it recommends immediate KMC even for unstable babies, except when the baby is in a state of shock. Strong emphasis on calcium citrate for treatment of apnea, family involvement in newborn care units, and the home visits by the trained worker, especially for the preterm and low birth weight babies. Some of the recommendations around KMC have also been updated, and that also includes now KMC at home and mother's own milk for feeding of the preterm babies, and CPAP in preterm with signs of RDS. The third important shift which we are doing to adapt to the changing landscape is having a specific target in ENA on the care of small and sick babies. And that target is to achieve 80% of the districts to have a small and sick newborn care unit. But when we look at what the countries have planned across 109 countries, the level of ambition in planning is nowhere near what the target is. So we want to achieve an 80% coverage, but only 33% countries have planned for 80% coverage. So when you don't plan for 80% coverage, it's very difficult to achieve that coverage. And if you see in terms of sub-Saharan Africa, only 10% countries have achieved that coverage. And some very good examples you have from Sierra Leone, from Rwanda, from Malawi, from Ghana, and also now from Tanzania. So a lot of learning from the continent itself where you can bring these learnings in context of Uganda also. And when you see what Uganda submitted in the tracking tool data, it is also really similar. They have plants for nearly 30-40% of the districts, and current functionality is around 10 to 20%. Now, often when we talk about the level 2 newborn care unit, people think that just putting one radiant warmer or resuscitation might be enough. But it needs a whole package of care, with a newborn care corner in the delivery room, a stabilization unit, a level 2 newborn care unit with CPAP, and the kangaroo mother-father care in the vicinity of it. And this should build on a very strong foundation of the essential newborn care and linked with a follow-up care at the home and the hospitals. We captured all this in a 10-component model for small and sick newborn care, which we were co-authors with WHO. And these 10 components, you need to systematically go through if you have to achieve the scale-up of small and sick newborn care. Also, in the pipeline is the norms for the small and sick newborn care, which will define the number of beds needed. So the new recommendation is 24 beds per 10,000 live births, equitably distributed. 12 square meter for each non-CPAP bed and 16 square meter for a CPAP bed. And lastly, an optimal nurse-bed ratio in all shifts of 1 nurse to 3 to 4 newborns for a non-CPAP bed and 1 nurse to 2 newborns for a CPAP bed. And the last important thing is, a lot of these babies who are going home from newborn care unit are still less than 2,000 grams, and they need continued care for survival, growth and development. So we are going to now come with the follow-up care guidelines early next year, which will include the optimal schedule, the number of visits and the duration needed for the follow-up. So with this, I move to the last part of my presentation and some of the weak links which we see in the system. One is the transport system and referrals. This is one real weak link across countries. And I also said in the beginning that 60% of 6-year deaths are also because of the delayed access to care. But we have some very good examples. India has done a phenomenal work in a government-led transport system. And the data from India shows that half of the women were transported in the night, when the facilities in the village for a public transport are minimum. And here is what you gain as 6-year death, here is what you gain in terms of stillbirth. So transportation is not just from one facility to another, but also from the home to the health facility. Same way we have very good examples from Sierra Leone and Pakistan, where it includes pickup from the home, inter-facility transport, and even drop back to the community once the delivery happens and 24 hours of stay is done. The second weak link is the stillbirth, and I'm sure you will be discussing about this in this meeting in the coming days. But if you look at stillbirth, because there was no SDG target for stillbirth, countries did not prioritize it in the national target setting. And 90% countries or 80% countries have a target for MMR and the NMR, but only 31% countries reported to have a target for stillbirth. And also when you look at the MPDSR component, the component for stillbirth in the MPDSR is in much lesser countries as compared to the maternal health component, which is in 90% countries. The third weak link, if you want to look at, is the subnational coverage. And this is an example from Nigeria, where you can see in southern Nigeria, the institutional delivery coverage is nearly 90% or 90% plus. But when you go to the northern part of Nigeria, there are districts and states with coverage which is 15 to 20%. And this is so well reflected in the map of Nigeria, where half of it is green and half of it is orange and red. Also, I want to show you that many countries who have achieved reduction have not been able to do an equitable reduction in terms of geography. Here is an example from Tanzania. 41% decline in neonatal mortality, which is quite good. But the range is 22% in the worst performing district to 56% in the best performing district. And when you see the map of Tanzania in 2000, it was largely orange and pink. But in 2015 also, you still see a lot of orange and pink, but a lot of blue. Compare this with the map of Malawi, which has shown a 50% decline in the NMR in the same time period. But the range is very narrow, 48 to 51%. And if you look at the map, the whole map has turned from orange to yellow. So what is important is, as we are achieving acceleration, we have to truly leave no one behind. The geographies, the population groups, and especially now, the adolescent girls. One of the big challenges which Uganda will need to address is the high total fertility rate and teenage pregnancies. Children giving birth to children. That leads to stillbirth, that leads to maternal mortality, that leads to preterm birth and neonatal death. And just to pick up from the Uganda DHS data, the teenage pregnancy for last several years has remained stagnant at 24%. And what is the biggest factor which can go as an investment? That is the education of the girl child. The Uganda DHS data very clearly says, if mother has no education, there is a 5 years difference in the median age of marriage. Childbearing starts 5.6 years earlier, and they end up having more children as compared to women who have more than secondary education. And most importantly, it reflects also in the terms of mortality, where there is a higher mortality in the children of women who have no education versus women who have more than secondary education. And last but not the least, another big challenge is outdated data or missing data. At UNICEF, in our global repository, if you see, there is very good recent data on skill attendance at birth. But if you look at postnatal care for newborn, only 107 countries have data, and for cesarean section, only 46% countries have recent data. When you look at this for the mortality, it's even worse. For stillbirth estimates, 60 countries have no data. And for the recent neonatal mortality estimates, the average data gap was 6 years, but in Eastern and Southern Africa region, the average gap is 9.3 years, which is huge. Compare it with Western Europe of 1.6 years and Northern America for 1 year. So having more recent evaluated data, survey data is something which is going to be very important. So as I conclude, I want to leave you with these 5 messages. The first is, sub-national focus will be critical to accelerate progress. District plans, the sub-national data, and ensuring these plans are adequately funded. The level of ambition and investment, be it in planning, be it in budget allocation, or be it in target setting, it needs to match the need for acceleration. And I gave you 2 classical examples of emergency obstetric care and care for small and sick newborn. The third important thing is, quality cannot be an afterthought. It needs to follow coverage at every step, be it the human resources, the community, the missed opportunities when patient comes in our contact, or over-medicalization of care. The fourth is ensuring linkages and interdependence between service delivery. Just working on one aspect of a primary care or a secondary care or a community-based care will not give the desired result. You need a system which has a strong interdependence and interlinkages. And lastly, improving the data availability, especially the subnational data, and using the data for quality improvement. And as I conclude, I want to use this quote from our former president who said, "Dream is not something that you see in sleep. It is something that does not let you sleep." And the 900 people in this hall, I'm sure every one of us is carrying the same dream to save the 2.3 million newborns and 1.9 million stillbirths which happen each year. Thank you so much, Grace, and thanks to the organizers for inviting me and for all the wonderful work Uganda is doing. I went through all your reports, all your presentations, and I was amazed by the amount of work which the country is doing. And I'm sure you are going to accelerate further in the coming years. Thank you so much.
Thank you so much, Dr. Gagan, for that wonderful presentation. Delegates, when you listen to this presentation, you reflect on the work that you do. Where do you place yourself? And where do we see ourselves as a team in Uganda that is striving so hard to address newborn mortality? Well, Dr. Dagan, we've been struggling with the aspects of newborn mortality, and now it's a center of discussion and it has come to the limelight. And your presentation answers most of them. Can you hear me? You cannot hear me? I'm muted. Can you hear me? Can you hear me now? Technical team? Can you hear me now? You're muted. Maybe, is it on your side? Can you hear me now? It's on. Mine is on. He's muted. Can you hear me, Dr. Dagan? Okay. So, I don't think he can hear us. But key things that he highlights is for us to have a seamless program right from our facilities to the community. He also speaks about focusing at the subnational level and increasing the level of investment given the need that we have. Where are we putting our priorities? And then he also brings the aspect of quality. We've been dealing a lot with quality since 2017. The maternal component has done quite well, but the newborn component is also your measure of success. When we get newborns who are not well, how are we doing the other side? And so we need to look here and then work backwards to improve the quality of care. And then of course the interdependence on service delivery and improving data. Without data we cannot plan. I think Dr. Dagan brings to us many of the things that we've been grappling with, especially in the maternal newborn health. Aspects of birth asphyxia, which is quite problematic and still remains the leading cause of newborn deaths. But when we look at what other countries are doing, how can we reposition ourselves as delegates who have not only come to listen, but come to learn and take back with us what we will do differently, especially when we come to prioritization and planning for our programs with a focus on reducing newborn mortality. So thank you so much, Dr. Dagan. You're welcome to stay with us for the next presentation if you are available. And
my pleasure, but I will need to step out now. Thank you so much again for inviting me.
Thank you so much, Dr. Dagan. We wish you a nice day today. We don't know what time it is in your country, but for us it's early morning here. Thank you so much for the wealth of information and knowledge you share with us here, and it will indeed translate into implementation. Right now, I would like to welcome our next presenter. I think she will be looking more or less at community financing models. And one of the things that was highlighted in the keynote address was investments. Is our investment commensurate with the need on the ground? But let's also hear from implementation on community engagement to improve respectful midwifery care in northern Uganda. And we are so delighted to have with us Dr. Rachel, the Executive Director of Mother Health International. You're welcome, Doctor. Yes, over to you, so you have the floor.
Good morning. It's so good to see all of your beautiful faces. For my colleagues in northern Uganda, Ichoma Beng, Foya Tichma. I'm Dr. Rachel Zaslow. I'm faculty at Yale University in the USA, and we have a partnership with Makerere University's School of Midwifery. So it's really Dr. Scovia Belinda and her amazing program that is responsible for me being here today. So I've been working in Uganda, and in northern Uganda specifically, since 2006. I came in 2006 to work at Gulu Regional Referral Hospital. I know there are a few of you from there here. At the time, there was no running water in that regional referral hospital. There was no electricity. I would deliver babies on the night shift with my light that was on my keychain. We've come so far in infrastructure from those days. And also at the time, I was realizing that a lot of women, as we discussed yesterday, were coming in late. They were coming from the village. Now that time there was still war in northern Uganda, but they would come with complications that had started deep in the village from home, and it was too late for us, and without a lot of infrastructure, we often couldn't save them or their babies. So I read a statistic at that time that 80% of women in the region in northern Uganda, this was in 2006, were delivering at home with traditional birth attendants. So we know we've come really far from them, but this is what compelled me to then keep working in Uganda and think about how we build infrastructure. Because for me, I always want to go to what are the values of the women in our community? What are the needs and what are the barriers? And so I started working in Atiak. Atiak at the time, it's an hour north of Gulu, 75 kilometers north. And at the time, there wasn't any healthcare. The Health Center 4 did not have any healthcare workers, and the road was bad. So it was 4 hours to get from Atiak to Gulu, where we had to refer patients. So that is the seed of what started Mother Health International. Next slide. Okay. So this is the background here. We know that we have in Uganda unacceptably high rates of perinatal mortality. And it's not just in Uganda, it's in the global south. Yeah. Oh, I have a clicker. Okay. Excellent. Okay. Okay. Thank you. I'm being coached in real time. So we know that there are unacceptably high rates, and we also know that most death in childbirth, both maternal and newborn, is preventable. So my question has always been, if we know it's preventable, and we know the causes of death, what is the gap between the prevention and the causes, right? How do we get there? And it's mostly infrastructure and it's mostly organization of care. So I'm going to talk today about Mother Health International and our work in northern Uganda, and I'm also going to talk about some of the evidence for how we get there. So, I don't know how many of you have read in the Lancet series, the series on midwives about the quality maternal and newborn child framework. So I'm going to share it with you just in case you haven't. But this evidence and this framework says that if universal coverage of midwifery care is achieved, over 80% of maternal and neonatal deaths in stillbirths would be averted. 80%. So I looked at this framework, and then we started following it, and we started building a birth center in Uganda. So we have a birth center in northern Uganda in Atiak. That birth center has been around since 2008. And we follow this framework very well. Currently, this is our current statistics, right? You can see what the current perinatal mortality is in Uganda. We've lowered it significantly since when I started working in Uganda. And then below that, you'll see Mother Health International's data in the last 18 years. In 20,000 deliveries, we've had 0 maternal deaths. Our neonatal mortality is 11 out of 1,000. That is actually the same as what it is in many places in the United States. And it's lower than what it is for Black women in the United States. Because the United States still has a lot of disparities in health care. It is not only Uganda. We have this problem around the world. So, how did we get there? How did we get to 90% of women in Atiak sub-county delivering at our facility with a licensed provider? From 2006, 80% were delivering at home with traditional birth attendants. How did we lower our perinatal mortality to be on par with what it should be? So I'm going to talk about how, and also how we finance it. So this is the Quality Newborn Maternal Child Care Framework. This was a study that was developed and published in the Lancet series. This is a framework for how you achieve safe deliveries, and not only surviving, but thriving. You can see the practice categories. Start at the top with education, information, and health promotion. Then we have assessment, screening, and care planning. Then we have promotion of normal processes and prevention of complications. Below that, we have organization of care. It needs to be available, accessible, acceptable, good quality, adequate resources, a competent workforce, continuity of care. Services must be integrated across communities and facilities. Then we have values. Are we thinking about values? Respect, communication, community knowledge and understanding has to be respected. The care needs to be tailored to the woman's circumstances. Then we have philosophy, optimizing biological, physiological, social, and cultural processes, strengthening women's own capabilities, expectant management, using interventions only when indicated, not before and not too late. And care providers, practitioners who combine clinical knowledge and skills with interpersonal and cultural competence, and a division of roles and responsibilities based on need, competencies, and resources. This means we have to have all of these things in order to achieve these outcomes. Now we can look at this framework and you can say, okay, I might do well in one area, but in another, I don't have time, right? Maybe I'm really good clinically, but I'm only one person, right? For me, I only have these two hands, and I only have so much time in a day. I'm also a mother, I'm also a wife. How can I achieve all of these things for every patient that walks through my door? So I want to talk about how we work together. So this is the Mother Health International model. Here we visualized it alongside the 3 delays, which we talked about yesterday a lot. I know that a lot of you have heard extensively about the 3 delays. And now I really want you to put in your head this QMNC framework, because it's the pathway to achieving outcomes that are beyond our wildest dreams. So here we have the 3 delays on one side, the QMNC framework on the other, and the MHI birth center in the middle. Now, here we say traditional midwives, right? I know TDAs have been outlawed, and I want to be very clear. They are not the ones that are delivering babies, but we have converted them in our community to community health workers. The minute they were outlawed, we said, okay, let's go through the CHW training. Let us bring you in. Why do we do that? Because they are the ones trusted by the community. So they work with moms to organize care. They have a phone. The community health workers in our community have a phone. We have 60 community health workers who meet every single Saturday with our team of midwives, our team of licensed midwives. They have a phone that we give to them. When someone goes into labor, they call their community health worker and they come together as a team to the birth center. They are picked up by our driver on an ambulance. So everyone is brought to the facility together and then they are a team. So you can see how those things align to the QMNC framework. When they come in, they are respected. If they have certain religious preferences, if they have certain things that they need, if they have certain beliefs, we respect them. The next thing, right, is addressing the delays, which also is about optimizing care. So, you know, a lot of times when I've worked in many hospitals in Uganda and around the world, and I often hear midwives say, these mothers, they just don't come in, right? They don't come in for antenatal care. We tell them, but they don't come in. Now, for me, when I was pregnant, if I had to walk to carry my water in the village, and I could only carry so much in a day, am I going to pick having water for my family, or am I going to pick antenatal care? For me, I would pick water. If my baby seems fine, I'm not going to go for routine care. I'll go when there's an emergency. But what if my midwife came to me? What if we have motorcycles where midwives go and conduct antenatal care in the villages? And in doing so, we also work with community health workers who are organizing them. They are organizing them, bringing them together. Our community health workers often say, we sniff them out at the borehole. We know they're pregnant before they're even pregnant, because they know they got married, we know we talk to them about family planning, we know exactly what's going on. So they organize for them, and then we bring nurse midwives to them, and we bring everything. We bring testing, we bring ultrasound scan, we bring everything you could need for a suite of antenatal care, right there. So in that way, we've gone from having an average of 3 antenatal visits to an average of 8 antenatal visits per pregnancy. We know if someone is having twins. We know if someone has preeclampsia. We know in advance what she's high risk for, and we can prepare and we can make a plan. We're still 75 kilometers away from the nearest hospital, right? We're still deep in the village. Our roads are not good. Some of them are impassable. We need all of the infrastructure. And then the last piece here, this yellow bubble at the bottom, right, is having highly trained nurse midwives on call alongside the community health workers, and having a stock lab, a stock pharmacy, and labor suites. So I've talked a bit about this, right? Community health workers, they're the keepers of cultural knowledge. We know that we can work on clinical excellence. That's something we as doctors, as midwives, we work very hard to do, is clinical excellence. But the evidence shows that if you have clinical excellence alone, you'll still have bad outcomes. Why? Because you're ignoring the circumstances of the mother. If she's experiencing domestic violence at home, if she's experiencing food insecurity, if she's experiencing too many children to leave the home and come for care, right? If she doesn't have any money for transport, it doesn't matter how good of a practitioner you are, your mother won't reach you. Or something else will intervene. So we have to work together, and we have to work as a team. When we talk about working as a team, it's not just midwives and doctors. In fact, for me, it's look at the mother, and then think about every single thing that surrounds her. That is our network of safety. Who is she receiving information from? Is it her mother? Is it her auntie? That person is part of her care team. Is it her community health worker? That person is part of her care team. Then we get to midwives. Then we get to doctors. There are things I can do, and then there are things I need to call my colleague, Dr. Annette Nakmuli, and say, Dr. Annette, this I cannot do. Please, you're a surgeon, you help me now, right? But it's also the same on the other side. There are things, I'm a midwife, I only have these 2 hands. Can I reach every mother in her home? No, I don't have that much time in the day. But who can do that? A community health worker. Who can do that? People in the village. We can work as a team to surround the mom with the care that she needs. The other thing is optimizing physiologic and biological birth, okay? This is something we've come really far from in the hospitals in Uganda, and this is a big part of that. You know this pelvis of mine, right? Do you know why childbirth hurts for women and not in cats or dogs? Does anyone know? Any guesses? It's because we walk upright. Cats and dogs walk on all fours, their tailbone does not curve under. For human people giving birth, our tailbone curves under, and it makes childbirth painful and it causes delays, right? The shape of the pelvis, the shape of the baby, all of it has to fit very perfectly. We have moved into lithotomy position for women in labor. That was developed by male obstetricians in the Victorian era for their own comfort. But did you know it makes the pelvis 30% smaller when a woman is laying on her back? So we tell women lay on your back to give birth. Now we've made the pelvis 30% smaller. We have more obstructions. So for us, we really value, get in the position you want to get in to have your baby. Me, I'll adjust. I'll adjust. If you want to deliver on your back, fine. If you want to be on your side, fine. If you want to be on hands and knees, fine. Me, I'll adjust. I'm the one who can move. I'm not having a baby right now. So we optimize these things, we optimize the process, and we really listen to what's happening for the mom and the baby. We monitor closely the heart tones, we monitor her vitals, and we adjust. We make a plan. We make sure we have an ambulance available, so if we need to transfer to higher level care, we can. This is about close collaboration, right? So we have a close collaboration with not only our nurse midwives and community health workers, but we also have a close collaboration with our hospitals that we transfer to. When we need to send a woman, we don't tell her, oh, well, I can't treat you anymore, go to the next hospital. That's often what happens. You have to make your own way. We do what's called a warm handoff. So if someone needs to go, we take her. We make sure she's in the care of the next level practitioner before we leave her. Right? These are all part of safe motherhood. I only have 5 minutes left, so I've talked a lot about all of these categories. I want to talk about how we make this happen. Okay, this is a breakdown of costs. So at the Mother Health International Birth Center, the average care per person, this is from the first prenatal until the last postpartum, all the way through is about $55 US. For the Ministry of Health, it is generally about $45 that is invested per person, okay? So we're about $10 more. How do we fill that gap if we don't have investments, right? But also here's the difference with this $10. We have an average of 8 antenatal visits. We have essential transport. 90% of women in Atiak sub-county deliver with a skilled practitioner at our facility. We have an average of 3 postpartum visits. We have a continuity of care strategy so that no woman can get lost. When I tell you, we know where every single woman who has delivered with us lives, what her circumstances are, and what she needs. I am not lying. We know that about every single woman in our area, and it's a big district. Our C-section rate is 5%. Our neonatal mortality rate is 11%. And our maternal mortality at this point is 0 out of 20,000. This represents about 67 averted maternal mortalities. Okay? Now, we're not big, we're not like Kawempe, right? We average about 3 to 4 deliveries in a day. We're not averaging 100 deliveries in a day. And of course, we refer to higher level facilities. As we said, a lot of referral hospitals will have a higher rate because they get the more complicated cases. We follow all of our referral cases, so these are included in our numbers. It's not just that we've referred out our complications and we're not referring those. So, yesterday somebody said that at the beginning that investing in midwifery has a return, right? Investing in maternal health care has a return. So, there are a lot of breakdowns, but on average, investment in the midwifery model of care saves $22,000 US per averted death. $22,000 US per averted death. Now, at MHI, in our short amount of time, with 20,000 deliveries, we've averted 67 maternal deaths. Okay? So think about that with a difference of only $10 per care episode, per patient that walks through our doors. So that small investment has a big return when you start thinking about it in larger numbers. So this is the study that sort of talks about the cost effectiveness. So how do we do that? So one of the things that we've done is made our community stakeholders. Yesterday, Dr. Jean talked about a program with hers about 1 chicken per family, right? That the community invests a chicken and that's what's used to build the birth house. We do something very similar. We have community, we ask for 5,000 shillings. Right? That 5,000 shillings from the community, because even if you're not the one delivering the baby, your cousin, your auntie, your nephew, your niece, somebody will be delivering. If everyone donates, then we have a pile of money here that we can use for fuel, for our ambulance, to pay our community health workers for organizing. The community knows when they come to us that they will have the care they need. And so it's very easy for them to invest that 5,000 shillings, dollar by dollar by dollar. We fill our gaps with community investment. And so we have a partnership that is part public funding via community investments, Yes, I'm wrapping up. This is the last bit. And then the rest is with, the rest is about really thinking about coordinated care with DHOs, with the Ministry of Health, for anything else that we need. So lastly, we've developed a curriculum around the Quality Newborn Maternal Health Framework. The curriculum is to expand this around Uganda and help bring this model to anywhere and any community that wants it. So I thank you for listening. Lastly, I ask everyone to put their hands up. You have hands that are in service of our community. In this room, hopefully there are community health workers, there are doctors, there are midwives, there are funders, there are administrators. Each of us has only 2 hands. Please grab the hand of the person next to you. Yes. Okay. Now we are connected. None of us can do this alone. We have to create a network of safety. The network of safety is from me to you, to you, to you, to you. Each of us is in service to this country, and I know together we can do it. So thank you.
Powerful. That is very powerful, Dr. Rachel. By the way, Dr. Rachel is a midwife by training, so those of us who are midwives are saying, we are not tired. Here we are. Apoy Mata, teach my better 19 morning. If I'm from there, let me speak with them through your things. And wherever they're doing work in the region where I come from, so I'm so proud of you. Thank you so much, Dr. Rachel. She highlights critical issues that come up. I think we've had discussions around taking services to communities in our platforms, technical working groups before, and we've shared some of the work that other programs have done in order to visit mothers and reach them in the community. So one of the things that we take from Dr. Rachel's presentation is the fact that they've taken a framework. How many frameworks do we have? Over the time, how many frameworks have we developed? We have PET framework, we have PPH framework, we have reduction of newborn framework, but how have we implemented those frameworks? So when I listen to her presentation, it's not only the content, but how do I learn, or how do we learn from what they have done to also be able to implement some of the frameworks that we, as stakeholders in all this, we've developed over time, and how do we measure ourselves in terms of delivery of the commitments we make through these frameworks. She also highlights the fact that she looks at the social determinants of health, although she of course breaks it down, that affects access to care and services, which is quite critical. But most importantly, she also brings on board, she discusses in return on investment. Many times when we listen to presentations, we're asking, okay, then how much? How much will it cost us? So when we have donors in the room, I think some of these models is what we can also take and integrate in our programs, because we see that the return on investment is quite good in terms of when you place $1, how much have we saved? And we also have an opportunity of the investment, newborn investment case, I think under development already finalized, that shows us if we invested in a certain package for newborn care, how much return do we get, or how many lives how many lives do we save? So thank you so much, Dr. Rachel. That was very inspirational, and I would like to applaud you for the great work that you're doing in Northern Uganda. And I hope that we can take this to scale, because many times we have small projects, but our challenge is taking them to scale. So next on the, sorry, we're not doing well with time. So for the panelists, I think we'll need to really stick to the time that we've allocated for the discussion. We are going to have a discussion, a panel discussion, and I request the panelists to take their seats. Please, it's going to be looking at strengthening community systems for accelerating a reduction in newborn mortality. So what's the role of the community? Very interesting discussion, which builds right from what the keynote address speaker presented and what Richard presented, and then looking at the practicality of it at different levels of care, starting from the national to community. Can you please take your seats, delegates? So, as they take their seats, what are we looking at in this panel discussion? The objective is for us to discuss opportunities within the community health systems for integration, for integrated and cross-sectoral investment for delivery of sustainable and comprehensive maternal newborn health results. We will also be looking at the level of systems inputs and strategic shifts required to accelerate community health as a key pivot for accelerating maternal newborn health outcomes. And we will be discussing some of the innovative approaches. We will be discussing innovative approaches, high impact interventions and lessons learned necessary to optimize community health towards improved maternal and newborn health outcomes. And we have with us our delegates. You're welcome. We hope you had a nice rest, and we're looking forward to listening to you. And so I would like to introduce them. I will introduce them as they speak, before they speak, so that we can save on time. Just so you understand who is speaking and the wealth of experience they bring to the table. So I'll start with our ministry, the steward to all this program. I'll start with Dr. Hilary Atwere. And Dr. Hilary is a senior, Dr. Hilary is a senior medical officer in the community health department. He has previously worked in Fort Portal, at Health Center 4, and Regional Referral Hospital, as well as IMC, now here, CCare. You're welcome, Dr. Hilary. We're very excited. He's going to represent the Ministry Community Health Department, and I'll go straight to the question. Dr. Hilary, for you, what are the key community system strengthening opportunities, looking at models, investments that exist within the community health strategy that we as program implementers in the room can use or take advantage of to advance maternal newborn health outcome at community level? Can you please share with us what the Ministry and Community Health Department has for us in terms of this area of work in the system strengthening cascade? Thank you.
Thank you, Grace. I'm happy to be here. The Ministry of Health is cognizant that health is built at home, in the community really, whether it's a home, schools, or any other community setting. And so through the Community Health Department, with the support of the other departments, developed the National Community Health Strategy. And this is an approach that is intended to be multi-sectoral, because we all know that different sectors contribute to health. And so it's meant to tap into the different sectors to be able to achieve community health. And so through the Community Health Department, it's backed the National Community Health Strategy, which we hope will be able to help the Ministry of Health to be able to mobilize resources available through partnerships with various implementing partners, and so be able to deliver community health at a community level. This strategy seeks to be able to help the ministry to map the different providers and implementing partners, and this should be able to help determine what resources can be deployed in the various community spaces. And so in this, it's envisaged that that we should be able to institutionalize community financing through public-private partnerships. However, maybe two key areas stand out in this strategy. One is to be able to build capacity of the village health teams, to be able to support them to cause engagement of the community so that they are empowered to be able to seek community health services and better the practices at the household level. And this can be leveraged by the maternal and child health interventions so that we have better outcomes. And at this level, this strategy ensures that services are integrated. And so in the process of building capacity of these village health teams, it's envisaged that we'll be able to approach households as a whole, as opposed to, say, implementing different activities that look at only key area, only a few areas. For example, if you were to implement ICCN, it would be probably isolated from other interventions. This strategy ensures that the approach is more holistic and integrated. And so in this, we hope that we'll be able to increase demand for these community health services. And so this, we hope, can improve the budgeting for these services. And maternal and child health interventions can leverage this to be able to achieve even better outcomes. The other key area would be because as we do the implementation, there is need to assess ourselves and be able to know how we are doing and understand in which areas we need to improve. So this strategy is intended to leverage on the electronic community health information system so that we can better understand what areas we need to work on, especially those that are key to maternal and child health. And we think that maternal and child health interventions can really leverage this to be able to enhance the outcomes that and the good strides that we've already been able to achieve. Yes, so maybe to close on that is that this strategy also enables us to be able to bring all this together in order to promote and essentially prevent disease, but perhaps to better our health so that we and in case disease does come, then this has been anchored to our already existing structure, which is facility-based, to be able to then complete the cycle.
Thank you. Thank you so much. Delegates, you've had we have a strategy. So we need to interest ourselves in understanding what the strategy is all about and how we can influence and ensure that newborn and maternal health is included, both in terms of investments, but also in their prioritization. And so, Doctor, you've highlighted critical issues and the elements or aspects in the strategy that actually we can leverage as maternal newborn health programs. I want to put Dr. Harriet on spot now. And Dr. Harriet is currently working with UNICEF as the health officer and is based in Arua Zonal office. And she is the team lead for health at UNICEF in the Arua Zonal office. She's a pediatrician with over 10 years experience in health programming, focusing on maternal and newborn health, nutrition, comprehensive HIV, WASH, health system strengthening, both at national and subnational level. She previously worked with Baylor, Uganda. And here in our panel, she's going to speak on behalf of partners, not only UNICEF, but partners in integral manner. And I just want to throw it back to you, Harriet. You have listened to Dr. Hillary's submission about the community health strategy. And looking at partnerships, what roles do partnerships play in strengthening community health systems? And from your experience, interaction, engagement in different platforms where we've seen partners play critical roles, what are some of the examples of successful collaborations that have improved maternal and newborn health? Over to you, Dr. Harriet.
Yeah, thank you very much, Grace, and thank you, colleagues in the
Is your mic on?
Yeah, hopefully that it's on.
It's better now.
Yes, so with partnerships, there are many opportunities that partnerships bring, and one of them is partnerships bring together resources that may be financial or non-financial to be able to achieve better results for health for both children and newborns and women. And these results may otherwise have been not achieved if these partners were not present to bring their different complementarities on the table. The partnerships also play a good or important role in closing health equity gaps. So they promote health equity. We've listened, and the reason we are here today is because of the power of partnership. Different partners in the house on the MNH agenda have come here today, and we've listened to their roles in different areas. Work that would otherwise be difficult to achieve without the partnerships. And in terms of promoting health equity, we've listened and heard. Most of these partnerships are coming in to address different vulnerabilities within our communities. And that way, we're able to provide a fair package of health care to our communities. What have been some of the excellent examples of partnerships? I'll start with the community itself. Nothing for us without us, as it's always said, especially in the HIV space. We've seen communities coming together to do different things. Communities themselves driving the agenda for maternal newborn. We've listened yesterday to examples of communities supporting blood donation drives. We've also had very good examples of communities raising funds for transport, establishing their own schemes for transportation of sick and small newborns, and also women that are pregnant or have given birth. And we have also, there are different components also of community, like parent support groups. You are all familiar with the parent support groups that have been formed around this country, one led by Mr. Basilio. There are many, and some of them just need to figure it out better. But these are helpful in supporting within the community. Of course, it's important to mention the public, where we have the largest number, which is the community health workers. And I'm sure my colleagues who will be speaking later will be strongly speaking about how the community health workers have been greatly used to put in to be able to support in promoting health for women and children in the communities. Then comes the transport agencies, the commonest in our section that we've worked with mainly around maternal newborn health is the border associations, which are being used in different ways to support transportation from community to health facility. Different regions have used this, and they are being used effectively in previous programs like Saving Mothers, Giving Life, the current programs that are running in the Western region with the community voucher system, where we see transportation of women and newborns and children under 5 from community to health facility with very good outcomes as a result of the additional support that comes through this work. We've also seen and experienced good partnerships with the private sector as a country. And the commonest example that is closest to our memories is in the recently concluded PET Awareness Month, where we saw private sector coming in different regions to support the awareness creation and the advocacy around hypertensive diseases of pregnancy. And the other is the faith-based institutions, and faith-based institutions come in different ways. Sometimes providing the community support around community financing. All of you may be aware about the community health insurance, where burial groups that started as burial funeral groups now have over 40,000 membership of members of the community are running a health insurance through the work of faith-based institutions. And in addition to these faith-based institutions, we've seen awareness being created through churches, through mosques, on different maternal newborn issues that have come up severally, and awareness is needed. And these are some of the areas where partnerships have been key. We have seen also had to run for babies through MTN. And those are some of the areas where we clearly can see the partnerships coming off and supporting one another, whether advocacy or financing, things that could otherwise have not been done if the support was not there. And then we've seen private sector coming on different ways, like we have digital platforms that have been developed to support maternal newborn health agenda, like Family Connect, delivering the key family care practices using these platforms. And these kind of platforms, electronic platforms, are being created with the support of the private sector. Of course, there are so many players that I can speak to, and I could speak until the cows come back home. But one thing that I can emphasize is that we are all here, CSOs, health development partners, philanthropies, different players, academia. I mean, schools are very important. We already had. If we keep the girls in school, then we can delay some of these problems that are associated to maternal and newborn issues. So with that, I think that I can come to a close. There is so much that can be said.
Very well put, Harriet. Thank you so much, Dr. Harriet, for highlighting partnerships. Sometimes you are boxed. We think inside the box. We don't think about the roads. We don't think about private sector. Even within our communities, we are thinking about just health and the clinical aspects of health. But health is beyond clinical if you are to make impact. And Harriet, thank you so much for bringing up some of these issues, the partnerships and their contribution to the work that we do. And let us also take note. I just now want to move to our friend, Henry, Lulu Henry Leko. I just want to briefly introduce him. So, allow me to introduce you before you can make the submission. Mr. Lulu is a DHO, assistant DHO for maternal health, and he operates in a Germany district, and he's played a pivotal role in overseeing maternal newborn health initiatives, bringing practical community-level interventions that have strengthened and improved maternal newborn health services in Germany. He's the vice coordinator or the assistant chair for the local maternity, West Nile local maternity system. And then before he joined the local government, Henry was the regional manager for AIDS Information Center in both West Nile and Lango, where he managed the regional health programs. But he also worked as a manager for Better Outcomes and Dreams project. Muke? Award 4. That's how far I can go. I think I'm safe that way. Looking at what Harriet has discussed, Henry, drawing from your experience, can you please tell us what you think, or from your region in West Nile, not only looking at Adjumani, but looking at West Nile, since you're even the vice chair for local maternity systems, West Nile local maternity systems, what are the most innovative and high impact innovations that have optimized community health for maternal newborn health? And as you share with us, can you also advise us on how you think this can be replicated beyond West Nile, the boundaries of West Nile region, maybe to Western or actually sub-region? Over to you, my friend.
Thank you for the kind introductions. Before I dive deeper into that subject matter, I want to take this opportunity to appreciate the government of Uganda and especially the Ministry of Health for the enabling policy and strategic framework that has promoted open door policy, that has also strengthened public-community partnership. And we also want to appreciate the various government partners. I may not be able to have the opportunity to call you by names because you are quite many, for the tremendous contribution, especially in the strengthening of the community health programs. Why I recognize the Ministry of Health is because the engagement of the community health structures is grounded on the community health strategy, but also more importantly, which was launched more recently, the self-care program, the self-care strategy. These are very, very key strategic directions that we are taking to be able to address some of the critical maternal and newborn health issues, and those are the areas which I will be focusing on. As the previous speakers have said, it is difficult to divorce the community health structures from the community health system from the health system, because these play complementary roles in terms of the facility community referral and facility community referral system. And so this is one of the things that we will be looking at. I want to appreciate the ministry for the support, especially the Western region, in helping us to personalize the community health strategy, especially the VHTs. Adjumani is one of the lucky districts that benefited from the Ukraine project that aimed at strengthening and revitalizing the VHTs. And so we benefited a lot in terms of capacity building for our VHTs, about 720 VHTs in Adjumani district and in other 20 districts benefited from that. And this is very key because the previous VHTs were trained long time ago when we were talking about the 6 killer diseases. Today we are talking about 13 vaccine-preventable diseases, and malaria is just knocking around the corner that we'll be able to produce this next year. So these are very strategic areas of focus, and I can tell you therefore that the civil societies and the partners in West Nile build on the foundation that the ministry made to revitalize the VHTs and other community structures. In Adjumani specifically, and the region, various development partners put resources to strengthen the Ministry of Health, to develop the necessary standard operating procedures and guidelines for enhancing the capacity of our community health workers. Here we are specifically talking about the VHTs that are cutting across the districts. We're also talking about the community health extension workers that are being piloted, and in the West Nile, specifically in Marachawe, is piloted in other districts. Through the support of Ministry of Health, we were able to develop standard training manuals and also guidelines to be able to enhance the capacity of these community health workers. Then, secondly, is that with this support from the partners, we were able to ensure that we collect real-time baseline data. Baseline data on the status of the community health service interventions, but also key performance indicators that needed to be addressed at the community level. Specifically in Uganda, for example, we are able to collect data, analyze our data on VHT reporting in terms of timeliness, in terms of completeness of reporting. We are able to collect data on key maternal and newborn health indicators, and then we went to the community to engage them in assessing their knowledge, their attitude, their practices in areas of maternal and newborn health, and also other health interventions. And that was very key to enable us to be able to provide evidence-based capacity building for these VHTs. We were able to do that very well, but we also built the capacity of the district level trainers and mentors. This is the strategic approach by the government partners, so that even if the resources, funding ends, the districts are able to sustain these gains. So I can therefore report to you comfortably that we have district level trainers of trainers who are able to provide the necessary capacity building for the VHTs at the community level. And specifically talking about the multi-sectoral approach, we enhance capacity not only in the health, we enhance capacity in community services department, we enhance the capacity in education, Ministry of Education and Sports. So at the level of the district, we are building the capacity of the DSTs, the education officers, and the community development officers who are at the front line of service delivery, especially the ones at the support level, to be able to provide support to this. When we did this, the next level now is to build the capacity of the VHTs. And this is done by the resource persons we have at the district level, including the senior woman and male teacher, if we talk about education. In health, we are building the capacity of midwives, of nurses, of clinical officers, a team of health workers who can be able to provide training on adolescent responsive sexual reproductive health services and GBV prevention and mitigation. We are able to then, using this, we did capacity building for VSTs, we did capacity building for peers, as I like it. We are looking at the group A's, for example, and group postnatal care. We are looking at the YAPs. We are looking at also health workers who are able to provide adolescent responsive health services, but also peers. The peer model is gaining momentum, and I can therefore say with confidence that we're able to build the capacities of peers in school, out of school, both therefore that helps us to be able to provide services at the facility, at community, and even in schools. We train, for example, in Uganda, close to 100 senior women and male teachers, who in turn went and build the training of the mentors, the peers in schools, to be able to provide sexual reproductive health education, and be able to empower people to appreciate their sexual reproductive health rights, be able to hold the bearers accountable and demand for services. We were able to also inform them of the availability and the existence of these services in our various facilities, in the communities. With the support of partners, we mapped key community hotspots where the key drivers of the challenges of adolescents. Talk about teenage pregnancy, talk about alcohol and substance abuse. We're able to map these spots. We're able to engage the community in the dialogues so that we're able to get solutions. In the local maternity, we usually say local problems require local solutions. So we go, for example, the subject of teenage pregnancy. We go and sit on the round table with the young people represented, with the political leaders, with the religious leaders, with the cultural leaders, with the police, family and child protection unit, with education officers, with the health workers. We are able to examine what is this that is driving some of these challenges. Alcohol and substance abuse, the increase in road traffic accidents affecting young people, teenage pregnancy, all these we discuss and we're able to get local solutions to these challenges. And then also what has worked very well in in Western and especially in Germany, is engaging the community health structures in health education and health promotion. We have empowered this team to go home to home. The VHT is going home to home to mobilize people, to sensitize them, and you have all seen, even in the first class, where we integrate HIV, TB screening, nutrition screening, and all these challenges. We are able to onboard these people so that they are the first line, frontline officers who go to educate community on some of these diseases of public health importance, and arising on here, they are able to make effective referral and linkage to our facilities. We have also seen communities being engaged in self-care programs. With the support of UNICEF, we are in the kitchen, we are trying to cook something in Uganda and in Africa, particularly caring for caregivers. This is a pilot, a mental health and support initiative to empower caregivers to be able to, first of all, identify the challenges that goes through with caregiving, but also to empower them with the support of VHTs to be able to address some of these challenges. And this is a big partnership. Ministry of Health, Maternal University, University of Wits in South Africa, UNICEF, the district local governments, the Ministry of Health, the Ministry of Education. We are trying to do that, and already we are seeing the promising results. This is informed by evidence. When we did the maternal and newborn quality of care assessment using the digitized World Health Organization standards, the 80s quality standards, we noted that mental health has been one of the poorly performing indicators. Actually, indicators that deal with mothers' experience of care, right from effective communication, respect and dignity, and then, more importantly, the mental health are indicators that were not doing well. And so with this, that we are cooking in the kitchen, our belief is that, and with the results that we are seeing, the preliminary results, we are seeing that that will be an innovative area that we can scale up. We have seen improvement in referrals. When we did the assessment, we have seen progressive improvement. When VHTs go to homes, identify mothers that have risks. Currently, we are implementing the IRR. IRR is identification, referral for lower BMOC facilities, but also retention in the CMOC facilities, and timely response to some of these emergencies. It is something that is working very well in a number of selected facilities, especially in a facility called Mongola. We are doing a very tremendous job. Those are initiatives that can help because we put the community structures at the forefront of identifying this. When they go to homes, during their home visits, they identify high-risk mothers. They ensure that these high-risk mothers are walked to the health center and handed over to health service providers. And from there, we are able to see that lower-level facilities that realize that this is a problem beyond their scope. They are able to refer from these spoke cells to the hubs. The hubs are the CMOC facilities, the health center force, the general hospitals, and regional referral hospital that has dedicated days for attending to high-risk mothers, which is done by a medical officer, by a midwife, by a laboratory technician, by a sonographer. So we have a multidisciplinary team that is able to work on these matters, and we already see positive outcomes from those initiatives that are work replicating to other districts.
And finally,
the story is enough, but let me now address myself. Let me address myself to provision of basic health services. We are all aware that under the self-care program, Ministry of Health is promoting particularly the subcutaneous injection as a family planning method that is the responsibility of protection and also preventing teenage pregnancy in the hands of these adolescents and young people. In Germany specifically, I want to say this is paying off. We started when our contraceptive prevalence was only 22.7%. In the last 3 years, we have moved to increasing contraceptive prevalence, to 48.6%. And I think we are currently in the district that has increased family planning uptake by a bigger margin. And I think we are on track to achieve the family planning target 2020. I think that is one of the critical areas. Also, the areas of teenage pregnancy, because of this intervention, and the community dialogues. The engagement of communities to appreciate the importance of family planning, especially the immediate postpartum family planning. We are also getting to do this. In Germany, currently our teenage pregnancy is at 15% compared to the national average of 24%. And I think there is therefore a lot of positive lessons that we are learning from there. In terms of the system, I cannot believe this. During the adolescent conference, the Permanent Secretary Ministry of Health officially launched the guideline for the operationalization of the district committee on adolescent health. I want to say with the support of development partners, we embraced that long time ago. Currently, as we talk, we are flying as a district because we have a functional district committee on adolescent health that sets plans, that is able to go and supervise delivery of adolescent health services at the community and the facility at the community level. That is able to come back of the drawing board to have a multi-sectoral dialogue guided by data. We extract data from DHS, we get data from the community service department, we get data from the education, to be able to track the critical adolescent health indicators, and where we are not doing well, we are getting back to the community with the support of their leaders to make sure that we address this task.
Thank you so much, Henry. Colleagues, the story is indeed long, and I hope West Nile has been well represented, and I hope it's a true reflection of what's happening. As UNICEF, we are very proud of West Nile and all the stakeholders within the region, and we're also very proud of Ajumani. He's spoken about partner issues, multi-sectoral approach, integration, and we can see the passion that he has. He could go on and on and on. But allow me now to move to the next presenter. Where are the midwives in the house? Woo! We have not forgotten you. And in a special way, allow me to read this. I know time is up. Chair. I mean, I'm MC, but allow me, we are only left with one panelist after this. Allow me to read this profile, midwives, so that you can also get inspired. So with us we have our midwife. She's Courtney, Sister Courtney, and at Uganda, she's a devoted and passionate midwife. You can see that from the age, retired but not tired. She brings 40 years of experience in facility and community-based care, and she has spent much of her career working with Chiwoko Hospital as a midwife. She is currently running a hospital-to-home program with Adara. As a community midwife, Courtney manages a large group of 120 village health team members and provides at-home follow-up care for high-risk babies for up to a year after discharge from Chiwoko Hospital in neonatal care unit. And she comes with the home-to-home, the first newborn follow-up program. It's one of its kind in Uganda, and I think we've also heard from the other presenters. They highlighted elements of this model in their presentation. Courtney's contribution as a midwife has transformed the way care is delivered to vulnerable newborns and their families in the community. In 2021, to crown it all, before she can speak, in 2021, Courtney was the finalist in the Midwife of the Year category at Ugandan Hero in Health Awards. In 2020, she was honored as one of the women in the Global Health 100 Outstanding Nurses and Midwives. And then in 2019, the profile, please make a profile for yourselves, so that when you retire, people remember you. Lastly, Courtney was named, in 2019, she was named as a newborn champion by the Minister of Health for her dedication to vulnerable newborns and their families. So Courtney, you're very welcome. We're so proud of you. What a profile. So I will go to the question to save time. Given your experience working in the community, how can community empowerment be sustainably achieved to reduce newborn mortality? Please use your experience, first-hand experience. Please share with us the experience, Mom.
I appreciate to be here. I'm going to use the hospital to home program to answer the question. Hospital to home program is a follow-up program on babies, on small sick babies who are discharged currently from Tuoko Hospital. And to make sure they thrive, they survive and thrive. The hospital to home program was started, it was initiated in 2019 after a research which showed that babies were not returning after discharge. They were not returning to the healthcare facility for follow-up. It was found that only 30% were coming back to the healthcare facility. So we had to go and look for the 70. We are working now in the community. We are following up these babies after discharge. We have two components in our program. We have the hospital component and we have the community part. I'm going to talk more about the community. But in the hospital, once the babies are admitted, during their stay in the hospital, they are given a discharge package, which include the topics like kangaroo mother care, breastfeeding, hygiene, identification of daily signs by the mothers, so that babies don't die. So once they are discharged, before they are discharged, they are linked to the community. The discharged staff links the mother to the village health team. This village health team, they are executives who are in the community. They are part of their communities, so they were the right people we chose to use in the implementation of our follow-up program on these babies. This village health team, I work with the 120 village health team, and we work in 3 districts, Nakasongola, Nakaseke, and Ruwero. These village health teams were equipped with the knowledge and skills, basic knowledge and skills to care for the newborn babies. And they were equipped with a backpack and all equipment needed for the baby's examination. They were given weighing scales, they were given timers, thermometers, and they weigh these babies whenever they go there. What do they do? These VHTs. They do home visits, and once they visit these babies, they do growth monitoring, breastfeeding assessments, they educate the mothers, the families, not only mothers, but the families. They educate on relevant topics, like the KMC, again, breastfeeding. At first, these mothers, after leaving the hospital, they were not continuing to express breast milk, and this killed so many babies. They were stopping to breastfeed, they were putting these tiny babies on the breast, thinking that they were taking milk, but there was nothing. So these babies used to die. So supervision of the breastfeeding now has made them survive. When these VHTs, before they go to the community, the VHTs, they have to visit the local councils. They report to the local councils that I have come to visit the such and such a person who is having a baby, a small sick newborn. So we work hand in hand with the local councils. They help us to identify, to locate the families where these mothers stay. They also, not only the mothers, they don't only visit mothers, but they educate the whole community about prevention of premature deliveries, prevention of hygiene, prevention of diseases, and they are also consultants, the community consultants there. So being in the community, in their own community, this empowers the community to accept, to access, and to utilize the health care in their areas. Because these people, they do a very good job. They are influencers of the community, the VHTs. So when these mothers are educated, visited, they continue looking after their babies very well. We get live babies. And what they do also, they identify danger signs. And once any danger sign is identified, the babies are referred to healthcare facilities, or if the baby is having a developmental disability, the baby is referred to Baby Ubuntu. Baby Ubuntu is our sister program which helps the babies with disabilities to live a better life. So we have the Baby Ubuntu where we refer our babies once identified with the developmental disabilities. The community has to be involved in every activity. If anyone wants to anyone wants to implement a program, he has to involve the community. The community has to be involved, and the community members have to participate in the program so that they own it as their own. Owning that program, it will continue even if the implementers go, because they will know it is their program and it is their own health, it is their own babies, so they have to work to accept it in the community so that the baby survive and thrive.
Thank you.
And these VHTs, the community leaders, the LOCs, they mobilize for transportation of these babies to the health facility. They mobilize the community to contribute money to give to the mothers, the mothers who are not able to raise up funds for transport. So we also collaborate with the Ministry of Health, the district, the sub-counties, the health facility in charges. We collaborate so that we do things together.
Thank you
we
so
cannot
much.
work alone.
Thank you so much, sister. I know
Let me conclude.
you know, we also when we said area of our passion, we want to put our hearts on the table. So, okay, finally.
Yeah. Currently, we are piloting the H2H program in the public setting, and we hope it will work. We have just started, we will be telling you the results. So, community engagement is very important. It empowers the community, it sustains the interventions, and if we do it, all babies will survive and they will thrive.
Well said. Well said. Thanks so much. I think she highlights one of the critical areas that we all miss in our programs. We celebrate so many newborns, preterms, discharged from our facilities. But when they go back, do they survive? And what is the quality of life if they survive? Many of them survive with disabilities, and we know what disability is. If you have a child with disability, it's very painful and very expensive to manage these children, especially when you don't have a good support system. I would now like to ask to put our ice on the cake as we wind up. I'm sorry that we are a bit not doing so well in time, but this is our last presenter, and she is Dr. Elizabeth Ekirapa. She is an accomplished public health expert with 15 years of distinguished performance, and she is an associate professor at the Department of Public Policy Planning and Management at Maternal University. She's a medical doctor. She also has masters in health economics, a doctorate in health systems research from Trinity College, Dublin. You're welcome, Doctor, and we're excited to have you. So from the academic and research perspective, Doctor, can you tell us how research, innovations, and emerging knowledge on community health can be leveraged to accelerate reduction of newborn mortality, and what are the promising advancements? Tell us what the promising advancements are showing in terms of what will give us most potential when we invest at community level. Thank you. Over to you.
Thank you. Thank you so much, Grace. So when we think about community systems, we are thinking about using organized structures and processes to help us deliver the services. But we are also thinking about integrating these services with community needs and resources. And so the first thing I want to say is that we need to link research more with the service delivery that we do. And talking about what are some of the interventions that we could be able to look at, that we could be able to utilize. I think we've already had so many of these interventions. I won't go into so many of them, but we already know these interventions. We know about the potential of KMC. We know about the potential of things like mHealth. We know about how we could utilize telemedicine. We know about how we could utilize simulation models for training. When I was training as a doctor, we didn't have these simulation models. So if you were doing a breech delivery, you'd go and practice on a live baby who could very easily come out dead. That doesn't have to be the situation now. We have these simulation models. So there are a lot of interventions around us. But what's the challenge? We tend not to scale up these innovations. So research can help us to find out how best to scale up these innovations. I also want to emphasize the issue of offering a package of intervention. Sometimes we want to just, provide specific things. But if you're in a household, you don't live your life in those packages. You live your life holistically. So when we think about research, when we think about what we need to do, we need to promote interventions that are multifaceted, interventions that are integrated, so that we can address the different aspects of the newborn's life that we need to address. But we also need to contextualize these things that we do. Henry mentioned that local problems need local solutions. So as we think about using research, we need to use those research and innovations that we think or we know are cost effective. We need to contextualize them. And I want to emphasize 3 areas. We need to think more about how we deliver the different services. If we think about making preterm services, services for preterm babies available,
you're not going to succeed if you're using the same model to deliver preterm services to an urban, rural woman who has to work daily to have an income, like you're going to use to deliver services to an upscale corporate woman who can go to Nakasero Hospital, or to the wife of a nomadic herdsman somewhere in the middle of Karamoja. Sometimes we use service delivery models that are like one size fits all. We need to be able to contextualize these models to the different communities and settings where we are. We also need to think more about who am I targeting? Whom do I need to be focusing on? Who are the newborns who are dying? Who are those who are being born as preterms? Who are those who are getting birth as asphyxia? Where are the hotspots for these different mortalities? We can do research that help us identify that. And then how can we actually target some of these particular vulnerable groups or locations where we want to focus? You can use things like vouchers to help you target those groups. You can use the example Badara, like we've just been hearing about, to follow up those newborns who used not to go to the facility. So we need to contextualize and ensure that we provide those services where they are needed. But sometimes we find that we do not have the solutions and the innovations that we need. And so we need to be thinking where the areas where we don't have solutions. We know that sepsis is one of the common causes of newborn mortality. Do we have the diagnostics that can help us be able to diagnose sepsis at the community level? What can we do to support the development of these diagnostics? We also need to do research that is going to promote data-driven decision-making. We are talking about community health information systems. How can we do research that can help us provide information that a sub-county chief can be able to use? That a sub-county chief can be able to say that we lost 30 newborns last year. We lost 40 the previous year. We want to lose 20 next year. No, not that we want to lose, but we want to make sure we reduce that number. What do we need to do? Can we do research that can provide such information? From the examples we've had, we've seen that we need communities at the center of these systems. We need districts actually taking the initiative to organize these services. For them to be able to do that, they need this kind of data. We also need to embrace more of predictive analytics. Can we predict that this mother is likely to have a preterm birth? Who are the mothers who end up with preterm births? Can we identify them during antenatal care so that we focus more on them? When a newborn is born, can we identify those who are likely to have complications? Can we focus on them, give them the information, follow them up, make sure they come back to the facility, or we go to the community to follow them up? As I draw to the close, the issue of funding this research, a lot of the research that we do in academia is funded externally and meets the interests of those who put out these calls. So we need to also fund our own local research. We need to own this research. We need to have a research agenda. When we talk about newborn health and trying to reduce this, where do we want to focus our research efforts? I want to appreciate the government. The government is currently giving money to Makerere under the Research and Innovations Fund. As Ministry of Health, do we go to Makerere and we say, government is giving you this money, this is what we are struggling with, we want you to do research on this? Or do we just allow that money to be used for different things? So we need to own the research that we do, we need to fund it, we need to make sure that we utilize it so that we scale up all these good models that we've been hearing about from this panel and out there. Lastly is the issue of critical partnerships and collaborations. Research can also help us to identify these critical partnerships and collaborations. At the national level, with development partners, we need those partnerships that are going to help us put in place policies that are going to support these efforts towards reducing newborn death. We also need partners who are going to allocate resources towards that. Grace said we are currently writing an investment case for helping sick and small newborns. That's an investment case that needs to be funded, but who are the partners we need to go to? When you do social network analysis, that's a branch of research that you can be able to do that can help you identify some of these partners. But what about a district and community level? Who are the people we need to be partnering with? Who are the people we need to work with, to reduce teenage pregnancy, to make sure that the facilities are providing quality care, to make sure that the district, the sub-county is allocating resources the way they should. Who are the people we need to be working with in the households, and how should we be working with them? Research can help us to be able to do that more effectively. How about the local resources? When we talk about community health systems, I said we are thinking about integrating services with the resources that we have. How are we using the locally existing structures that we have? In our communities, we have circles. We did some research where people were able to use these circles to save money that the mother could be able to use to transport herself or transport her baby to the facility. These circles can provide a social network that can be able to support mothers who are going through a difficult time. These circles can provide a network that can support mothers who are doing KMC. How are we using these circles? How are we using the borders to help us improve transport? Lastly, social accountability. We did research around community scorecards, and we're able to see that you can use community scorecards to hold households accountable. Should a man simply have 3, 4, 5 wives and give back to 45, 20 children whom he cannot care for? Should that woman have 10 children? How can we engage households to make sure that they're also responsible? They're ensuring that this pregnant woman is going to be able to give back in a facility, that newborn will be able to be born safe. How can we hold the health facilities accountable? We found the community scorecards could be able to help us do that. How can we hold the leaders accountable to make sure that they're allocating resources? So if you think about research and you think about innovations, we can be able to link research and service delivery. And I want to conclude by saying we need to promote research that is multifaceted, and we need to complement that with political and community advocacy that is going to ensure that we have optimal data-driven resource allocation at the national level, at the subnational level, but also at the household level to enable us to be able to address the challenges and the problems that cause us to have this high newborn mortality that we've been talking about.
What a wonderful way, what a nice way to wrap it up. Thank you so much, Dr. Elizabeth. I will not be able to repeat what you have said in the interest of time, but you have crowned it all so well. Thank you. MC, I just want to ask for 2 questions from the audience. Just 2 questions, and then if you have any other burning questions to any of the panelists, you can engage. We are still here together outside of this. So any 2 burning questions from the audience from what you have heard that you would want to fire at any one of them? Henry is laughing.
Thank you so much. My question goes to Mr. Leku Henry. You mentioned that one of the achievements that have reduced teenage pregnancies is the increase in the contraceptive use among teenage girls. But I'd like to ask, have you considered the fact that a lot of the pregnancies are defilement cases, and so have you involved enforcing the law to curb a lot of these development cases?
The second question.
Thank you so much. I appreciate the submissions of the colleagues, and I would want to address this to Dr. Hilary. Having learned that in the past we had community health extension workers almost rolled out throughout the country in 2018, then we had some hiccups, and this was called off, I could say, and now ministry began again the processes of rolling it around the country. Can you tell us what lessons have we learned from what had happened in the past, that maybe those gaps, if addressed, can make us again prevent us backsliding and saying that next time we shall have this activity done? And finally, how can we tease out maternal and child health to come out clearly in the community health agenda? Thank you very much.
Thank you. I asked for only 2 questions in the interest of time. Somebody's putting up their hand. MCQ, thanks. Okay, just I'm using my power to just give that one of the delegates only. Allow me to use my power when you're in the seat. Take advantage, so let it go to one of the delegates, and that will be it. Then we'll respond and we wrap up the session. And as you provide your responses, let's be short. Let's not speak too long because we're already done with our time. Thank you.
Thank you. Good morning. My name is Rogers Mandela. I come from Kanka Division, KCCA. I just had 2 questions to Sister Connect. I think I got the name right. One is how are you able to mobilize, sustain, and facilitate the PhDs that you are working with? I just wanted that to come out. Then 2, I also wanted to see in your presentation something to do with the integration with our child intervention like nutrition. Thank you.
Okay, I think now we can go over to Henry, first then Hillary, and then we'll wind it up with Sister Connie.
Thank you so much. One of the key things that has helped us, as I said earlier, to address AI-related pregnancy was number 1, the community dialogues that we have held with the key stakeholders, but also arising from this community level interactions, we were able to identify the key drivers of teenage pregnancy. We were able to map hotspots, and arising from the presentation of this data to the district committee on adolescent health, which is a multi-sectoral team that has the police, there has also the resident state attorney and the magistrate city and to provide legal guidance, and also the political leaders who are involved in the legislation. The district is able to formulate ordinance on health, ordinance on education, ordinance on production, and ordinance on environmental protection. The police that attends this function and the local council leadership are able to shut down some of these major community level drivers of teenage pregnancy, like the late markets have been regulated, the discourse that are played in every household, in community level, during either introduction ceremonies, during the wedding, that are rampant all over the place, are being regulated, and you don't just do it. So, I will not point therefore at that, but in terms of enforcement therefore, I must say the leadership are implementing this ordinance to the latter. That has paid off. Thank you.
Thank you for that short response to the point. Dr. Hillary, over to you.
Maybe to start with the gaps or the challenge with community health workers. Well, I don't know if it would be a gap, but previously the VHTs were and are probably still mostly operating on a voluntary basis. And so the community health workers, we thought that they would introduce the cover that can be compensated, and they are able to carry out the community health interventions perhaps better. And so the idea is, and probably previously we probably lacked a strategy as well on how to entrench the community health workers, how to bring them on board to be able to fit into the structure at the time. So what this strategy does is that it provides a space for the community health workers, but also backs it up with an entire strategy, so that the community health workers are able to provide support for the VHTs at the village level, and the community health workers can feed in at the parish level, which has not been so well utilized in the community space. That can better anchor the entire community health system to the facilities, to enable that linkage and coordination. Maybe to address the question on
how we can make maternal newborn health salient in the community health strategy.
Yes, sorry. So the strategy, as I mentioned earlier, and as the previous speakers have been mentioning, has come up with a model that is integrated, and that integrated essential community health service package has broken down different community health services for each group by age group, and there is services that are catering to and addressing the maternal health. There are services that are addressing the child health as well as the newborn care, and so under there we think that maternal child health can leverage that, but while looking at the broader sense of the community that interacts with the newborn mothers.
Thank you. And lastly, Sister Connie, how we sustain the VHDs in just 1 or 2 minutes max.
We don't work alone as H2H to mobilize the community for community sensitization meetings. We work with the DHE, the district health educators of the districts where we serve, and the health assistants, plus the local leaders of those areas where we go for the meetings. Those people, our VHTs, they also mobilize, so people attend in great numbers. And to sustain the VHTs, we don't give them salary, they are volunteers, and we only give them incentives. We give them bicycles for transport, and we give them T-shirts for identification in the community. We give them raincoats, gumboots, and umbrellas to use, and those are the only things we give them, but we don't pay them.
Thank you so much. Join me to applaud the team. Thank you so much, David. Can you please have your seat? And I hand over to the MC. Thank you for this opportunity. Over to you.
Ladies and gentlemen, a round of applause to our very powerful chair for this session. Grace, you've done an amazing thing. Thank you very much indeed. And another round of applause to the panelists. I think that has been very, very powerful. Very, very powerful. And without any further ado, ladies and gentlemen, allow me recognizing our midst, Honorable Josephine Bebona. Now, important to note, Honorable Josephine is a midwife. So I expect all the midwives in this room to say something about Honorable Josephine Bebona. Thank you. Not only that, but Honorable Josephine, she's a woman member of Parliament of Bondi Bujo, Important to note, she is a member of the Health Committee of Parliament, and very, very importantly, she's the chair of the Parliamentary Committee for Safe Motherhood. A round of applause for her. Excellent. At this juncture, I want us to throw 30 minutes into our break tea. Our next session is going to begin at exactly 11:30. Our tea is down, so let's stand slowly as we walk through the stores, we walk through the poster presentations, we go quickly, grab a bite, and come back so that by 30 minutes past 11, we are starting another very momentous session. I thank you all.
Has been invited by the governments of Malawi, Sierra Leone, Uganda, and Zambia to address their health worker shortage. Partnering with universities, schools, hospitals, and clinics, we focus on educating the next generation of doctors, nurses, and midwives, strengthening care quality, and improving health outcomes for millions across the region.
Has trained more than 42,000 health workers who are in service to over 76 million people in Sub-Saharan Africa.
Our work isn't theoretical. We are on the ground, in classrooms, clinics, and communities, building the health workforce of the future, one country at a time, one community at a time, one person at a time. In the classroom, in partnership with Makerere University and Mulago Hospital, Seed Global Health trains emergency medicine doctors because in a country of 50 million people, there are currently just 14.
We realize that there are so many cases of patients who die just because there are no people who are skilled to handle those emergent cases.
By focusing on academic excellence and hands-on skills, we are building a resilient health workforce in a country in critical need of their expertise.
The 12 week gives a full mirror image of the heart. We have done our IELTS training through Seed Global Health, and now I have come back to the university to train others and create other specialists. I'm really grateful for what Seed is doing here because it's bringing many people on board, equipping our field with many personnel who are skilled to do procedures that are really life-saving. But you will never forget this, even when you become specialists.
350 kilometers from Kampala, at Lira Regional Referral Hospital, midwives trained with Seed support at the bachelor's and master's levels are conducting rounds in the maternity ward, serving a hospital that supports over 2 million people in the region.
The mothers who come here for delivery, some of them come from 100 kilometers. This hospital serves more than 3,000 in a month.
Here, demand is constant, and the need for highly trained midwives is critical.
I'm proud to say I'm a pioneer bachelor midwives. Seed Global came in to support us when I was a student. The partnership with Seed Global Health came at a very right time. We needed to have the capacity to train our students. Seed Global Health has not only touched us as an institution, but has also touched the community around, supporting community outreaches where we reach out to the community directly and provide services. And you're seeing our mothers are smiling, they are happy because they are getting quality service.
After lunch, a team from Lira University's Community Midwife Program arrives at Obutorelo Village, home to more than 30,000 people.
We are going to check on you and we are going to check on the baby.
Women who deliver at home, one, either they die during the delivery or the children die. The delivery die. The sort of need for the midwife to come on the ground to the community.
News of their arrival spreads, and over a dozen mothers, some expecting, others with newborns or small children, gather to learn from the Master of Midwifery student about family planning, nutrition, and other vital topics.
I want to talk to you about the importance of breastfeeding.
Engaging with the community and understanding patients on a practical level is a mandatory step for his graduation.
Taking out that chance to give that correct information, utilize it and make someone better. That's the passion I get for it.
To see your student do very well and have that sense of pride.
As the afternoon sun lowers, Dr. Joseph Emeron, Director of Katapi General Hospital, is training one of the first emergency response teams in this part of the country.
I used to get a lot of reports about how poor emergency services work, but currently that story is changing, and basically because we created a team that can rapidly respond to those emergencies.
Educated with safe support, Dr. Emeron, one of Uganda's first emergency medicine doctors, has returned to his home village, fulfilling a childhood dream of becoming a doctor.
My hope for this hospital for the next 10 years is that we are delivering better emergency care for the community. Also, we want to be a role model in the country where other people can come and learn.
This is one of our new ambulances in order to go to deeper areas. This ambulance has saved a lot of lives.
His efforts have caught government attention with consideration to promote his hospital to regional referral status, a testament to his leadership and critical role of developing skilled health workers. After all, how can we hope to achieve universal health coverage, combat the next pandemic, or address the health impacts of climate change without them?
Our goal as a country is to build a strong health workforce that is responsive. We know that all the other pillars of the health system are going to rotate on how good the human resources for health are.
We may have the hospitals, the vaccines, but without the health workers, you cannot deliver. SID comes in a very critical role because we train a highly skilled health worker. Really, our mission is to advance the health workforce as a global priority.
Similar days unfold across the region, and whether in Malawi, Sierra Leone, Zambia, or Uganda, they're collectively proving the power of our model. The training skilled health workers strengthens quality of care and improves health outcomes for millions across the globe. Together, we are building the health workforce of the future, one health worker at a time, because health workers save lives.
Health workers save lives. Health workers save lives. Health workers save lives. Health workers save lives.
Good morning, good afternoon, good evening, everyone. From wherever you're watching us, my name is Enid Kawala, a public health social scientist, senior graduate fellow at Maternal University, and a PhD student at the Clinical Criminology Unit at Maternal University. I'm here to bring you some of the things that we realized or we found at the TBA sites. As I was trying to conduct a study on traditional birth attendants in Eastern Uganda, I delved into the practices, management, and what they use in management of these obstetric complications within the community. And I happened to interact with the traditional birth attendants, the community, but even mothers that have really had their deliveries or even attended any or gotten any services from any of these traditional birth attendants. So while I was moving around, I met this mother who had already sought care from a TBA, and here we find her being examined by the TBA, and she was almost due, almost ready to give birth. So she's there, and the TBA was quite kindly trying to palpate her and examine her. So I moved to another TBA who was called the champion of TBAs. And she is here trying to show us some of the traditional medicines that she uses in management of these obstetric complications, and that is some of the medicines in her jerrycan there, though with the ID testing. She showed us a delivery bed there, and there's another delivery bed there that we found at one of the TBA sites. One of the TBAs showed us a medicine trolley, and that is it. And then there's another medicine trolley there. You can see stethoscope and other traditional herbs there. So we found another TBA. They are seated with other mothers during antenatal, and took us through some of the traditional herbal medicines she uses in management of these complications, like what she uses for obstructive labor, augmentation of labor, and she showed us some of the bottles that she uses to back this medicine. Those are other trolleys that have some of the modern medicines that they use in management of these complications. Here is the TBA site, and this is one of the TBAs who is taken to be like the Kawentu of TBAs in Mayuke. So you see she has two houses, or three houses there, but one is a delivery room. That is her placenta pit where it was captured, and we found some fresh placenta there. But you could have seen after a lot of questions. So after showing us that, I had to come there to be examined, and she told me I was a 12 weeks pregnant, which was not right. So there's another TBA there trying to show us how she uses the barrier method to dispose of the placentas. Then we found some other TBAs with some mothers, like that one was taking some traditional herbs to prepare her for delivery, and that is what they called the natural oxytocin. They also took us through some of the delivery rooms, and we saw something that they use, especially in polyclamping. You can see a razor blade there. We saw some injections there, and then we also saw a jerrycan that was used by one of the TPA to keep her paraffin, and told us this paraffin is mixed with sugar to help in management of preeclampsia. So that is another herbal medicine that they use during pregnancy to avoid vomiting, and that is what we call a mungwa locally. It has multiple uses, especially stopping vomiting or nausea, but there are also other mungwa which are used in other conditions. Then those are other traditional herbs that we got. Those are some of the mothers we found who had come for delivery. Then we found some there who had come for antenatal. And they also showed us some of the other herbs that they use. That is in Fodo, which had multiple uses as explained by Harvey. That is how they manage their waste. And you can see that some of the waste was poorly disposed of. And we found this, though she lied to us that they don't use that medicine, but there was evidence that she uses that medicine. So I arrived at this TBA site, and I told her to assume I was a patient, and let her try to examine me and speak to me the way, tell us how she takes care of a mother. So I lied down there. She had to take me through how she manages mothers when they come. That is her delivery point. She puts that white cavera. She told me to put my lesu. I removed my lesu there, that blue. And I told her to, try to examine me. That time I had, of course, I had a bigger baby because I just from eating sugar canes in the community with mangoes. So she also assumed I was pregnant, but I was not pregnant. So there I turned around, and then she teaches me, she tells me how she examines the mother, when the child, when you've given birth, how you put the baby. And that is how she positions her baby, and doing the skin-to-skin thing, and trying to demonstrate how it is done. Then you'll see her trying to show me how she will help me to touch my baby, and then to make sure that my baby doesn't fall off. But if you realize in the corner there is a stool with a glass of water. And that glass of water is ever there for in case any mother comes when she's ready to give birth. In case that mother wants anything to drink, she provides it, unlike in other facilities. So now that I've delivered my baby, she's checking for whether there is any problem, She's trying to check if there is anything, you see. the stomach was full of juice. So we also visited the male TBA, and this TBA was also tried to examine, but check the environment in which the bed is, check the nature of the mattress, check everything was just dirty around. I remember I had to leave when my skirt was dirty, but that is what they do, okay? So he says that he's a TBA and his wife is also a TBA, and they survived, okay, by doing TBA work as them. So him and the wife, that is their work, and they've lived as TBA. He's the one who trained the wife, and now they become TBAs. And they have so many clients. So there's that TBA who's also trying to show us some of the medicines that they use in the community for mothers. If you want to remove, to get, she called it in that area. So for instance, now like there's a common condition called in the community. Then is that it's like something like pseudosciences or post-date. Sorry, pseudosciences is something like that. Okay? You know that you're pregnant, but when you're not pregnant. Then there are also those conditions whereby a mother is pregnant, but HCG shows that you're not pregnant. Those are the medicines that she uses. Then when you look at those people who have had pregnancies that are post-date, so those are some of the conditions, the medicines that she uses. You are pregnant up to 9-10 months, but you're not giving birth. Then she gives you that. Then she also showed us some other medicines that she uses, especially if you want to change the sex of the baby, you can use that. If you want to conceive and to never conceive, maybe you want you're yearning for a baby, but you're not in position to, you can't get it or you failed to get it, she has the medication there. Then we also had other medications for other complications, like obstructed labor, preeclampsia, placenta previa, and the rest. So those are some of the things she uses to pack these medicines after, like especially those that we are made to drink. Okay? Then it comes, that is her delivery bed, you can see. And in that delivery bed, you see that is the form, those are the papers that she uses to, to write in case there is anything, but she didn't show us. So I laid down to help me and examine me. But then I realized that up there, she had a drip stand, and you can see normal saline up there with injection. So I was wondering who put this normal saline. However, she told us she has a referral nurse who keeps checking on her to see if there is if there is anyone who needs to be cannulated, if there is anyone who needs IVs. So she runs the IVs after that nurse helping her to cannulate. So she examined me and told me that my uterus was just ready to receive a child, okay? Which is different from the first TBA who told me that I was 12 weeks pregnant. So that is the environment in which she delivers her patients or her mothers, and those are some of the things that we really noticed at the TBA sites. So these are some of the cases of conditions like PPH, which they tried to manage, and then you can see these mothers who are being examined, but in examination she's not a very first person to use a stick. There's another who told us that she also uses a stick, which is marked, okay, from 1 centimeter, 2 centimeters, and the like. So she starts sitting into your vagina to check what, whether you have, how many centimeters you have at that point. So now we also noticed other things like how they manage mothers with asphyxia, children who are babies who are asphyxiated, and there's another way they do their neonatal resuscitation, like the way they put the tail of the polyp into a baby's anus and then start growing it. And then there are these other things whereby they told us, if you really have if you're not getting contractions, they put you on a border until that border to pass through the bumpy road. Until when you feel like, yes, you get the contractions, then they bring you back. So there's a lot of, there are a lot of things that are being done in these TBA sites. And thank you for coming for this wonderful Safe Motherhood Conference. I'll be sharing with you what the lived experiences of mothers are, those who have sought care from TBS in one of the districts where we are doing our studies. And you will see that mothers have really appreciated this TBS. However, they have caused more havoc, okay? Because now we have to go into the nitty-gritties of their MPDSR process. How do they do this maternal death response and surveillance? Especially one of the TBS who's taken as a national referral TBA, who had lost like 3 to 4 mothers in just 1 week. What are the challenges that these mothers are really getting in the community that are fostering or prompting them to visit the TBS? All those details we shall share them in our subsequent engagements. So that is all briefly about the TBS studies that we are conducting in the country. And we shall share all this and hope to come up maybe with cost-effective interventions and policy programs that can help us to solve this problem of the TBS and the maternal and newborn mortality rates that we have in the region.
Constitutionally, the government of Uganda has an obligation to provide basic health services to its people. In line with this obligation, in 2018, the government established the Mulango Specialized Women and Neonatal Hospital. The 450-bed facility provides highly specialized reproductive and neonatal treatment and healthcare services. The 9-story, fully furnished, state-of-the-art facility, secured at the cost of 91.5 billion shillings, availed by the government of Uganda and the Islamic Development Bank, IDB, is equipped with highly specialized healthcare in maternal fetal medicine, gynecological oncology, reproductive health, benign gynecology, and neonatology, which includes surgical and medical. Other areas include diagnostics like radiology, laboratory and pathology, plus medical support services like pharmacy and physiotherapy, among others, as enlisted within the hospital's mission of providing and promoting access to quality specialized reproductive and neonatal health care with cutting-edge research and advanced training.
Yes, so we need a participant or delegate back into a room.
Offered at a subsidized fee based on the principle of post-recovery in order
Those who are finishing their keys, we can get back into the room for the next session, please.
NICU, for the newborn babies who need intensive medical care. The unit has advanced technology and trained healthcare professionals to give special care for the tiniest patients, including babies who need specialized nursing care. The unit has given a chance to babies born so small, as low as 300 grams to live. The hospital runs a specialized daily screening program for cervical cancer, which is very common among HIV-positive mothers. Other areas of specialized care include reproductive medicine, where infertility and reproductive challenges are addressed at the Diagnostic Center for Men Fertility Evaluation. This laboratory offers couples with reproductive challenges full diagnostic evaluation of male infertility and intrauterine insemination. The hospital has a powerful diagnostics division with experts in endoscopy, laboratory medicine, pathology, and radiology who use the high-tech equipment and innovative technologies. Behind tech CT scan machines is diagnosis. The services offered are cheaper and give quick results. Physiotherapy is important in women's health during pregnancy and after childbirth. The hospital has a mandate to train medical students in obstetrics and gynecology, pediatrics, radiology, and anesthesia. The hospital supports government policy of developing the health sector and reduces maternal and neonatal mortality, thus improving healthcare and service delivery.
Yes, we are participants back in your room, please. Finish taking your teeth. If you still have, you can actually bring in your teeth and take it within here. Time is very important. Please come in, please. Can have a walk with tea.
Maternal and perinatal death surveillance and response is a quality improvement intervention. There is a global guidance that every maternal death that happens, that occurs at different levels of care should be notified, should be reviewed, and actions should be identified. An action plan should be made to prevent the next step.
So the MCHL activity has been collaborating with the ministry and other stakeholders to improve the maternal perinatal death surveillance and response system. Right from the start, we collaborated with the ministry of counterparts to ensure that they are able to meet and review maternal perinatal deaths. So they were initiated what we call the community of practice. The national community of practice is a group of stakeholders who come together every week.
Hello, my name is Claire Andisiwe. I'm a neonatal nurse working in neonatal intensive care unit, also known as NICU, at Mulago Specialist Women and Neonatal Hospital. Mulago Specialist Women and Neonatal Hospital has one NICU, which is located on the 3rd floor. NICU is a place where we admit sick newborn babies who need further management and specialized care. Well, as you enter into the NICU, everyone is advised to remove street shoes at the entrance and put on clean indoor shoes, which are provided. After that, every visitor entering NICU is supposed to wash hands with soap and water. This is very important and is continuously observed to control infections in the NICU. In NICU 1, we admit babies who are born from outside this hospital and are referred here for further management. They usually have different cases, those with neonatal sepsis and also neonatal jaundice that need laboratory treatment. In NICU 2, we admit sick and babies who are born from this hospital. Some are very sick and need mechanical ventilation to support breathing and need postmortem. Others are admitted for observation in case they do not score well. In NICU 4, that's where we admit extreme preterm babies and preterm babies. These babies are cared for in servo-controlled incubators or under radiant warmers if there are so many procedures being done on the baby. During admission to the NICU 4, babies
Dear participants, let's come in to the next session, please. Time. Very important.
And one mission to the support given to this sector and the leaderships given to this sector to see that this sector was accredited as a baby-friendly facility. We do have education to mothers about the importance of breastfeeding, the dangers of mixed feeding, and the dangers of formulas. Health education is done on a daily basis.
Thank you so much. Thank you, Coach. I want to welcome you back from that break. I believe it was worth it. We just want to keep within our time because we have a lot to cover and limited time. But as for now, I want to just pick up from where we stopped and transition into our second presentation for the morning. We have a lot. We have amazing case studies to launch and reports as well to launch. We'll be looking at the newborn care standards, newborn investment care, implementation strategy for child and newborn, and USA MCHN activity legacy documents. So we have a lot on our schedule, but I'm not going to be the one handling that. He's so far tested his voice and his passion. He is part of the committee that is putting this all together, and he's a technical officer, Motherhood at Ministry of Health. Please, those of you who are present, join me in a big hand clap as we welcome Dr. Jeffrey Barbara.
Good morning once again, ladies and gentlemen. I'm very excited to be a chair for this very powerful session that is going to discuss a very critical issue in our midst. And we will be looking at incredible work that has been done in Kampala metropolitan area with support, incredible support from USAID, initiation activity. I think it's very important for us to applaud USAID initiation activity for the great work that they have done over the past 5 years. And with support from other stakeholders and partners. Now, if you have a phone and you see that your neighbor is not yet in here, just pull out a phone, give them a ring, because this is not a session any person should miss, so that they are here in time. They just do that quickly, just call your neighbor so that they're here with us and we start the ball rolling. So, for those who have the program right before you, we will be listening to a presentation on strengthening urban health systems and governance for improved outcomes for women and children. And that will be presented by Dr. Nathan Tumwesije. After his presentation, we shall get a presentation on collaborating to implement RAMHA strategies and guidelines for high-impact interventions at national and subnational level. And that will be presented by none other than Ms. Agnes Namagenda. And then we will share with you a video story of what we're talking about. We shall be attaching some video to the audio. And then thereafter, we shall delve into the Kampala data-driven approach to enhancing urban RAMHA and nutrition services. Ever since we started these powerful conversations at this 4th National Sex Motherhood Conference, one of the themes that has come out very, very strongly is our data-driven approach. And I really want us to really pay critical attention on the presentation that Dr. Richard will make on the Kampala data-driven approaches to enhance urban RAMHA and nutrition services. And it's very important to note that for the time USAID MCHN has been with us, there are a number of partners and stakeholders that they have worked with. And this is a time that we shall also recognize those incredible people that have supported the work for USAID MCHN activities. And we shall close with some very powerful remarks from our chief guest of this session, from remarks from the representative from USAID, Office Director for Health and HIV, USAID Mission, and then we shall get remarks from our chief guest for this session, who is none other than the chair for the Parliamentary Commission on Safe Motherhood, who is a midwife just like us. So, and then we shall launch the incredible documents that we have, which are targeting newborn. And as you remember yesterday, we want to see that our efforts on newborn care improve quite significantly. Now, it's important for me to note that the documents that we're going to launch today, they're very critical. And we shall have 2 launches for these documents. So we shall undertake the first launch in this session today, and then we shall undertake another launch during the closeout ceremony tomorrow during the National Sex Motherhood Awards dinner, where we shall have both the Permanent Secretary and the DG with us. But today, we want you to appreciate what the contents of these documents is, and to ensure that when you go back with them, you put them to very good use. Now, without any further ado, allow me to invite our very first speaker for this session, who's going to share with us strengthening urban health systems and governance for improved outcomes for women and children, and that's none other than Dr. Nathan Tumwesije, the Chief of Party, USAID Extension Activity. Dr. Nathan, the floor is yours. Good morning, colleagues, ladies and gentlemen. I will start on the existing protocol to move forward. The next couple of minutes, 7 to 10, I'll share the few but very critical things we have been working with together
with various government actors, our host government, Ministry of Health, and other government structures to pull momentum and achieve milestones in improving outcomes for the woman and child in Uganda, but also particularly in Kampala. Next slide. Should I move in myself? Yeah, thank you. The USIP Maternal Child Health and Nutrition activity is a 5-year project. It actually ends at the end of December this year, so we have exactly 2 months remaining to the end. And so we've been in this space for almost 5 years. The aim of this project, which we call activity in the USIP speak, is to improve maternal newborn child health and nutrition outcomes in the country through various initiatives, and these are the project objectives actually. Rollout of key maternal newborn child health and nutrition strategies, guidelines, tools, training, packages, and priority high impact interventions at national level as well as at subnational level, district, healthcare facility, and community level. Another arm is strengthen, and we've been working on this, we've been working hand in glove with our government counterparts to strengthen coordination and linkages within and between various sectors and their structures, including technical working groups, departments, divisions, etc. We've worked hard at increasing use of data for planning, decision making, and learning at all levels, including ensuring that this is really mainstream and is institutionalized, and we'll be looking at some of the examples around this area. In Kampala in particular, so what I've described above is at national level. Minister of Health and Office of the Prime Minister and other ministries, departments and agencies that work with these 2 ministries. But in Kampala, capital city, the smaller Kampala that excludes Wakiso and Mukono, we've been working with the various actors in this space, in the public and private sectors, to strengthen delivery of services. Maternal newborn, child health, nutrition, postpartum family planning, and of course, general health systems cross-cutting areas. We have also had an opportunity to work in the area of global health security, contribute to the Ebola response, as well as contribute to the COVID-19 response. The program areas, I've already touched on them: reproductive, maternal newborn, child health, family planning. And family planning, we've been focusing mostly on postpartum family planning, immediate postpartum, 48 hours, 6 weeks. Gender, youth, and social inclusion as a cross-cutting area, WASH, health system strengthening, I talked about global health security. Okay, I don't see a signal here. I don't want to read here. I want to be guided. It has come through. So, as we wait for this to come through, we've walked the journey along with the Ministry of Health, and I'm going to begin with appreciation. And this is a bit unconventional, this should be at the end, but I want to begin with that. My system is not working, so if you can get me my laptop.
Let me work from here. So, appreciation. First, USID. And I'm beginning with USID because USID, first of all, has provided us with the funding to do this work, but also the design of this project was unique. One, it provided us with two arms at national level, but at the same time at site level, district and site level in Kampala. That provided a unique opportunity whereby we would experiment initiatives we are designing together with the ministry at the national level, right in Kampala, and would quickly learn from implementation and go back and tweak the policies and guidelines at the national level. So that kind of design provided these opportunities, and it's unique, and so we do appreciate USID that did this. The second issue is that USID provided us with ongoing technical support. We walked the journey together with USID every day, every week, every month. And that helped us a lot because we were able to quickly demonstrate where we are meeting challenges and difficulties, and we are given room to quickly adapt and change direction to be appropriately responsive to the needs of the host government and the respective structures within Kampala at facility as well as community level. So we do appreciate USID's substantial involvement in this work. A big hand for that. Ministry of Health. Now we came a long journey with the Ministry of Health. We started this activity in 2020, and as soon as USID introduced us to the government structure, we went into COVID-19 lockdown. But the ministry quickly adapted. We did the bulk of the work in the first 2 years virtually. I remember very well with our USID colleagues the entry meeting with the Office of the Prime Minister. We did it virtually. The entry meeting with KCCA, we did it virtually. And you can imagine how difficult that was. But the ministry was able to stand with us through the journey, and we provided the logistics to make sure that that happened. The ministry also provided room for us to be adaptive and to do business in an unusual way, in unusual ways. And because of that, we were able to literally rock the boat most of the time. We pushed ourselves beyond boundaries. We could have caused discomfort here and there, but it was all in the interest of the results to have the woman and child be served. But we do appreciate the ministry's commitment. This thing has gone back. Going back to the previous one, it doesn't come through. Oh, here it does. Now, top leadership involvement. I wish the Permanent Secretary was here. As we dived into making sure that we change the way of doing business, at one point, we spent 5 months having the Permanent Secretary of the Ministry of Health doing with us weekly Monday morning ward rounds in one of the hospitals in this city to make sure that we actually cause change. That is a bit unusual. Clinical ward rounds with us together with the hospital teams. Top management would be there. Permanent Secretary, Director General, Commissioners. Every Monday, 7 a.m., we would start our ward rounds by reviewing the data of the previous week. Deliveries, deaths, those who have survived,
events. And we would do that on a weekly basis for 5 months. And that caused a shift. We do appreciate the top involvement of the Ministry of Health. So involvement of top leadership. Now, with this approach of doing business unusual and pushing ourselves and everybody beyond the usual boundaries, we are able to move various initiatives. The MPDSR policy was already in existence, and thank God, and we appreciate the Ministry of Health for having put this in place as early as 2017, if I can remember. Now we have to use that policy to actually move to the next step, to functionalize that MPDSR policy. And so we went into a data-driven approach. Fortunately, the ministry had set up the MTRAP system, which had data already mined, scattered there, and we went into making sure that we generate these weekly analytics working with the ministry teams. I want to appreciate the various individuals that we worked with at the Ministry of Health to be able to move this MPDSR agenda. I remember the first presentation we actually made was in April 2020 during lockdown. At that time, there were no movements. We were working remotely, big data, analyze, and try to convene the whole country to actually begin doing this on a weekly basis. I remember I did the presentation myself. This was an opportunity for us to begin working in an unusual way. Initially, we had to buy data, get people's phones and send them data so that they can log into these meetings. And we did that for 2 months. And then we pushed back and let go a bit, dipped a bit, and then picked up. Now that has been mainstream institutionalized, and every participant who logs on, I think last week we had 700 participants, buy their own data. I don't know whether the government gives them the money or they use personal money. I really appreciate, and I know most of you who are here actually participate in that forum, in that platform. Can we give ourselves another round of applause? Because we've been able to bring the whole country together every week without forcing anybody. 7 a.m. people have woken up, and 7:30 the business begins. For me, this is an achievement in terms of mainstreaming institutionalization and sustainability. MCHN activity is ending. This is going to continue. Whether the SID investment is there or not. And for me, this is a major milestone. JP, I want to single out JP, and I want you to stand up for recognition on the crowd. And I'm not going to, sort of call upon many individuals. You can sit down. But it has been rewarding working with JP because he enabled us to push beyond all possible boundaries that we can think about. And that time JP was the student doing obstetrics and gynecology. He hadn't graduated yet. We would hold meetings in women's hospital, in Kawempe, wherever he would be. If Dr. Maganga is here, is Dr. Maganga here? Probably not. Retired commissioner. You know where we came from. So we do really appreciate your involvement. Thank you. The LMNS. I don't know whether you know how LMNS started. It was a conversation between myself and JP. And he gave it a name. And the whole thing was about accountability. How can we have an accountability framework that drives itself? And I shared with him that when we worked in Busoga under Petra,
We used to have monthly breakfast meetings with districts, local government leadership, RDC, LC5, COW, with simple dashboards. How many men circumcised? 3. How many mothers died? 1. So I said, JP, your idea is good, can we move it? So he gave it a name. Then he started asking for support, and I didn't give him the support because LMNS is not a government structure. At that time, it was not a government structure. But we quickly went to the PS and said, you know, we need an instrument because this is going to be a payroll structure, and people are like, what is this? We've never seen it in any government policy. And the PS actually caused that instrument happening. And as you can see, in each region, we are able to pull voices for everybody. The resources are there, meager but there. Resources in terms of humans, time, brains, but also funding at district level, regional referral, etc. And this LMNS is supposed to pull all those so that local solutions actually are designed for local problems. So we really appreciate the milestone around this. And in Kampala, for the urban area, we will quickly move these experiments and lessons, MPDSR, data-driven, weekly, LMNS, accountability, to Kampala. And we've seen how we've been able to move rapidly within Kampala. I'll be talking about more about Kampala later on. So OPM, I haven't talked about OPM, and maybe you may be wondering what we've been doing at OPM. So OPM hosts the Maternal Nutrition Programming Platform, and so we are also in that space, helping OPM to push the various agenda for nutrition-sensitive programming. You know, we have nutrition-specific, nutrition-sensitive programming. Things are only and somebody who are here, they understand this. We have the Ministry of Health spearheads interventions for nutrition-specific interventions. Others are actually spearheaded by other ministries, departments and agencies for the government of Uganda. And so we're helping OPM to advance this agenda. We do appreciate for the work that we are doing with the Sector Nutrition Platform at the Office of the Prime Minister and the various ministries, agencies, and departments that are involved in this agenda. KCCA. We have colleagues here from KCCA. Dr. Wundo, can you stand up? A huge round of applause. So, Dr. Wundo is the Division Medical Officer supervising in our division, representing the Director for Public Health and Environment for KCCA. The teams at the state level as well as the divisions, we do appreciate your leadership. You actually told us a little more about district-led programming. We thought we knew it, where the district is at the forefront of planning, design, implementation, tracking, monitoring, documentation. You showed us the way, and we catalyzed what we desired, both for reproductive maternal newborn child health, but also for COVID-19 vaccination, as well as Ebola response. A round of applause to KCCA. Referral hospitals, and these are few actually, and they can mention them. Kawempe National Referral, Mulago National Referral for actually child health. We've done a lot of work on child health at Mulago National Referral. We have Naguru Regional Referral, those are public. We have public health facilities that are directly governed by KCCA. The large health centers, the smaller health centers that are public. We have community structures. We dived into urban community health. A very, very complex area, and we've done a bit of learning there, and a lot still needs to be done. And Richard will be sharing some of the achievements we've registered. Private sector, very important in Kampala. About 98% of the facilities in the city are actually private. So the bulk of the facilities are private. And believe me, the privates we are talking about are not Nakasero, Case, Clinic, Korolo Hospital. We are also talking about those private healthcare facilities that have one nurse or assistant nurse, located mostly in communities that are under-resourced, underserved, but they actually do a lot of work and they generate a lot of volumes. We do appreciate your openness to actually work with an institution, a project that traditionally would be working with public facilities, and we've registered success and some good results. Round of applause for private actors. And I cannot forget Uganda Healthcare Federation. I don't know whether we have anybody from Uganda Healthcare Federation. Our Sabawati partner who was helping us with entry, convening, advocacy, negotiation with the private sector. Now, out there, though the activity, the project was not directly working with districts beyond Kampala, who are actually working through regional partners and regional referral hospitals to reach all the other districts. And the districts are here. And we talk to you virtually almost every day, every week. So we really appreciate the district teams as well as service delivery teams, not only at facility, but also community level. You are the ones who actually drive the work. For us, we only do the talking. A huge round of appreciation for these teams, the frontline team. Partners. Later on, you will see a list of partners that we've worked with, at least some of them, both development partners as well as implementing partners. As an activity, we have actually worked directly with some of the development partners, including UNICEF, WHO, including ELMA and their partners, etc. And then the various implementing partners, both USIP funded and non-USIP funded. And then finally, the consortium team. Makerere University School of Public Health, Uganda Healthcare Federation, Save the Children in Campus, and some of our small sub-grantees at community level, White Ribbon Alliance, Youth Alive, and Child Foundation Uganda. Those were direct recipients from us at community level. So, now, how do we do this? We apply a systems and strategic partnerships approach, harnessing the power of information and data. And I will not talk more about this because I've already talked about how we are still utilizing data, how we institutionalize this, and it is driving itself at all levels. Even at facility level within Kampala, monthly data reviews are happening, even without our presence, because we have already pulled out. Private sector, having private sector facilities report through the HIS tool. 1 quarter ago, we had moved from 500 private facilities reporting in the HIS to now, I think it's over 1,000. The number is over 1,000 in the HIS 2 accounts. Making that happen. The big hospitals, private hospitals in Kampala have their own reporting systems internally. For them to agree to actually ensure that they add on the HIS 2 or integrate so that the data can go directly to the HIS 2 from their system, it's a hurdle. Approvals will have to be obtained from the proprietor in Nairobi, in India, in where sometimes that will take 8 months. But we made that happen, and we do appreciate the flexibility. Human resource for health. We touched on all aspects of human resource for health strengthening, working together with our counterparts at KCCA. Competences, that's a given, training and mentorship, but we used information and evidence to actually lobby and advocate and engage our colleagues at KCCA to recruit medical officers and aesthetics to address the issue of referrals, emergency CDM sections at health center courts. So at one point we put together a proof of concept for that. We could call it research or something. We recruited 6 medical officers, 4 anesthetic officers, deployed them, tracked, and looked at referrals going from Kiseni, Komamboga, Kawala, Kawembe. Are they reducing? And we demonstrated that actually those unnecessary referrals went down. Then went back to KCCA. Hello, recruit these cadres. And they did recruit them. And we do appreciate the partnership with KCCA around this area. Preceptorships, and then of course community resources, very, very important. Now, when you talk of a community health structure in an urban area, one may think that it isn't there. They are there. They are community resources, they are VHTs, in places they are not there. Sometimes the LOC1 is the VHT, a lot of the times, and maybe his friends. Then there are volunteers in there. So we mapped. We went into communities and really mapped these resources, strengthened them, gave them skills and knowledge, equipped them, and then deployed them. Because they know those parishes and LOC1s and villages better than us. And you can't believe there is a lot of work there that needs to be done. The urban under-resourced communities and populations, I don't like calling them urban poor. No, they are not poor, they are under-resourced. They are out there yearning for these services. And through mapping and strengthening these community structures, we are able to reach them. Funding. Because of information, and we started with Kawembe National Referral Hospital, the team that is here, thank you, and we do appreciate for allowing us to dive into your data and actually show you what the hospital is dealing with or was dealing with at that time, and that continues to happen. And when that data reached the Minister of Health, because the PS was part of the weekly, deep dive meetings, Kawembe Hospital was able to have their allocation for drugs and commodities increased 3 times. Just data. So the issue of chronic stockouts for everything started becoming less and less of a problem. We also worked with our colleagues at KCCA to do public finance management. At one point we had a couple of, we could call them auditors, or you can call them that, who went in and helped with some of the backlogs that were existing and therefore blocking KCCA from receiving more funding from Gavi, UNICEF, and other donors. And so those tabs were reopened, and KCCA started getting funds going to them because of those initiatives. I think Jerry talks about the corporate society for safe motherhood. He's the one who coined that word. Corporate society for safe motherhood. So I remember we invited the corporate directors and then this Kawembe, and we did ward rounds with them. They reached the newborn care unit and some of them cried. And then they started giving us things to work with. Now that's mobilizing resources from the non-health private sector. And that is going on, still going on. It is driving itself right now. Yesterday I had on radio Stanley talking about their initiative to raise more funds without anybody pushing them to do this. So the space is fertile, not only for Kampala, but for the whole country. The space is fertile for leveraging funds from the non-health private sector to be able to move forward. I talked about community structures, so I will not talk about that again. Commodities. Now, this is a very, very difficult area. And over the past couple of months, I think over the past 3 years, we've had a handle at this. Within the KCA area, I already talked about Kawempe, ordering, reporting, and management of stocks. We do monthly commodities data reviews and real-time corrective actions. And in the house, we have every actor within the city. Be it IPs, all the IPs are in the room. National Medical Stores is in the room. JMS is in the room. And we look for solutions on a monthly basis after circulating dashboards showing what is happening around this area. And we've shifted positively. Routine service delivery processes speaks for itself. QI. When we started doing the weekly MPDSR meetings, the feedback from the districts, our midwives, was, you keep on talking about QI. Why doesn't the ministry come here and show us how to do QI? And people have been doing QI, but only in HIV and TB, but not in MCH. Now, at national level, we are able to put together, develop, disseminate the required tools to be able to advance the QI agenda for maternal, newborn, child health, as well as nutrition services, and we cascaded this to Kampala. QI collaboratives, Richard will be sharing some examples of successful QI collaboratives around MCH. The IDEA approach at community level, this uses a gender lens to actually do improvements at that level. This is a WIHA is an American organization. This is a WIHA model. So we've been able to advance that within the city. Quick learning and adaptation using data. Host-led programming, I talked about that. How the government, Ministry of Health, as well as Kampala, the private sector owners, the medical bureaus that govern the faith-based facilities are at the forefront of whatever we've been helping them to actually implement. Partnerships. This has brought in complementarity, and the partners are many within the city, and I have listed there. Some of them are development partners, whereas others are implementing partners. I talked about that, and Richard will talk about this later on in more detail, so I won't be spending time here. But the point here is data driving everything. Very, very important. Now, the thing disappeared again. Yeah. Yeah. So, now this is the last slide, by the way. We have taken a lot of time. But you know the passion, huh? The passion. Yeah. So, my colleagues are going to share with us a summary of key outputs and achievements that we registered working together with the Minister of Health and Office of the Prime Minister. They are going to outline. And some of those are some of the guidelines that are going to be launched later today and tomorrow. Then that's Agnes will share that, so you call upon her. Richard, he will introduce himself. He will dive a little more into Kampala and show you some of these things that I've been talking about. But as we are doing these things and providing technical assistance, we are mindful of the fact that we need to harvest knowledge, new knowledge that may be marked, so that we put it on paper and we share it with everybody. What really works and how do you do it. Some of the areas of what works, we know because it is in the guidelines which the experts put together. And Earlier, I didn't talk about nursemaid, but it was listed in my slides. Nursemaid. JP, what does nursemaid mean? National Safe Motherhood Experts Committee. That term was also coined by JP. And we put together that. I don't know where, I think JP shouldn't have been a doctor, he should have been a literature student. So that's a structure that was informal at that time. And if there are any members of NASMEC in this room, they are there. Dr. Nonge, Professor Annette, can you stand up for recognition? And I will say why we are recognizing you, NASMEC. Thank you, thank you. Way back in 2020, he coined that word. And we said, okay, we have brains in this country. How can we get these brains to get together and actually give us all these guidance, tools, strategies, frameworks, do them without us paying them? And I don't feel bad. That we didn't say that we are not going to pay you, but that we knew. So these NASMEC members had task and finish teams. They still have. Anything that we feel needs to be done, can we update the Syrian section protocol? I'm giving you an example, I'm not a gynecologist. The team says we are going to do it, give us 2 weeks, and they agree who is going to do what, who is going to review what, and they will do it. So these guidelines, protocols, training packages that Agnes is going to show on one slide have largely been done by NASMEC. Without us paying them. You can't imagine. This is a passionate group that has done wonders so far. And I wish I could be made a permanent member of NASMEC, even after retiring. I remember in 2020 we revolved the PPH framework, the first one. During lockdown, each one of us would work from their house. Right when they lifted the lockdown, we actually disseminated it. You remember? At Africana. PS launched it. That framework was done under the hardest of circumstances. And following that, many other frameworks have been done. And they continue to be done. Then the service provider at frontline level to be able to provide a service, save a life, give a life. So, appreciation. Now, some of the new knowledge, it may not be new knowledge, but knowledge collected, put in one place, is available in some of the legacy knowledge documents for the project. And we put those together. Richard has some QR codes, you can use your phone to look at it, but we are going to upload them on the ministry portal. There are still about 3 or 4 which are being worked on by the technical people, and they will all be available on the portal, which is written there. These are the new guidelines that we talked about, whether they are maternal, newborn, child health, immunization, nutrition, family planning, etc. already uploaded on that portal. As soon as the launch happens, the document is uploaded so that everybody in the country can actually access them without need for looking for a hard copy in somebody's office. So that portal, that's yours. That portal is a ministry portal, and we help the Department of Health Information at the ministry revamp it for easy access. It is now available. And we keep on uploading the documents there, in addition to many other documents the ministry owns. So please, ladies and gentlemen, utilize that. JP, apologies. I took a long time, but I wanted to sort of paint a bit of history so that people appreciate us, and also gain the enthusiasm to go to that portal and see a lot of these frameworks that we are talking about. Thank you very much for listening. Have a good afternoon.
A second round of applause, ladies and gentlemen, for Nathan. And the main reason why we let Nathan share this is because there's no other better person who can share it than Nathan himself. He has been the kitchen at the foundation of setting up MCHN and all the other aspects that have brought the entire team together. It's been teamwork. And why we are here is because we've created a dent in maternal and perinatal mortality in this country as a team. Our next presenter. Now, Nathan, you will allow me to restrict the time for the other presenters because I see you've given the entire introduction. So my next presenter, Ms. Agnes Nawadinde, Senior Technical Advisor for Reproductive, Maternal, Newborn, Child and Adolescent Health for FHI 360. Please, if you can share with us your presentation on collaborating to implement trauma strategies and guidelines for high impact interventions, national and subnational level. How many minutes? 10? 15? That would be great.
They do talk about gender. There should be some gender consideration. Nevertheless, good afternoon, colleagues. I want to continue riding on the already set protocols to share the opportunity of USAID MCHN's experience, successes, and achievements in collaborating with other stakeholders and rolling out RMCH and nutrition strategies that are very impactful at national and subnational level. So just to pick on from where Dr. Nathan has stopped, at the start of the project in 2020, the activity of the project conducted a joint inventory for existing as well as required strategies. And this was done along with Ministry of Health, working closely with its technical working groups, subcommittees, development as well as implementing partners. Not forgetting the Office of the Prime Minister through its multi-sectoral nutrition secretariat, development and implementing partners. Following this, there was joint designing, implementation, and tracking of a roadmap for the development, updating, review, as well as approval of the prioritized documents. Emphasis was also put on dissemination of the completed documents, both at national and subnational levels, as it had been identified as a weak link previously. We know that a number of documents have been on the shelf for a long time, and they haven't been trickling down to the lower health facilities. Last but not least, there was emphasis on the need to ensure that the completed documents can be rolled out in non-conventional ways, including training, mentorships, as well as uploading on the various platforms available. Last but not least, the roadmap stressed the need to strengthen the functionality of the line technical working groups and subcommittees with a focus on use of and institutionalizing use of tools to standardize business. We brought in an idea of having a standard agenda for all the technical working groups, and this included review of action points for accountability, having data analytics to drive agendas, as well as one unique presentation to aid learning for the people who have convened. And we see that this has worked well, and that is something that we are proud to say. We've institutionalized. All the technical working groups are able to use data and reflect on their progress. Last but not least, on this particular slide, there was need or an agreement to utilize online platforms for communities of practice to aid learning, sharing of best practices, as well as dissemination of strategies that would have been completed. So on this slide, we point out the process and partnerships we leveraged to roll out the prioritized strategies. USAID institution activity, under the leadership of the Ministry of Health and the Office of the Prime Minister, provided technical and logistical support for updating, reviewing, adapting guidelines into the national context. Just to break this down, we were able to provide, to work with the Ministry of Health to convene writing workshops, as well as convene stakeholders to put or adapt global guidance to national context. Support was also provided for pre-testing these guidelines, as well as having them validated by the stakeholders in place through convening stakeholder meetings. Not forgetting support for fast-tracking approvals, as well as copy editing into usable forms, user-friendly forms. I also want to stress the need that, unlike previously, a lot of emphasis and support was provided to these government of Ugandan structures to ensure that dissemination was conducted at national level, but also sub-national level, using virtual platforms, as Nathan has highlighted, physical engagement, as well as enrolling or sharing these documents on the Ministry of Health portal, This would not have been possible without collaborations or selected strategic partnerships with other actors at national level. I want to, in a special way, appreciate the work we've done with the Ministry of Health, the OPM structures, our UN agencies, UNICEF, WHO, UNFPA, the World Bank. We worked very closely with them to develop the sharpened plan, USAID implementing mechanisms at the birth site, as well as other implementing partners, World Vision, Save the Children, to mention but a few. At regional level, we also worked very closely with regional IPs, both USAID and non-USAID, regional referral hospitals, as well as the 11 LMNs, as been highlighted in the previous presentation. So, as a result of our collaboration, we note that over the 5 years, we've had 29 strategies developed. I want to pause at this point and clarify that for this presentation, the term strategy refers to policies, guidelines, tools, as well as frameworks to guide implementation, not necessarily, so it's a little bit bigger. So of those 29, 24 have been rolled out, and 4 of these are maternal health related, 2 are newborn, 6 speech to child health, 7 are nutrition related, and 7 are cross-cutting. That includes the sharpened plan, the quality of care guidelines, among others. I thought I was whispering. So this slide, I wanted to highlight that this is work in progress. You can't say you've completed updating guidelines. Even tomorrow, I think the first presenter from UNICEF highlighted that they're going to release guidelines about newborn care. So this is ongoing work, and we note that at this point in time, we have 5 guidelines that are pending approval, including guidance to implement the LMNS strategy, as well as the Respectful Maternity Implementation Framework. But I also note, and I want to rally all the stakeholders in the space to support Ministry of Health continuously update guidance based on global releases. The project has also leveraged the LMNs and MPDSR platforms to ensure that there is ongoing sharing of learnings, accountability, referrals, improved referrals, and real-time consultations. And I won't spend a lot of time on that because Dr. Nathan did a good job. This is an example of a partnership or partnerships that we demonstrated working in the Ministry of Health to partner with the subnational structures to cascade the updated inter-class guidelines as well as INCI at district and facility level. So we started off with conducting national trainings, and this was in collaboration with WHO, UNICEF, and the Uganda Pediatrics Association, where master trainers were trained, and this in turn conducted regional trainings in those regions listed there. And this was in collaboration with a number of partners. The list is long, so I'll not go over it. And these partners, these regional trainers, together with their regional IPs in their different catchment areas, then rolled out to the district and facility level. And as Nathan highlighted, the scope of the project was restricted to catalyzing linkages between the national level and subnational structure, and not necessarily duplicating efforts of the regional level structures like a regional referral hospital. As I conclude, overall, the contribution of the collaborations to roll out the various strategies has improved maternal and child health outcomes in the country, and as highlighted yesterday from the MPDSR report and the recently released annual health sector report, we know that there's been a dent in mortality over the 5 years, but also a reduction in the negative outcomes of nutrition, including stunting and wasting amongst our children in the country. And this has been attributed to improved provider competencies and adherence to standards that has contributed to enhanced quality of the services that are being provided. I want to thank you all for listening, and over to you, Jeffrey.
A second round of applause to Agnes. And I really want to thank her for serving us some 5 minutes. That was very powerful, Agnes. Thank you very much. And ladies and gentlemen, the main reason why we come every year for the National Safe Motherhood Conference is to share these best practices, to see what the Kampala Metropolitan Local Maternity Neonatal System can learn from Chigezi Local Maternity Neonatal System, can learn from Karamoja. The cross-pollination of ideas is what is going to move us from one point to another point. And really for me, when we hear these phenomenal stories of the progress that we've made in a very short time, combining our efforts as a team, it's what we have to continuously do. And that's how we are going to end preventable maternal and perinatal deaths in this powerful country of ours. Without any further ado, allow me to go to our next speaker, and that is my brother Richard, who I know is also going to send me some 5 minutes. And he's going to share with us the Kampala data-driven approach to enhancing urban rural care and nutrition services. My brother. And by the way, to let you know, he needs a very handcraft, because this man here is also the chair of finance for the National Safe Motherhood Conference 2024. So that round of applause is not good enough. Thank you very much indeed, and we look forward to hearing from you.
Thank you, Jeffrey. I know people have been eager to see who can demo Richard is. Many have not had a nice experience, but I'm glad you're here, finally, at the conference. So I'll be speaking to the work we've done with the KCCA, Kampala Capital City Authority, as well as the other public facilities and private facilities within Kampala, including Kawempe National Referral and the private sector. Dr. Nathan has done a good job, so I'll just run over the data, because he said we've been using a data-driven approach. So what does the data look like, and what are some of the change packages or the game changers that have been employed to see the results that we are going to be seeing today. So a little bit of the dynamics in Kampala. Kampala is quite different from many of the cities we have across the country. The populations are different during the day and the night. You have the people living in Kampala, Most of you come here to work. So we have to plan for the day, guys, and also plan for the night population. It's very, very tricky and difficult. It's also surprising that the unemployment rate is 26.3%. Most of us want to come to Kampala for jobs, but actually the unemployment rate is very high in the city. And when Dr. Lita talked about the under-resourced people, these are the people we have to support to make sure they get quality health services. We have about 339 health facilities, and only 1.2% are public facilities. Majority, 96%, are private for profit, meaning that the people within the city have actually to pay for this service in one way or another, factoring in the unemployment rates. But then 60% of the population is slum dwellers. And this is where we focus most, to make sure that the facilities that are within the slum communities are able to provide an affordable, quality care service for women and children. So I'll leave out the rest because I think Nathan has spoken to that. I'll start with antenatal care attendance. Within the city, we've seen tremendous improvements in antenatal care attendance, especially for the fourth visit, rising from 25% in 2019-2020 to 73% in the current financial year. Much of the efforts have been around mobilizing these communities, and I know that our colleagues, the Social Behavior Change Activity, SPCA, have been very helpful in designing materials, a family health care campaign that has worked in Kampala to ensure that women are able to understand why they need to attend antenatal early, but also complete all the required visits. But also we've done a lot of work in using QI, using the IDEA approach that Aneta talked about, as well as the high-risk collaborative to make sure that we mobilize women to attend antenatal, identify high-risk women, and link them into care and keep them within care as well. But amidst that, we see low attendance in the first ANC, within the first trimester, and the complexities are because Kampala is a transient population. Okay? People are coming in, people are going out. Many times when women get pregnant and are about to deliver, they want to go and deliver with their grandmothers in the village. So maybe they don't actually attend antenatal here or deliver here. We have mixed communities, different cultures, different tribes, different countries within the city, refugee populations. Reaching them with one single message is not possible. You have to tailor messages for different communities. You have to understand their cultural perspective, and address all the myths and misconceptions. It's been very complex, but our SBC colleagues are helping us there. In terms of newborn resuscitation, we've made also tremendous improvements. We've seen more babies being born struggling to breathe, but then resuscitated successfully, rising from 85% to 96% within the current financial year. But also generally, we are seeing a decline in the number of babies who are born with asphyxia. And I want to say that efforts have not just been us, but there's been a lot of trainings, mentorships, but then the collaborations with UNICEF, supporting Save the Children, I think has some work around resuscitation. Dr. Victoria Nachibuka is doing work around resuscitation within the city. So we work together to see that we are able to save more babies within the city. CQI, this is just one of the examples of quality improvement, the high-risk collaborative. I think Kampala has done extremely well in the high-risk collaborative. And we thank KCCA for this effort. So we have been working in 24 facilities. And we've seen women who are able to receive a complete risk assessment at AAC rise from about 50%, and now being sustained at 100% in all these facilities. All of them being assessed for a high risk. Thank you very much. Our Kampala teams. Now, the women that are identified with a high risk are supported to have an individualized birth preparedness plan. And that has come from 33% to now 94% within the supported facilities. Health workers spending time to work with these women to ensure that they prepare for their birth, the labor and delivery, and thereafter the postnatal period. And out of that, we've seen the outcomes improve within the city. Within the cohort of the women we've worked with, the pregnant women we've worked with between January 2023 to March 2024, 99% walked out of the facility alive and with a live baby. We had, I think, about just 34 maternal deaths, no, 2 maternal deaths and about 34 perinatal deaths within that period in the facilities that are implementing this collaborative. I'll quickly run to MPDSR, and I know it has been said, we launched a report yesterday, but what is the story within the city? The perinatal death reviews were the lowest in this country, in Kampala, at 38%. As we exit and KCCA takes over and sustains this and Kawempe National Referral, they are able to review more than 50% of their deaths and understand the issues and set up action plans to address these issues. So we have to appreciate the teams in Kampala who sit every day. Kawempe sits almost every day because they have about 70 perinatal deaths, okay, on a weekly basis, and they have to review half of those to understand why these babies are dying. Maternal death reviews have also risen from 87% to being sustained at well above 100%. The greater than 100% is because of backlogs. What have been some of the results, the actions that have taken place as they review and develop action points? We've seen improvements in the health workforce. Nathan has talked about the proof of concept that we did with the KCCA, and now they've received a new approved structure, staffing norms for their facilities, and they're working on recruiting more health workers within the public health facilities in the city to ensure that there's 24-hour CMOC functionality in Chisenyi and Kawala. Before, some of these facilities never do Caesars at night, they would refer them to Kawempe. Now we know that Kawala, Chisenyi are doing cesarean section day and night because of the investments in our health workforce. The hub and spoke model. I think the hub and spoke model that's now being rolled out in the country has been an exemplar from Kampala Capital City Authority. The city decided to use a distribution model. And if you're familiar with Mobits, the Vasley, okay? So they have, this is what the director of the system would say to us here. They pick that model where there's a warehouse and then you have distribution trucks, okay, that are stationed within different regions who distribute to wholesalers and then distribute to retailers. So they developed something similar for their facilities and got hub facilities, which are CMOC facilities, to be able to support the BMOC facilities that are within their catchment. In terms of top-down referral support, mentorships, and supervision. And through that, we've been able to reach private and public facilities with trainings on helping mothers survive, helping babies survive, and many other frameworks have been rolled out through that. Service delivery, KCCA has been able to procure 7 additional ambulances. They have a referral, the cadet system, which is the Kampala Emergency Dispatch and Call Center, and they're able to support referrals in real time. As soon as the facilities communicate, they dispatch ambulances, track those referrals, and ensure that they arrive in time and these women are saved in time. There is also now a 24-hour coverage for CMOC functionality, as I've said. The referral protocols have been put in place and shared across. Each facility has a number, a contact person of who they should call before they refer. To seek guidance, to make sure that they prepare for this woman who is coming, and attend to these emergencies in time. Health financing, Nathan talked about this. We work with the corporate society within Kampala. MTN organized a marathon run for babies and able to tour an oxygen plant for Tseni. We've seen Stanbic Bank giving gift hampers supporting newborn care within Kawempe, as well as other facilities. This as well has been talked about, ensuring that we have essential medicines and supplies. Now, engaging the private sector has been very, very instrumental to this work. We were able to work with KCC and map all the TBAs. It's surprising that Kampala also has traditional birth attendants. There are over 49 of those. Okay? Now, KCCA has a real-time map knowing where these are, because we have the geolocations. Okay? And they are being followed up to make sure that they stick to their role of referral. Okay? And most of these were causing a lot of issues. So they were visited, they were assessed, they were supported to make sure that they did not retain women there. KCC has been issuing management letters to private facilities that do not perform well or lose a baby or a mother, especially where they have gaps within their health system building blocks. And some of these have even been closed. Some have been supported, mentored, trained, supported to have protocols and guidelines, and they are now doing much better. And because of that, KCC has won a lot of awards. We should clap for them. Many of their facilities have been recognized in a different ways. I've spoken to this. Serial sections have gone up within the KCCA facilities in Kampala, and thus the referrals have reduced. We've seen a decline in the institutional perinatal mortality rate. The maternal mortality rate is still staggering. But I know that things in Kawempe, where most of the women die, are working so hard. But most of these are referrals that come from outside actually Kampala. And they struggle with this and do their best. Children, we've seen improvements in the vaccinations for childhood vaccines, as well as ensuring that all our children are fully immunized by 1 year within the city, coming from 31% to 80%. We've done some work around profiling zero-dose children, making sure we know where they are, what are the reasons why they are missing some doses, and then design strategies to make sure that they are reached, and we address some of the gaps there. Family planning, especially postpartum family planning, has come from 11% within the city to 60%. Now women are able to have a family planning method of choice because of the efforts of the health workers within the city. We've not forgotten about gender, the youth, and making sure everyone is taken care of. We've done some work with our partners within the city to ensure that we reduce all forms of GBV, gender-based violence, and ensure that those that are victims receive services appropriately. Nutrition has also improved. I've spoken, I've seen Madam Samali, the Assistant Commissioner for Nutrition, within the Ministry of Health. We've seen nutrition assessment within the city come from 5% to over 70% in all the public and private facilities. And this is, more work has been done in the private sector. And therefore, they're able to identify children who are malnourished and link them into care. We've seen a reduction in malnourished cases within the city. We've done community work, reached children below 2 years with vitamin A supplementation, deworming, as this slide sticks to that. I'm trying to run through because of time. And finally, the reporting has also improved. And Nathan spoke to this. You see where we started from, reporting on time from 19% to now 75%, making sure that within 2 weeks, by the end of the month, our facilities have reported into DHIs to their data. Thank you very much.
Yes, and I want to thank my brother for saving me some 2 minutes. And it's very important for us to appreciate that for KCCA to do well. Districts like Mukono, DHO Mukono, I say somewhere, DHO Mukono, where are you? Excellent, yes, DHO Mukono. When you do well, KCCA does well. I saw NDHO Wakiso. Excellent, when you do well, KCCA also does well. Is Impiji in the room? So the neighboring districts, when you do well, also the indicators of KCCA significantly improve. So that is one case that we have to continue to work as a very, very solid team. That was a very powerful presentation that has driven averages. And the message here, as we go back, and the PSA, as we open the 4th chapter of safe motherhood in this country, we must get back and embrace data. Capturing data, understanding data, appreciating the data, and utilizing the data to improve our practices back in our respective local maternity and medical systems. Colleagues, allow me to invite our next presenter, who will share with us some of the lessons and takeaways on KCCA's behalf, and that will be none other than Dr. Chris Owundo, the Division Medical Officer for Nakawa KCCA. Dr. Chris, and I know he's going to send me some 3 minutes as well. Thank you. We're really doing well in terms of time. Dr. Chris.
Thank you. Good afternoon, ladies and gentlemen. I bring you greetings from KCCA, from my boss who's unable to be with us here due to some of the issues some of you are aware of. And I will add my voice to the protocol which was recognized. I am here basically to agree with what the team has presented. All those were takeaways from the period we have been with FHI. And we were praying that they don't go, but I think this is inevitable. We still count on those who are coming on board to support us. So as I take some, I was also taking some lessons from the team. What are the takeaways? We need to appreciate that the government of Uganda stewardship at all levels is essential for fostering local ownership, responsiveness, and sustainability. As you can see, we had disengagement. I think it's the other side. In one of the photos, we had the Minister of Health and KCC officials and Minister for Kampala, and this was during the partners engagement for Maternal Child Health Symposium, and this was basically reaffirming commitments to reducing maternal and newborn mortalities in the facilities of Kampala. So as the leaders came on board, it was an energizing moment for all the stakeholders involved in this to see that the commitment from the top is key. What we need to appreciate is that stewardship at the other levels. Like for the case of Kampala, of course, we are looking at divisions, which operationally are districts. And we also have levels below districts where we have key stakeholders that are critical. And the basis for that is the fact that when you are talking about Kampala, this is where we are finding that 99% of the facilities we have are private facilities, privately owned. And this number has been expanding. We had an opportunity in 2018 to do a mapping. At that time, we were able to identify 1,500 facilities. But last year, with support from FHI, the geo-mapping which was eventually undertaken, we were able to identify select about 2,000 facilities. You can see that the private facilities have been expanding, the public are the same. And when we talk about, like the previous speaker has been able to demonstrate that the numbers have been increasing. If you are looking at, say, antenatal care, OPD attendance, and other parameters, the numbers have been increasing, and we realize that the increment may not be that we are attracting more people in our public facility, because they are bursting, but it is likely because we are bringing on board many private facilities that were not reporting to improve the reporting, but also improving the qualities in there. And as such, you find that our parameters get better. So the engagement of leaders at all levels is that approach which we have relied on to get the proprietors in the private sector on board. We also had engagement of the business community, who are critical to provide resources that normally the government may not be available at the government's disposal for improvement of services. And here we have seen Standard Bank, for example, make significant investment at some of our public facilities. We know we have now the oxygen plant at Kisenyi. We recently, for example, had the staff of Standard Bank making a donation for antenatal care equipments to Kiswa Health Center. And there are so many other examples. So this mobilization platform is a very good opportunity that we shall continue riding on to make sure that we are able to improve the quality of services that we provide. This has also been well elaborated by the previous speakers, the issue of data-driven stakeholder engagement and advocacy, which stimulates local investment in health. The decisions we make are data-driven. And it is from this data that we realize that one of the key delays leading to maternal and perinatal death was the challenge of accessing ambulance services. And that enabled us to make a case to have KCCA prioritize the procurement of these ambulances, which are helping us. And you know, the way we are managing these ambulances is also a takeaway approach for others to teach. You know, quite often, personally, I had the opportunity to have worked in a local government, and you will find that one big challenge is the effective use of these ambulances, whether they are used or not, or if they are really supporting the purpose for which they are provided. Now, for us, we have an EOC center, which is a centralized mechanism of managing these ambulances that when the need arises, the call center is raised, they do a quick triage, and they are able to dispatch an ambulance. And for that, we are confident that all the ambulances are doing what they are meant for. We were also, okay, I had talked about the oxygen plant. One of the biggest reasons for referrals from Kisenyi to Kawempe was the challenge of oxygen in the operating center, in the operating theater. And this was timely when we were able to get this investment in order to address that challenge. The other takeaway is the fact that the strategic partnership approaches enhance synergies and promote mutual accountability, driving sustainable impact. So here we can see the key partners that have been in this journey on the newborn partners for Kampala. You said MCHN activity, of course, we really appreciate and we are very grateful. We also have the SWAP that is serving women and serving women and preterm babies project. This is supported by Save the Children. We also have the resuscitation, infection prevention and breastfeeding, the RIP team, which is led by Elma and Dr. Nachibuk. I don't know if she's within here from Zambia Hospital. She's the brain behind this, and this has been very timely. And of course, we also have UNICEF, which is there and is making significant contributions in enabling us undertake a number of interventions within the city. And those are the areas of complementarity and synergies which we have been working on, including trainings and mentorships. And maybe just to emphasize something on mentorships. You know, at programming level, there is a tendency to allocate resources to specific facilities. Like we had that in the design, MCHA was targeting 23 facilities. And quite often these are high volume facilities and which are largely public or PNF facilities. We had a question. For example, one undertake mentorship. And one of the listed facilities is Zambia Hospital, Naguru Hospital. So the question was, whom are you going to mentor and who is the mentor? Because the people you want to mentor are the one in these hospitals. And yet, the reasons they are having maternal mortalities and newborn mortalities are likely from the data we had. Latent referrals coming in from specific, well-mapped facilities around there. So as KCCA, and that's why we appreciate the flexibility of the team from FHI, we're able to agree that let's do the mentorship. Let these hubs now, the hub model, let these 23 facilities be distributed the hubs, so that they can make the facilities that will often be referred to them. And of course, using staff from those same facilities was a much better approach because they strengthen, first of all, establish rapport with the providers the other end, but also in the process strengthening linkages and referral mechanisms. So that if there is a challenge, somebody can pick a call and reach out to the senior person at the other end before even referral is effected. So there are so many other areas, HMI's strengths and HMI supporting. As of today, about half of the facility are enrolled in the DHIS school system. We would wish to have 100% facilities in Kampala enrolled. Of course, if that happens, our data will skyrocket. We shall be able to demonstrate the contribution of all other persons, other Ugandans who have invested in provision of health care services in the private sector, and we shall be able to plan better. This is not possible without the partnerships, because we do not have the human resource to go out there to mentor each of these new private facilities and follow them up on weekly for the weekly surveillance report, but also monthly and quarterly for the rest of the other reports. We have also, this collaboration was able to support the quality improvement initiative, supply chain management, newborn equipment, stimulation labs, human resource for health enhancement, and nutrition. We can confirm that up to 9% reduction in the institutional perinatal mortality rate has been documented during over this 3-year period from 2020 to date. So you can see that we have saved significant lives as a result of this collaboration. And finally, this has also been well elaborated. Nathan made a clear description on how anchoring technical assistance at both national and subnational level streamline system-wide recruitment efforts and foster local ownership. We have seen that guidelines that are coming from Ministry of Health, as they update them and review them, they are informed by the data coming in from the implementing at the implementation level at facilities. And we are very grateful for Ministry of Health to continue leading on that front. We have also seen how the regional mechanism is working. Yes, KCCA had the G2G as well. Unfortunately, we lost it earlier this year. But we have Naguru Hospital, G2G. So, working with the Naguru Hospital and currently reach out to India, we are still strengthening some of these initiatives which we started on. And at district level, in our case, like I said, we look at divisions for that purpose. There is a lot of work going on there, and all this eventually feed back into what the Ministry of Health comes up with. Chair, I want to thank you, and I want to appreciate all partners that have supported KCCA in strengthening maternal and child health response in the city. Thank you very much.
Thank you. And I will request you, Dr. Please, just to take a seat at the front here so that we can get some questions from the audience. We'll take only 4 questions. But let me also invite the other speakers, Dr. Nathan, Ms. Agnes. And as they come, can we have, please, the visual of the MPDSR story as the panelists come here to take some photos. But let's see that MPDSR story. And if you have a hot question that you really think that should be responded to, not in the 5th NSMC, but in the 4th NSMC, this is the time. And the male champion, male involvement champion has a question, and then we have another question there, so 2 from this side, and then we shall have a question over there. Let's have the MPDSR story, please.
Maternal and perinatal death surveillance and response is a quality improvement intervention. There is a global guidance that every maternal death that happens, that occurs at different levels of care should be notified, should be reviewed, and actions should be identified. An action plan should be made to prevent the next death.
So the MCHN activity has been collaborating with the Ministry of Health and other stakeholders to improve the maternal and perinatal death surveillance and response system. Right from the start, we collaborated with the Ministry of Health counterparts to ensure that they are able to meet and review maternal and perinatal deaths. So they were initiated what they call the community of practice. The national community of practice is a group of stakeholders who come together every week on a Thursday to review and account for the mothers and the newborns who died in the previous week.
USAID MCHN stood with us. We needed a dedicated team of personnel that would deliberately focus on picking the analytics, analyzing the analytics, following up with the districts. We have over 140 districts. We enhanced our MPDSR by doing a deep dive into cases of maternal death that happen specifically at lower level health facilities. So these virtual platforms are also referral platforms. If you're sending a mother to another level of care, please, I'm sending you a mother, this is what I've done, and expect this mother in. I'm stuck here, I need blood. So we are using these platforms, virtual platforms. So our MPDSR of Uganda is both a learning and accountability. That's the uniqueness. For example, if there is a problem with equipment, problem with blood fridging, problem with infrastructure of the theatre, you need funding. So being able to share some of these annual reports, MPDSR reports, with members of parliament, with the Speaker of Parliament, so that we could use them as advocacy tools to guide resource mobilization.
To make sure that when mothers are referred and they need blood, blood is readily available. For all blood groups, from group O, group A, group AB, and group B, blood is always available. We have also introduced a distribution system whereby if our lab staff can take blood whenever they go on their supervision trips. So they go to the healthcare facilities, they help them to account for blood, they help them to manage their needs so they can have blood as and when it is needed. And even then we have also introduced Zoom meetings, weekly Zoom meetings whereby we share what has happened, the maternal deaths, how we can improve, and this will have really improved blood stock levels in the healthcare facilities to avert maternal deaths in those centers.
We were seeing minimal implementation of the recommendations that were coming from the MPDSR conversations. So much of the conversations were remaining national. We weren't having regional involvement. Majority of the regions will only point at the Ministry of Health. We have this problem, we don't have assemblies. Ministry of Health, you're supposed to help us do that. We absenteeism issues, Ministry of Health is supposed to address that. These maternal deaths are happening in our region, Ministry of Health is not doing their job. So everything was coming to Ministry of Health. And so that's how the local maternity and neonatal systems came into being. There are those very solid impacts that we have seen the LMNs have done. Are our national regional referral hospitals taking responsibility to drive the regional transformation agenda? For us, we are very happy when we see our national referral hospital now on top of transforming maternal and newborn service delivery in Kampala Metropolitan, because it's a national referral hospital, and that is one of the responsibilities that it's supposed to do. We've been able to also bring on board the private sector. The private sector is now fully on board. Previously, teachings will only happen, mentorships will only happen in the public sector. Why? The private sector now will really pay much attention. But now, because we've also been able to embrace technology, that much of the teaching happens virtually.
The LMNs have done a great job. Because if I was delivering 120 mothers a day in 2019, 2018, and currently I'm delivering 60 to 80 mothers a day, it means that something has been done. I'm sure when you walk around, you're also happy.
We are able to easily, in a minute, get a communication from the Senate to all the 15 millions of this country in 1 minute. And we are sure that communication will have reached why? Because of the local maternity and neonatal systems. So there is proper alignment of partner support, there is proper alignment of the vision,
For the frontline healthcare workers, now they understand where we want to go. For us to reduce maternal and prenatal mortality reducing from 336 per 100,000 live births in 2016 to 189 per 100,000 live births 2022, and prenatal from 27 to 22 per 1,000 live births. It's an awful lot of efforts that have been gone in, and in no doubt, what we've done in MPDSR, what we've done in the local maternity and neonatal system have made a very significant contribution. In the last 5 years, we had a 44% reduction in maternal mortality.
There's been increased government participation, especially the Ministry of Senior Leadership, engaging with the data and interrogating the facilities on what were some of the available things that they should have handled before these women came into the facility, encouraging LMS to meet their orders. And they've also been improvements around blood supply, okay? Working with the Uganda blood transfusion services to ensure that blood is available in the facilities and is moved quickly to where it's needed. We've seen the teams engage more with data. I think that's been the biggest way. Okay? People being able to look at the data and make timely decisions that are better driven on how they can reduce maternal and prenatal deaths. So our recommendation is that the Ministry of Health takes this care to ensure that regions, through their local maternity and neonatal systems, are able to work with the data that is reported in our national health information systems and use that data to target their interventions on what they need to do best and earliest to save women and children.
Very, very proud. LMNS coordinators in this room, you could just stand up for recognition. The LMNS coordinators. I think there are somewhere, yes, the LMNS coordinators, those are very, very magical men and women who are driving transformation in the regions. And a round of applause to the resources that enabled us to put this story together, and USAID and activity. Now, let's get the questions.
Yes, sir.
Many involvement, John.
Many involvement, definitely. And we are very happy that the Many Involvement Technical Working Group sits in the Ministry of Health. And my co-chair, Dr. Magahi, is one of our strongest champions for engaging men and boys. And I want to just tell the team that actually men involvement was actually sits in the reproductive health. That's where it started from. And Kampala, talking to our Kampala champions, is that we trained male involvement champions in 5 divisions of Kampala City. Dr. Wundo knows us very well. And just to say that we train father mentors, by the way. The Ministry of Health developed a male involvement training together with WHO, developed male involvement training manuals, and reproductive health was a key topic in this training manual. So just to put forward to the panel that actually we have champions who were trained in using our documents, our training manuals, and I just had hoped to hear something small from one of the speakers on the issue of engaging father mentors, the issue of engaging men, and my question, I think, let me get my question to all of them. What have we done in that area? Knowing very well that for safe motherhood, you need to have positive fatherhood. Thank you.
Excellent. Let's get the second. What was the second hand? Well, let's get my.
We can come up with a resolution on what we want to do with TBS. I'm aware WHO has put standards on what we can do to give a role of redefining the role of the TBS. Last 2 weeks ago, we are launching the health promotion, and you could see that we are talking about VHTs, we are talking about tools. Yet the TBS are there. You even have a referral hospital for TBS. Quite disturbing. Is there something that we can make as a resolution so that next year we come here with a different stories about the TBS? Secondly, it's about KCCA. Thanks very much for what you shared with us, good initiatives. I want to ask the sustainability of the program because it looks like there are other agencies attached. My assumption was the city was able to do that. And also as the CCA, I wanted to know how you are managing, because when you looked at the indicators, MPDSR yesterday, and even what the doctor presented yesterday, we are not doing well as Kampala on the indicators, on the referrals. What different things do you want us to see in the subsequent years so that we can see that we are making a difference in the urban? Because urban poverty hits us and we usually forget because we focus on the rural community. Thank you.
Dr. Dan. Dr. Dan Roper, right over there. Yeah, we can just go.
Yeah, thank you very much. I congratulate you, Dr. Nathan, and the team for a successful implementation of the activity. There are some things which are cryptic that usually we face as implementers. We'd like to learn from you and your team how you navigated the various challenges and what you learned from that and what you advise other implementers. The second one is that in every presentation you made, including yours, there was a tinge of sustainability in basically everything that you did. What advice would you give the Ministry of Health, for example, and IPCL to build sustainability in everything that they do? And lastly, brother from KCCA, what proportion, if you can, just an estimate of all these interventions you think you'll be able to carry forward in case there is no further financing for them? And also, if you can comment on how you manage startup centers in the city, that would be very helpful for us to know. Thank you.
No, so that one question has like 5 of them. But just hold a minute, because I want to assess. This is a very powerful conversation. My brother Kamara Daniel, one of the recent young nutritionists, will make a comment. Oh my Jesus. Okay, let's get Kamara.
Thank you so much. Thank you so much, Dr. JP. Now, my question goes to Dr. Kajimo. I am very excited for the nutrition indicators that you moved from 5% to 70%. That was extremely excellent. But now, just like in the urban settings, we have now increased the obesity rates. What are you going to do to prevent that? And also, the vicious cycle of malnutrition in these mothers who are attending antenatal. How are we going to bring out the strategies of ensuring the nutrition preconception care to come out clearly and have these mothers be attended to, or they prepare 3 months prior to getting pregnant. So that will break down the vicious cycle of malnutrition.
Excellent.
Thank you.
Now, can we jointly agree that you're going to borrow me some minutes of your lunchtime? And the reason is that we stole some time from their session for break, isn't it? And I'm very happy that we have all agreed to that. Let's first respond to those quickly, yes? And then we shall take another round of questions. It's a very interesting conversation. And so for me, it's important that we really ensure the interaction is very powerful. Now let's see, those who are going in the second round, I can't miss the Kampala Metropolitan LMN coordinator. And then my sister right over here, that's 2. The Acholi LMN coordinator, yes. And then my sister right over there, and we shall close. We shall close the section with the questions, yes. Let's respond, please.
Thank you, Chair, and thank you for the questions.
And we can just make it brief to the point.
Very brief. I will respond to a few of them. The question on male involvement, I think this has been with us and is still with us. And we have some initiatives that we've been undertaking. For example, I want to answer this together with the question on TBS. So we identified the TBS and brought them on board as Mama Ambassadors. Why Mama Ambassadors? Is that we were incentivizing a TBA who helps a mother as early as possible in pregnancy, because these mothers don't only visit them during labor, they even go for antenatal care to these TBAs. So a TBA who links up a mother to a specific facility, which we identified as a hub, would be motivated. That would mean that we are not kicking them out of business, but we were bringing them closer and having the mother at least undergo assessment by a trained provider. And in the process, risks can be documented early enough and proper management plan provided. In the same way, using the same approach, we encourage their partners, the male partners, to come on board along that Mama Ambassador approach. This of course gives us better results, as we could explain better later. Now there is the other question I need to move to. The question on KCCA has done much, and yet we could be having other partners. Of course, KCCA works with and through partners. You cannot deliver the services in Kampala if we go so as government. First of all, like I had highlighted, when you talk about human resource for Kampala, we are just a drop in an ocean. If you look at the population and available human resources, we are very, very few. And related to this is the question of absenteeism. If you look at the staffing norms for Health Center 3, Health Center 4, remember that our KCCA facilities are Health Center 4s and 3s, and then 2 Health Center 2s. The staffing norm cannot work for secretary that sees up to 1,000 clients on a daily basis. So we have been engaging Ministry of Public Service and Ministry of Health to revise the staffing structures for KCCA, which they did partially, but the engagement is still on. And you realize that the staff that we have are largely on a 12-hour shift. Now that also presents a challenge on the challenge question of absenteeism. But what the administration has done has provided in each of these health facility attendance register manager, assistants, who physically, I prefer calling it mechanically, manage attendance register, so that we can have a basis for sanction those who are a problem. But of course, the softer approach is to mindset change, which is the better approach to make sure that the staff are available to provide the service.
Thank you. Dr. Nathan.
Yeah, I will talk to a few of the questions. Richard, you'll talk to Mary involvement from the angle of GC. So challenges, this is a very loaded question. The journey definitely
has been a journey that is full of challenges, if I could call it that. And they are broad and at different levels, and I will limit myself to Kampala. I will not go to the national level for reasons that you may understand. So, the number one challenge or challenges, the wide systems gaps across all elements of the healthcare system. As Dr. Wundo has described, the system which is entirely pivoted on one private sector serving very many people who don't have the resources. But then they will end up, some of them, going to the public facilities and congesting them. So the overcrowding of public facilities that do not have enough stocks, do not have enough human resources, personnel, 24 hours, do not have enough equipment, do not have enough space. Actually, that's a very, very big problem. So across the healthcare system, that's a huge challenge that we meet or we met from day one until today, actually. So what have we done about that? That's wide systems gaps, cutting across. One, partnerships, strategic partnerships, because the resource envelope that we have thanks to the American people from USAID was limited. And it also has boundaries, because there's agreement between the two governments. So strategic partnerships. We are not able to buy any equipment, pieces of equipment, high level, low level, ordinary. But other partners were able to do that. For the small equipment that we were able to do, to procure, we procured. Say nutrition equipment, anthropometric equipment, basic equipment here and there in the clinics, so we were able to do that. When I say system gaps, I also touch on human resources for health. Numbers, and I described what we did in the circumstances, but a lot more still needs to be done. Skills, competences, I think we've largely done a lot of that, because that was in our control, really. The other gap that still touches on governance, stewardship as part of the healthcare system, of course, appreciation at all levels, not at your level, sir. So please, all levels, there is governance at all levels, healthcare facility, level, community level, leadership and governance. But we dived into those areas and were able, with the stewardship of KCCA, to clearly define roles and responsibilities for leaders at various levels to be able to take up the mantle, including community level, actually. What is the role of the LC chair? What is the role of the religious leader? Very interesting that we actually discovered many healing informal groups within the city during the COVID and Ebola response that we were not aware of, that people are really congregating around. They might have their own leadership hierarchy. But through engagement, those leaders were able to actually appreciate their role, specifically around infection prevention and control within their own congregations, including the churches, these big churches that we have in the city. So that was within our control to a large extent, and we were able to have some mileage around that. Engagement and negotiation. That's the other avenue that really helped us. And that has to be sustained. The learning was that has to be sustained. Engagement, negotiation, building relationships at all levels, and can start from the national level, but also KCA level, city level, division, and many times we would make some mistakes around that. Truth be said, we jump protocol without you realizing that you've jumped protocol, and therefore you are not able to move all the mile. And you got to come back and check the boxes and then go back. in our engagements with traditional institutions. You know, in Kampala, we are the center of a huge traditional institution, which is very useful. So we found a way of leveraging it from the leadership side so that those structures can actually lend us their voices. That's the, for example, Bulange level, and then I've forgotten the word in Uganda, the chiefs at the lower level. Those are actually very useful. I never knew that they were actually chiefs within the kingdom that can actually go a great distance. Okay. Yeah, in helping with health issues, public health issues. So it's a multi-style kind of approach that we adopted. Dynamic, you know, thinking on your feet, but also being able, you know, to agree that you're going forward your sleeves and make your hands dirty.
Thank you, Malcolm. Yeah. Now, just to the point, Agnes, any questions just quickly? You just make it brief.
I think most of the questions were around Kampala, but I want to speak about the gender sustainability approach, where we worked very closely with the government of Uganda structures to strengthen the system. Just to probably take an example, we worked to strengthen the technical working groups, institutionalizing use of data, as opposed to doing the work, working alongside with our colleagues to ensure that they can continue doing this even when we're gone.
In a second, Richard.
Yes, I think Dr. Samuel spoke to the male groups, and just to add that just in Kampala, we've worked also with the male champions, especially the community work around community nutrition and birth preparedness to make sure that the men accompany their women where possible. We have, as I said, Kampala is dynamic. Time poverty, men are available, but there's been some traction around that, and I think it complements our work.
Excellent. Excellent. Now, 1 second, Dr. Your question, just to the question. To the question. Because previously we were doing well with time, but now we're doing terribly with time.
Thank you, Chair. My name is Kampala, and I would like to thank Nathan and team for the great work done in Kampala, especially the hub in Kawempe. But our biggest challenge is about the referrals, and those that have been referred through the pre-referral communications coming in an ambulance. But what can we do about the paramedics? In our third Safe Motherhood conference, we talked about paramedics training, since now we have emergency medicine. How far has that gone? Is there a plan? We need people with these patients in the ambulance, giving them treatment as they reach the destination.
And that is to Dr. Owundo?
Yes.
Dr. Owundo, that's your question. My sister here, question number 2, just to the question. Okay. And you mentioned to who the question is being directed.
So thank you so much. My name is Dr. Wangoi Betigani from Kenya. I work with Gates Foundation, and I'm really pleased to be here to learn so much from Uganda. And this question is actually to you, Dr. JP, on I'd love to hear from you on what your thoughts are in terms of introduction of innovative, high-impact interventions, such as the emotive bundle, the multiple multi-nutrient supplements in ANC, and CPAP for neonatal resuscitation, just given that a lot of the issues now that we are seeing in MPDSR in Uganda are on PPH in the facilities, anemia in antenatal, the antenatal cycle, and birth asphyxia.
Excellent. That's me. It's my sister from the Ancholi Local Maternal Medical System, Dr. Breakout. And that is the third one. And I had the last one right over there. Other questions, you will interact with the panelists during lunchtime. My sister.
Thank you very much. I want to appreciate the innovation of the NASMEC. I think we've seen experts reach the last mile midwife. I was very happy when Professor Annette Nakimuli came up to Gulu in the name of NASMEC and met the last mile midwife. They were very excited to meet her. And then the LMNS is working very well so far. And I must say the LMNS has strengthened the governance roles of the regional referral hospital very greatly. However, the challenges that we are grappling with is the absence of critical cadres. We cannot save babies from dying when all the general hospitals in Acholi don't have a pediatrician, and they are delivering over 300 babies in a month. That is one big challenge that we are struggling with. And then two, the emergency medical services ambulance. To my view, as the LMNS coordinator for Acholi, I'm speaking for Acholi, they have not yet met the need of the very sick newborn. The midwives still confess that ambulances seem to respond more to the mother with difficult labor than to the sick newborn. And they still confess, we still have babies coming desperately on a board once in a while. And outcomes haven't been good. No wonder the numbers are not coming down. So we need deliberate efforts to improve referrals for the sick newborn and to have the critical cadres to save the newborn. And lastly, the LMNS coordination, I don't know if it was my plan that if it's obstetricians that should coordinate it. I think our counterparts, the pediatricians at regional level, are a bit laid back in the LMNS. So the plea for the newborn is not as strong as it is for the pregnant women. So I don't know if you can create space for them to coordinate, or I don't know what it is, but they need to be brought up front as well. Thank you.
Thank you. Thank you. And let's have the last question right over there, and then we close the questions, we get the responses. I think it's Dr. Omundo. I think my sister Baita just raised a comment, sharing her experience from Acholi, so we only have a question. And maybe myself, I've been fired very tough questions. But let's get from my sister. Yes, please.
Yeah, thank you.
In a second, please.
Thank you so much, Odu Felix and Medical Officer.
Who are you directing the question to?
I have two questions, one to Dr. Undo, and the other one can be co-answered by Dr. Kajimo and Dr. Nathan.
Proceed.
Yeah, the first one to Dr. Undo. How were you able to start the implementation of the new health structure to optimize more functionality in KCCA, where now we have increased numbers in Kiseni of medical officers, and they are able to perform cesarean sections during day and night? This would help other regions learn from you. The second question is, what mechanisms has USA put in place to ensure that at all costs the programs that are introduced like IRR, collaborative, helping babies survive, high-risk clinics, survive and thrive? Because we have seen that when partners leave, these programs tend to end with them. But do they have what they will be doing to ensure that at all costs, this baby that is now walking can run? Thank you.
Excellent. And I'll start with my sister. One, to thank you for coming all the way from Nairobi to learn with us. And I know we have other countries here. And for me, colleagues here, that's very powerful if we are sharing that across our different countries. There are three things: system, processes, teams. If we have an innovation, if you have a system, a catalytic mechanism that is going to cause change, we must ensure that we have a system in place that is going to absorb that catalytic mechanism. We must ensure that we have the team. The teams must be in place. They must be of a very positive mindset. They have to share the vision with us. And three, we must ensure that we have the processes
the political will is very, very important. So regardless of the intervention or the innovation that we are creating, for as long as we have evidence that is going to make a change, we must ensure that those three are in place, and the rest will follow. Leadership, governance, and accountability are very, very important. My brother.
Thank you, Chair. Just a quick one, an earlier question on sustainability. We know that a number of interventions, including MPDSR, can not fail to board because the support, technical support coming in from FHI is supposed to be coming to an end. It is not excusable at all to have any reason why we cannot sustain MPDSR. But also under CPI, we know that MPDSR is a key parameter which is assessed. So we intend to write on all those measures which aim at strengthening sustainable facilities to ensure that some of these initiatives are sustained. The question on scaling up, remember, for the public ELF facilities, easier to sustain. For the purely private, we have to scale up because there are many. Not all of them are on board. But whenever during this MPDSR reviews, we track the referral route, the mother to, and we quite often end up at the private facility where the delays challenges were. And there's no way we can run away from that. We shall have to do it because we inspect these facilities and ensure that they are compliant. We also have that we can close some facilities, and we've done it a number of times before.
Thank you.
Now, on the question of paramedics in the ambulances, as you are aware, you could be aware that we have a well-described ambulance operating system for Kampala, but we started with what was available. And the first thing was having the call center, having the ambulances, having the dispatch teams on board. We have provided for these cadres in the revised structure which we are pushing, and we think that is the more sustainable approach. In the interim, our call would be to an implementing partner coming on board if they can pick on a paramedic for specific ambulances, though there are not many, we will be able to address that. Finally, on the issue of the structure, I think the question is how did we succeed to get the numbers improved so that we are able to operationalize this, including higher cadres. We did a wheezing study, workload indicators of staff need as a justification, a basis to make a case. For the obvious reason that the numbers are not distributable. We have seen all this in the MOH annual reviews that we are seeing so many persons. And therefore, there are various structures for a mobile health center cannot operate in our setting. And this was the basis, and it was easy to justify, and when it was provided with the way to do it, then the Health Service Commission did their work.
Thank you. My brother, Richard, you have 1 minute, please.
Yes, so for sustainability, I think we've demonstrated that. And the thing is, the government structures must be that. I know that all of us attend MPDSR meetings, and you have no idea that MCHA was behind the initial steps. You now have a Zoom link that is offered by the Ministry of Health, so long as FHI 360 Zoom link. That is sustainability. You have Bruno calling you and running up to you and reminding you he's not an FHI 360 employee. That's sustainability for me. For IRR collaborative, still, when we had discussions, they are being led by Crucible from the Ministry of Health and Elizabeth Namakal from SCAP department. They meet on a weekly basis. That's leadership, that is sustainability. the government taking over what we have started.
Thank you. A round of applause, ladies and gentlemen, for this very, very powerful team. And we can proceed and take up the seats. We are going to the close of this very, very powerful session, ladies and gentlemen. And without any further ado, allow me welcome remarks from USAID. And they will be delivered by the representative from USAID. The floor is yours.
Good afternoon. Thank you for having me here. And maybe I should just remark about the energy that's in the room right now. It's almost palpable, but it's a little emotional as we look at all this action that's happened. And I just want to recognize that. My name is Marianne Mbija, and I'm making remarks on behalf of the U.S. Embassy. All protocols observed to our ministers in the room, our directors from the Ministry of Health, commissioners and assistant commissioners, our representative of the Director of Public Health, KCCA, and our heads of agencies across the UN, as well as representatives of our implementing partners, civil society, and of course all the advocates, the allies, who are all here to support Safe Motherhood. I come here to represent the United States Agency for International Development. I'm a Deputy Office Director with USAID. As I said, my name is Marianne Mbija. The U.S. government recognizes that a healthy population is a foundation for every country's social and economic development. And therefore, every year, the U.S. government here in Uganda actually invests over $500 million in Uganda's health sector. And I'm pleased to be here on behalf of those investments. Today, actually, we're marking just 5 years of investment in collaboration and efforts for this project, MNCHA, and I'm deeply honored and inspired to be here to recognize those achievements. They're not small, as you just heard from all those presentations. USAID's Uganda Maternal Child Health and Nutrition Activity is full of stories and lessons and relationships and partnerships and results and data and learning that have showed exactly how powerful our dedication can be just by working together to make progress. We thank you for your dedication to Safe Motherhood. We also recognize at the U.S. government that overcoming barriers to access and use of quality reproductive, maternal, newborn, child, and adolescent health requires resources. And not all districts are similar. We've heard about how the urbanization here in Kampala has really affected how services are delivered. So in response to this, in 2020, USAID actually invested $26 million towards this activity, which will end in December. And it's all about improving health outcomes across Uganda, but especially here in Kampala. And there are 5 lessons I want us to take away, because we just heard so many great and interesting pieces from the experts who've been part of this process. But from us at the U.S. government, there's one, that policies and guidelines are crucial for the standardization, but they really require resources after the development, because after all those debates in the boardrooms happen, we have to get to work to actually implement them across the country. 2, data-driven decision-making really helps target interventions in high-burden areas. All the dashboards and data that's there, we have to keep using it to drill down to where young women need the most support and how we help there. 3, I would say service delivery is tied to strong governance and leadership at all levels. We've heard that directly today. And that 4, a resilient health system can actually withstand adversities. And I want to say for this project in particular, this included COVID-19, Ebola, and even the current Mpox outbreak that we've seen here in Uganda. This project could have been disrupted multiple times, and they not only persevered, they contributed to the response and were engaged throughout, and we really appreciate that. And 5, I think we haven't heard it enough. I think it's going to continue to be a conversation about how we leverage the private sector and those partnerships to continue to sustain the gains. At Kampala's health services are driven by the private sector. And so if we don't figure out how to unlock that, we won't get further to achieve the goals that we need to make. So I'm inspired by the incredible work of our partners, especially frontline health workers. I know most of you are in the room today. These really are tireless efforts in achieving remarkable results. We really are proud to be part of this. And while we have made progress, we do recognize that there definitely is more to be done for small and sick newborns to receive the care they need. We recognize that neonatal mortality has stagnated over the past 15 years, not just the past 5 years. It now surpasses pneumonia, malaria, and diarrhea as the leading cause of death among children under 5 in Uganda. To address this, we really do believe we need to invest more in high-impact newborn care, including neonatal nurses, equipment, transport, lactational support, including human milk banking, and the follow-up of discharged newborns by community health workers, along with integrated community case management and continuous capacity buildings. As partners, we need to continue to align efforts to prevent deaths. And the data tells us that we actually can make progress with quality services because we can address birth asphyxia, prematurity, and sepsis. We have the tools, as we know. On the reproductive health side, I can't not speak about high teenage pregnancy rates, which remain a challenge. I applaud the efforts being made to increase accountability on the issue. And the U.S. government is investing in multiple programs for adolescent girls and young women through the DREAMS platform and also through a group antenatal care model. However, we really think this problem requires a continuous multi-sector approach that involves all of us, whether it's development partners, community leaders, parents, young people, and the ministries to really tackle this root cause of the issue. As the U.S. government, we remain committed to support Uganda's efforts to reduce preventable deaths for mothers and their newborns, as well as drive lasting change for urban, poor residents of Kampala. We will also continue to work with partners to ensure healthcare services supported by the U.S. government are free from discrimination and provide access to all populations, including key populations. And I'm confident that the conversations we have here this week will lead to tangible improvements for mothers and children across Uganda, just as they have in the past years. And I urge the government of Uganda to adopt and sustain the valuable lessons learned from this work, such as the maternal and perinatal death surveillance response, ensuring accountability for the care of every mother and newborn, and utilizing these very effective networks to approach the gaps in quality service delivery, including nutrition, and engaging more meaningfully with the private sector. So thank you all, and I appreciate all your support.
I don't think that's enough round of applause for you. We greatly appreciate the support that the US government is giving to the sector. Now, finally, allow me to invite our chief guest for this session, and that is Honorable Josephine Bebona, the woman member of Parliament for Bundi-Bujo, but also very importantly, the chair of the Committee for Safe Motherhood in the House of Parliament. To give her remarks, and we shall launch our key documents after her speech. Honorable.
Thank you, Doctor, for giving me this opportunity. Good afternoon to you all. I also follow the earlier on protocol, which has been observed by the other presenters. Like they have told you, my name is Josephine Bebona Babundi, the woman MP Bundi-Bujo District, and I'm serving my second term, and I'm also going to look for another one. Yeah. So I'm happy to be here and I take the honor to welcome all of you. I must say this is a very, very rich engagement. We are having almost, I think, all the partners, all the implementing partners, all the midwives, and all the representatives of different agencies, and also all those who have represented different regions. Thank you so much for taking off your time to be here. And thank you so much for coming to participate in this engagement, where we are all sharing experiences so that we can see how to improve, so that we can see that no mother dies when giving birth, and we also reduce the numbers of the children who are dying in our facilities and in our communities. We thank the government, which is working very closely with the different implementing partners, and which is also working with Parliament, of course, because as parliamentarians, we play a very critical role in shaping health policies, allocating the resources, and ensuring accountability. We engage with the ministers because they are also supposed to give us the accountabilities when we appropriate funds for different sectors. Our engagement with them is very essential in driving forward the agenda for improved maternal, neonatal child and adolescent health outcomes. And now we are here. The theme today is about community engagement. To me, I think it has been very good. The one who chose it, we really give a round of applause, because this is the time we move away from our towns, we move away from our offices, we move away from our comfort zones to go and engage with the communities to make sure that all of us participate in improving the health in our communities. Now, recently we had an engagement with the religious leaders. We're also telling them, go out there and preach the gospel, but again, we don't want any mother to die when giving birth. We don't want the children to die. You know, for them, the mobilization is very easy. For them, the people come to them every Friday, every Sunday, every Saturday. People continue coming to them year after year. So their engagement with the communities, talking about health issues, is easy for them. Unlike for us politicians, when you call for a meeting, you know what it means. But we also have different forums. We have very many platforms at barriers, at functions. We can also talk about it. We also encourage our colleagues to talk about health issues and so many other things. We also engage with the cultural leaders to talk about health issues. So all of us are working with the communities. I must commend all of you who are making sure that we work with the community to reduce the numbers, to make sure we improve our health systems, not only waiting for government efforts, not only waiting for the funding. We can prevent at community level, we can prevent even at low cost, by the way. As we allocate these budgets, as we allocate these funds as members of parliament, sometimes we are let down by government. Sometimes we have the gaps, the insufficient funds because of the budget cuts. So when the government fails to implement the signed instruments, let's say, for example, we can say we want the health budget to be at this percent, and we fail to reach that percent. That means we are failing to implement the signed instruments. So the gaps will remain there, the challenges will remain there, but all the same we cannot get tired. We shall continue talking, we shall continue engaging all the agencies so that we see where to close the gaps. Now, so many presenters have presented, and I only noted some of the few things For example, there was an issue of follow-up after discharge. Follow-up after discharge. But what of on admission? Are the midwives, are the health workers there on admission? The issue of absenteeism came, someone talked about it, but it is still also a very big challenge. I am the midwife who is an MP and who is hands-on. I'm always proud to be a midwife. I've always been proud. I am the midwife who trended on social media and on TV in 2019. The midwife who delivered a baby in Chikube district. We were on field visit. It was around 4 p.m. And this was the health center, but there was no one on duty. So because the houses for the midwives are within the facilities, or they will think that they are on duty, there is no one, like the duty is not busy, and they step out, but here comes a mother who is in second stage of labor. You know what it means. And this is what exactly happened. I had to swing into action, quickly rush, put on gloves, put the mother on the bed. By the time I prepared the insurance and want to use, the baby's head was up. And what could I have done? I delivered this baby very successfully, and by the time the midwives came around, we were there breastfeeding our baby in bed. Yeah. So, sometimes absenteeism, the way we attend to our duties is also very, very important. And since then, I have not stopped delivering mothers. I have been a member of parliament now, coming to 10 years, but when I'm in the village in my constituency, I continue doing these services to the mothers. Because before I joined parliament, I served for 18 good years. I have seen some of my OGs around. Welcome and thank you for coming. So they were telling me, now you cross to politics. I said, but still, the skills are still in my hands. Because I believe even when I leave politics, I can still continue to help out these mothers. Now, the issue of teenage pregnancies also came out, and it is still a challenge to all of us. That is why we are engaging the cultural leaders, the religious leaders, and all of us. And for me, as we enjoy sub-region, we still have, I think, very, very high numbers on top of the Busoga region. I think it also has high numbers. But we are still continuing to talk to the parents, talk to the teachers, everywhere. And not only talk to the girls alone, but also talk to the boys. Because this teenage pregnancy is caused by a boy or a man. In most cases, they are young boys, not even to the age of taking a woman in, you know. So that is still a very big challenge, but I know we, all of us putting our hands and heads together, we shall make it and we shall see how to improve on various gaps which we have identified. And I know from this conference, all of us, at least someone has gotten a message or something to learn or something to go where we are working and improve on those gaps. As we also continue to engage government to make sure and continue pushing a little bit on our budget allocations for the health sector. Now, I'm here to officiate on the national launch of some of the documents which are going to help us as we continue with our work in our communities. And I take the honor maybe to call upon, I don't know whether Doctor is the one who's going to tell me people who are going to join us so that we can launch these documents and therefore be disseminated to various entities. I thank you so much and thank you for listening.
Thank you very much indeed, Honorable yes. we have launched. And ladies and gentlemen, as we position the documents, I would request to have the USAID representative by the front, SCCA representative. Let's have the MCHN team. Let's have Dr. Dan Dropera from MOH, the chair of ADHOs. Let's have the chair from DHOs. Let's have the conference chair. Let's have Professor Pius Okong, the chair for the health committee. Let's have a representative from ELMA, WHO, UNFPA, and UNICEF, and we take on this very powerful process. Yes, we're just going to sign against the documents. Yes. Dr. Kenneth, let's have the markers. Let's have the markers. Very good. And my brother, there when you come and just say a little bit as we sign the documents, just a little bit about each and every document. Let's also take that as a very powerful photo moment for us.
Thank you, Dr. Jeffrey. Good afternoon, everyone. I want to stand on the existing protocol. I want to take this opportunity to present to you the key documents that we are signing off today. First, the newborn situation analysis, which is a comprehensive report that has been developed by the Ministry of Health with support from our partners, led by the Maternal School of Public Health team, highlighting the key gaps and areas of improvement needed for the country to reduce newborn mortality. We know that we have made minimal progress in reducing newborn mortality, currently standing at 22 per 1,000 live births. And we need to move twice as much as we've been moving in order to achieve our target of 12 per 1,000 live births by 2030. So this report highlights the recommendations that we need to take as a team in order to be able to achieve this target. The second document is the National Implementation Strategy for the newborn and child health. This is a revision and update of the child survival strategy, which was developed from 2010 and 2016. We know that through this strategy, we are able to reduce the different areas that were highlighted in this strategy. We are able to contribute to the reduction of child mortality from 9 to 1,000 live births in 2011, currently at 52. But again, more needs to be done. But most importantly, in this strategy, we're also focusing on the aspect of child development. As we are continuing to reduce more child mortality, a lot of effort is needed to be put in the way how the children are developing in order to be able to realize their maximum potential. The third document is the USAID MCHN legacy document. I think we've had a presentation from Dr. Agnes and the team. And at this moment, I want to take this opportunity to congratulate Dr. Anita and the MCHN team for successfully implementing the MCHN project and the great support that we've offered to the Ministry of Health. Great appreciation to all our partners, UNICEF, USAID, MCHN, ELMA, and WHO for supporting us in having this work produced. Thank you.
Amazing. Just quickly, all participants of the program STAM at UCU Mukono University, let's kindly meet at the entry at the photo booth. We'd like to take a quick picture. All participants of the program STM at UCU kindly meet at the entry for a group picture. Okay, we're now going to have a photo moment after the signing. We're going to request our guest of honor please to step behind with the entire team, and then we'll have a group picture.
But surely, it's supposed to
I think let's have the group picture and then we shall be signing at leisure when others are done. So collectively, let's take the group picture.
Let's have a photo moment and then we can all right.
Did you also take me a picture? Please, please.
As we take the photo, and the photo is going to be for only the colleagues at the front. The rest of us, we can proceed and enjoy our lunch as we play our second video on the urban tour. Second video on the urban tour. Our next session, the breakout session, will be starting at exactly 3. So just look at your program book and see which breakout session you want to go to, so that by 3 you're there to listen into the very powerful abstract presentations that will be made in those sessions. I thank you very much.
olw'okuba nti nali lubuto omwana nga yeetiise mu lubuto ngenda okuddayoko ku myezi 9 omwana nga bangamba omutwe guli mu sayidi agenda ate leero amagulu gali wano bwe wati ku lubuto then omutwe guli mu sayidi tegunnabako otereera kadde nemba ndi awo nga ndaba mpudde ebintu bya breakfast ngenda okulaba nga kugenda kubintu mulemu kumasa ngenda okulaba nga okuyanga mbuyidinga so nga ate nali sirina bulumi bwonna nenkubira omwami okuba nti yalina ngamba aliko walaku nenkubira mulala wange ate atwalako mugala nane nkubyalalo waka nebateeka kataana ebantwala the biggest death was always Mother died in blood. Blood is blood. So that is why you say MCH came in very because they now started telling us stories. They started strengthening the audit system. And when you understand the audit system, you come up with recommendations. What are the aspects and how can I prevent the next step? What was the actions on this program? The key innovation, one, is infertility coordination and verified communication. We put it upon ourselves to ensure that the loop is open. So that what happens, it doesn't matter if I receive a result to a bad communication, then we set up bilateral audits. And however we are auditing, we want to audit, then we sit together in the clinical webinar and discuss what are the gaps and which is the conclusion. So we have to create a partnership with to find a solution. We receive blood from the month. We calculated, these are the numbers we get, these are the expected transfusions, we shall get our blood with this excellent. And we receive blood testing, including the red blood groups. So additionally, receiving and that is how the heartbreak came in. And if it sticks out and needs blood, the ambulance is taking it until they have finished with the heartbreak. So
one
Constitutionally, the government of Uganda has an obligation to provide basic health services to its people. In line with this obligation, in 2018, the government established the Malawi Specialized Women in Neonatal Hospital. The 450-bed facility provides highly specialized reproductive and neonatal treatment and healthcare services. The 9-story, fully furnished, state-of-the-art facility, secured at the cost of 99.5 billion shillings, are verified by the government of Uganda and the Islamic Development Bank, IDB, is equipped with highly specialized healthcare in maternal fetal medicine, gynecological oncology, reproductive health, baby gynecology, and neonatology, which includes surgical and medical. Other areas include diagnostics, microbiology, laboratory and pathology, plus medical support services like pharmacy and physiotherapy, among others, as enlisted within the hospital's mission of providing and promoting access to quality specialized reproductive and neonatal health care with cutting-edge research and advanced training. All these services are offered at a subsidized fee based on the principle of cost recovery in order to maintain the specialized services for women and their newborns. On the third floor is the neonatal intensive care unit, NICU, for the newborn babies who need intensive medical care. The unit has advanced technology and trained healthcare professionals to give special care for the tiniest patients, including babies who need specialized nursing care. The unit has given a chance to babies born so small, as low as 300 grams to live. The hospital runs a specialized baby screening program for cervical cancer, which is very common among HIV-positive mothers. Other areas of specialized care include reproductive medicine, where infertility and reproductive challenges are addressed at the Diagnostic Center for Male Fertility Evaluation. This laboratory offers couples with reproductive challenges full diagnostic evaluation of male infertility and intrauterine insemination. The hospital has a powerful diagnostics division with experts in endoscopy, laboratory medicine, pathology, and radiology who use the high-tech equipment and innovative technologies. The high-tech CT scan machines use diagnosis. The services offered are cheaper and give quick results. Physiotherapy is important in women's health during pregnancy and after childbirth. The hospital has a mandate to train medical students in obstetrics and gynecology, pediatrics, radiology, and anesthesia. The hospital supports government policy of developing the health sector and reduces maternal and neonatal mortality, thus improving healthcare and service delivery.
Congratulations on your bundle of joy. Oh, she looks lovely. Dear parents, here's how to handle milk. First, ensure to breastfeed them within the first hour of giving birth. Continue to give only breast milk for the first 6 months. Then, introduce the baby to soft foods at 6 months, while you continue to breastfeed them for at least 2 years. Breastfeeding the baby will support their immune body to develop. This is the happiness experience. Oh no, it's not just like the ministry. It's support from USAID. Now that I'm giving back to my bundle of joy, I need to have another baby. As opposed to doing antenatal visits. Me and my husband have already chosen to take in a family planning method that suits us. But I didn't do. This is to allow my body to recover and to give the baby time to grow. Give yourself at least 2 years before having another child. Speak to a health worker about a family planning method that works for you. Oh no, it's brought to you by the Ministry of Health. It's support from USAID.
Hello, my name is Claire Andisuwe. I'm a neonatal nurse working in neonatal intensive care unit, also known as NICU, at Mulago Specialized Women and Neonatal Hospital. Mulago Specialized Women and Neonatal Hospital has one NICU, which is located on Stanford. NICU is a place where we admit sick newborn babies who need further management and specialized care. Well, as we enter into the ICU, everyone is advised to remove strictures at the entrance and put on clean indoor shoes which are provided. After that, every visitor entering NICU is supposed to wash hands with soap and water. This is very important and is continuously observed, control infections in the NICU. In NICU 1, we admit babies who are born from outside this hospital and are referred here for further management. They usually with different cases, those with neonatal sepsis and also neonatal jaundice that need phototherapy treatment. In NICU 2, we admit sick town babies who are born from this hospital. Some are very sick and need mechanical ventilation to support breathing and need cosmetic. Others are admitted for observation in case they do not score well. In NICU 4, that's where we admit extreme preterm babies and preterm babies.
These babies are cared for in servo-controlled incubators or under radiant warmers if there are still many procedures that are being done on the baby.
No, the lines are long.
During admission to the NICU, babies are transported in a neonatal transporter which has a neopub and an oxygen cylinder and a mobile baby warmer, which is very important to keep the baby safe and warm as they go to the NICU. On admission, preterm babies are placed in servo-controlled incubators or radiant warmers that control temperature regulation of the baby. A team of specialists assess the baby's condition and plan of care is documented. Parents of babies admitted in our NICU are an integral part of care. Therefore, they are involved at every stage of care provided for the baby. All the babies' vitals are monitored throughout their stay in the NICU, and the NICU team is able to respond to any alarms very fast. The servo-controlled incubators keep the baby's temperature in the normal ranges of 36.5 degrees centigrade to 37.5 degrees centigrade. This is effectively achieved if the temperature sensor of the incubator is connected to the baby and the temperature is set in the baby mode at 36.5 degrees centigrade and the air temperature set at 34 degrees centigrade. We use monitors to check the heart rate of the baby's oxygen saturation, which is given as SpO2, and blood pressure of the babies. These are connected to every baby on admission to help the team monitor the baby's well. Preterm babies need a conducive environment that supports continuous growth and development.
How will I get them?
Every organ of the baby, for example, the lungs and the brain, continue to grow even after birth. Therefore, it's very important that our NICU provides all the necessary conditions to ensure that every parent goes home with a healthy baby with good quality of life. Babies are swaddled well, provide warmth and comfort and safety as if they are still in a mother's womb. This also promotes muscle tones and they are able to go through normal process. Parents participate in feeding, which is via the nasogastric tube or orogastric tube. This feeding is done 2 hourly or 1 hourly depending on the baby's condition. The parents can also start kangaroo mother care or kangaroo father care when the baby is unstable. Usually at 4 weeks, there are routine checks which are done to ensure that everything is okay before the baby goes home. After discharge, the parents are supposed to come to the follow-up clinic, which is located on level 1 every Tuesdays and Thursdays. It is important that growth and development and home-based care are still closely monitored even after discharge from the NICU. Parents still need support in caring for the babies and advised to come back to NICU at any time whenever they see any change in the baby. These babies are seen weekly in the kangaroo clinic or follow-up clinic, and later the follow-up days can be adjusted according to the baby's condition. Usually the babies are discharged from the kangaroo clinic at 2 years. To all parents who have their babies in ICU or Uganda special women and neonatal hospital, I would like to encourage you to have confidence in us because your baby is in the best hands. We are a team of highly trained specialists, nurses, doctors, and social workers who are committed and dedicated to ensure that your babies are very well taken care of and to ensure that you go home with a healthy baby. To all those who need NICU care services, please don't hesitate to come to our NICU at Motherhood Specialized Women and Neonatal Hospital. Thank you.
Hi, I'm Dr. Linka Morase. I'm a pediatrician and the head of the neonatal intensive care unit here. So you're welcome to the NICU.
Hi, I'm Init Kwanda. I am an assistant nursing officer. I'm happy to work here in NICU and I'm passionate about this disease.
I'm Sister Agnes Chirikumuino, one of the nurses working in the neonatal intensive care and Lago specialized care unit. You're most welcome as we care for our small babies and we go on with the ongoing care, keeping them warm, feeding them, keeping oxygen in. Thank you so much.
My name is Anatija Perez. I'm a nurse working in NICU. I've been here for quite long. I think I'm the judge of the unit.
Manya yampana kiboneka Rozi, ndi mufumbo, nina abaana bana, ndi mulimi, ndi mukyala mulunzi. Musawo Rozi yeni, namumanya ajjanja ku baana bange, wakati yalinga family doctor. Musujja we gujja, yukira munye. Family planning, azika wenziza akalira wonna. Twakoosaka ne tukola, ng'omwami tansiriza. Then ninjja ne mwekira muganja ng'obulire ku mwami family tazaagala kibi kyate abaana najja n'amubuulira omwami nakkiriza. Abaami okubeera n'obuvunaanyizibwa mu kintu kya family kusobola okujjukiza wanganze wange olw'omwanjukiza kannyamba so myezi giweddeyo oba oliawo obulungi weerabidde n'okugamba kangende kuzaku ku musawo wankubadde mpozi manya kati omukyalo tubeera ddize oyinza okwerabira musawo oluusi najja n'ambuulira nakubawo eri emyezi giwedde oba nedda ekintu kikulu okukola family planning kubanga embeera nga woogiraba abaana awo singa oba obagattika tekiba kirungi nnyo kyetagala bawa space nosobola onaasoma onaakolaki onooyonsa entereza ya musawo ziri yo nnungi kubanga nebubeera kiro ogenda bugenzi musawo nze mami njiguliraawo omwana alwadde omwana akola omwana leki atugamba atwanguyiza nnyo okusingawo n'okuteekamu transport n'ogenda embaali n'ogendawa ono ye aba atwanguyiza nnyo wano.
Despite significant improvements in the global under-5 mortality rates over the years, many Ugandans still die of preventable but treatable diseases. In Uganda, primary health care has been the key means to addressing and diversifying some of these health services at the community level.
It is important to note that the government of Uganda and its Vision 2040 and the National Development Plan call on sectors to take advantage of ICTs to optimize service delivery.
Evidence shows that community health work programs are a cost-effective and efficient way to increase access to primary health care, especially in resource-limited settings.
the VHTs are a health center one, meaning they are the first contact people in the community make with the health system. And in most cases, they do pre-referral treatment and then they do community campaigns, but they are also very important in mobilizing the community to help. For example, immunization. But recently, they have been very important in educating the community on COVID-19 and also drawing up support for COVID vaccination.
But despite committing to allocate 50% of government budget, Uganda has struggled to fulfill this commitment, with the health budget remaining stagnant between 6% to 9%.
We commend the government of Uganda, the Ministry of Health, for prioritizing community health, but we urge the government to increase budget allocation for community health.
In 2022, the Oyam District local government, Living Guilds, and Malaria Consortium agreed to collaborate and leverage their respective capacities to co-design, co-implement, and co-invest into supporting the strengthening of community health systems through holistic performance management of BHTs in the public sector.
The digitalization of the VHT has helped us so much to improve on the quality of their services. I was in church, I can survive VHT even at night, even over the weekend, at any point, because I have the phone which I can just log in and see in this VHT that log up to you about 32 of them, how many are what, how many don't work. It has helped to give us support timely on the third one. It has helped us for referral. Through the assessment, diagnosis, and management, it gives us real time data which we can use for referral emergency cases and also to check on the stock level so that we can replenish all the feed the need in the communities.
In Oyam District, BHT spent at least 5 hours traversing the community, diagnosing, treating children under 5, offering antenatal and postnatal care to women, and making referrals to health facilities for family planning and vaccination.
Well, definitely want to do mobile malaria. Ahora me referenciaron. Kind of more common, one for me, no copy to share a more than 2 years. No answer, no me or power, and to work therapy by center.
Although there has been progress in areas of reporting, supervision and using of data for decision making, more needs to be done to increase medicine qualifications for VHTs so they can treat present conditions in the community and to standardize the conversation.
All along we have communicated we have decided to say part of our money which we get and which money is the PHC grant. That part of the money is taken from what it should be doing in the health facility and directed to support motivation of this community work.
During their visit to Oyam in May 2022, the Health Committee of Parliament witnessed the impact of effectiveness of VHTs when they are well supported and motivated to serve their communities.
And it's quite hard for the health centers, the nurses, midwives to work progressively. The only people who can be helped, who have been involved in Oyam, are the village executives.
We have seen a result-based program actually taking place in the ground. We've got all the briefing that has been happening, and we have seen that actually digitalizing VHTs is the way forward.
To achieve universal health coverage and ensure that everyone can get the health care they need, no matter who they are or where they are, the government should support more VHTs who have the capacity to reach everyone in the community and have been proven to have a high rate of return on investment.
It's my humble appeal that the government of Uganda and us legislators should allocate some funds that they should get in terms of salary. We could start with 100,000.
Our role as a parliament is to allocate funds, more funding to the ministry. But of course, when we put in the request for funding, we are there to support.
No, why? Where many work in Germany, me work on many people Europe. That way, I don't want to find a computer compared to the one who learn now. I don't want to go forward. But it's like, what I mean is that is what I mean.
It's a stark reality. The world faces a critical shortage of health workers, leaving countless without the care they urgently need. This challenge is especially pressing in Africa. Sub-Saharan Africa, with over 1.2 billion people, has just 3% of the world's health workforce, but shoulders 24% of its disease burden. To combat this need, Seed Global Health has been invited by the governments of Malawi, Sierra Leone, Uganda, and Zambia to address their health worker shortage. Partnering with universities, schools, hospitals, and clinics, we focus on educating the next generation of doctors, nurses, and midwives, strengthening care quality, and improving health outcomes for millions across the region.
SID has trained more than 42,000 health workers who are in service to over 76 million people in Sub-Saharan Africa.
Our work isn't theoretical. We are on the ground, in classrooms, clinics, and communities, building the health workforce of the future, one country at a time, one community at a time, one person at a time. Our day begins in the classroom. In partnership with Makerere University and Mulago Hospital, Seed Global Health trains emergency medicine doctors because in a country of 50 million people, there are currently just 13.
We realize that there are so many cases of patients who die just because there are no people who are skilled to handle those emergent cases.
By focusing on academic excellence and hands-on skills, we are building a resilient health workforce in a country in critical need of their expertise.
The 12 lead gives a full mirror image of the heart. SID has done a lot. I was trained through SID Global Health, and now I have come back to the university to train others and create other specialists.
I'm really grateful for what SID is doing here because it's bringing many people on board, equipping our field with many personnel who are skilled to do the procedures that are really life-saving.
Got it? Yeah, you will never forget this, even when you become a specialist.
"350 kilometers from Kampala, at Lira Regional Referral Hospital, midwives trained with SID support at the bachelor's and master's levels are conducting rounds in the maternity ward, serving a hospital that supports over 2 million people in the region.
The mothers who come here for delivery, some of them come from 100 kilometers. This hospital serves more than 3,000 in a month.
Here, demand is constant, and the need for highly trained midwives is critical.
I'm proud to say I'm a pioneer bachelor midwife. SID Global came in to support us at school when I was a student.
The partnership with SID Global Health came at a very right time. We needed to have the capacity to train our students. SID Global Health has not only touched us as the institution, but has also touched the community around, supporting community outreaches where we reach out to the community directly and provide services.
You're seeing our mothers are smiling. They are happy because they are getting quality service.
After lunch, a team from Lira University's Community Midwife Program arrives at Ogutowelo Village, home to more than 30,000 people.
We are going to check on you and we are going to check on the baby.
Women who deliver at home, one, either they die during delivery or the children that they're delivering die. The sort of need for the midwife to come on the ground to the community.
News of their arrival spreads,
and over a dozen mothers, some expecting, others with newborns or small children, gathered to learn from the Master of Midwifery student about family planning, nutrition, and other vital topics.
I want to talk to you about the importance of breastfeeding.
Engaging with the community and understanding patients on a practical level is a mandatory step for his graduation.
So if you have that chance to give that correct information, utilize it and make someone better. That's the passion I get from it.
You see your student doing very well. You have that sense of pride.
As the afternoon sun lowers, Dr. Joseph Emoron, Director of Katapi General Hospital, is training one of the first emergency response teams in this part of the country.
I used to get a lot of reports about how poor emergency services were, but currently that story is changing. And basically because we created a team that can rapidly respond to those emergencies.
Educated with safe support, Dr. Emoron, one of Uganda's first emergency medicine doctors, has returned to his home village, fulfilling a childhood dream of becoming a doctor.
My hope for this hospital for the next 10 years is that we are delivering better emergency care for the community. Also, we want to be a role model in the country where other people can come and learn.
This is one of our new ambulances. Been able to go to deeper areas. This ambulance has saved a lot of lives.
His efforts have caught government attention, with consideration to promote his hospital to regional referral status, a testament to his leadership and critical role of developing skilled health workers. After all, how can we hope to achieve universal health coverage, combat the next pandemic, or address the health impacts of climate change without them?
Our goal as a country is to build a strong health workforce that is responsive. We know that all the other pillars of the health system are going to rotate on how good the human resources for health are.
You may have the hospitals, the vaccines, but without the health workers, you cannot deliver. SID comes in a very critical role because we train highly skilled health workers. Really, our mission is to advance the health workforce as a global priority.
Similar days unfold across the region, and whether in Malawi, Sierra Leone, Zambia, or Uganda, we're collectively proving the power of our model, that training skilled health workers strengthens quality of care and improves health outcomes for millions across the globe. Together, we are building the health workforce of the future, one health worker at a time, because health workers save lives.
Health workers save lives. Health workers save lives. Health workers save lives. Health workers save lives.
Good morning, good afternoon, good evening, everyone. From wherever you're watching us, my name is Enid Kawala, a public health social scientist, senior graduate fellow at Munyonyo University, and a PhD student at the clinical epidemiology unit at Maternal University. I'm here to bring you some of the things that we realized or we found at the TBA sites as I was trying to conduct a study on traditional birth attendants in eastern Uganda. I delved into the practices, management, and what they use in management of these obstetric complications within the community. And I happened to interact with the traditional birth attendants, the community, but even mothers that have really had their deliveries or even attended any or gotten any services from any of these traditional birth attendants. So while I was moving around, I met this mother who had already sought care from a TBA, and here we find her being examined by the TBA, and she was almost due, almost ready to give birth. So she's there, and the TBA was quite kindly trying to palpate her and examine her. So I moved to another TBA who was called the champion of TBAs. And she is here trying to show us some of the traditional medicine that's used in management of these obstetric complications, and that is some of the medicines in her jerrycan there, though with the ID tested. She showed us her delivery bed there, and there's another delivery bed there that we found at one of the TBA sites. And that is it. And then there's another medicine trolley there. We can see a stethoscope and other traditional herbs there. So we found another TBA. They are seated with other mothers during antenatal and took us through some of the traditional herbal medicines she uses in management of these complications, like what she uses for obstructed labor, augmentation of labor, and she showed us some of the bottles that she uses to back this medicine. Those are other trolleys that have some of the modern medicines that they use in management of these complications. Here is the TBA site, and this is one of the TBAs who is taken to be like the Kawempe of TBAs in Mayuge. So you see she has 2 houses or 3 houses there, but one is a delivery room. That is her placenta pits were constructed, and we found some fresh placenta there. But you could see we asked her a lot of questions. So after showing us that, I had to come there to be examined, and she told me I was a 12 weeks pregnant, which was not right. So there's another TBA there trying to show us how she uses the barrier method to dispose of the placentas. Then we found some other TBAs with some mothers, like that one was taking some traditional herbs to prepare her for delivery.
Utilization of data. PS, a lot of it is upon the true data. And just last night,
critical shortage of health workers, leaving countless without the care that urgently need. This challenge is especially pressing in Africa. Sub-Saharan Africa, with over 1.2 billion people, has just 3% of the world's health workforce, but shoulders 24% of its disease burden. To combat this need, Seed Global Health has been invited by the governments of Malawi, Sierra Leone, Uganda, and Zambia to address their health worker shortage. Partnering with universities, schools, hospitals, and clinics, we focus on educating the next generation of doctors, nurses, and midwives, strengthening care quality, and improving health outcomes for millions across the region.
SID has trained more than 42,000 health workers who are in service to over 76 million people in Sub-Saharan Africa.
Our work isn't theoretical. We're on the ground, in classrooms, clinics, and communities, building the health workforce of the future, one country at a time, one community at a time, one person at a time. Our daily begins in the classroom. In partnership with Makerere University and Mulago Hospital, Seed Global Health trains emergency medicine doctors because in a country of 50 million people, there are currently just 13.
We realize that there are so many cases of patients who die just because there are no people who are skilled to handle those emergent cases.
By focusing on academic excellence and hands-on skills, we are building a resilient health workforce in a country in critical need of their expertise.
The 12 lead gives a full mirror image of the heart.
SEED has done a lot. I was trained through SEED Global Health, and now I have come back to the university to train others and create other specialists.
I'm really grateful for what SEED is doing here because it's bringing many people on board, equipping our field with many personnel who are skilled to do the procedures that are really life-saving.
Got it? Yeah, you will never forget this, even when you become specialists.
"350 kilometers from Kampala, at Lira Regional Referral Hospital, midwives trained with SEED support at the bachelor's and master's levels are conducting rounds in the maternity ward, serving a hospital that supports over 2 million people in the region.
The mothers who come here for delivery, some of them come from 100 kilometers. This hospital serves more than 3,000 in a month.
Here, demand is constant, and the need for highly trained midwives is critical.
I'm proud to say I'm a pioneer bachelor midwives. SEED Global came in to support us at school when I was a student.
The partnership with SEED Global Health came at a very right time. We needed to have the capacity to train our students. SEED Global Health has not only touched us as the institution, but has also touched the community around, supporting community outreaches where we reach out to the community directly and provide services.
I see our mothers are smiling, they are happy because they are getting quality service.
After lunch, a team from Lira University's Community Midwife Program arrives at Ogutowelo Village, home to more than 30,000 people.
We are going to check on you and we are going to check on the baby.
Women who deliver at home, one, either they die during delivery or the children that they're delivering die. The sort of need for the midwife to come on the ground to the community.
News of their arrival spreads, and over a dozen mothers, some expecting, others with newborns or small children, gather to learn from the Master of Midwifery students about family planning, nutrition, and other vital topics.
I want to talk to you about the importance of breastfeeding.
Engaging with the community and understanding patients on a practical level is a mandatory step for his graduation.
Just to have a chance to give that correct information, utilize it and make someone better. That's the passion I get from it.
You see your student doing very well. You have that sense of pride.
As the afternoon sun lowers, Dr. Joseph Emeron, Director of Pataki General Hospital, is training one of the first emergency response teams in this part of the country.
I used to get a lot of reports about how poor emergency services were, but currently that story is changing, and basically because we created a team that can rapidly respond to those emergencies.
Educated with seed support, Dr. Emeron, one of Uganda's first emergency medicine doctors, has returned to his home village, fulfilling a childhood dream of becoming a doctor.
My hope for this hospital for the next 10 years is that we are delivering better emergency care for the community. Also, we want to build a role model in the country where other people can come and learn.
This is one of our new ambulances, being able to go to deeper areas. This ambulance has saved a lot of lives.
His efforts have caught government attention, with consideration to promote his hospital to regional referral status, a testament to his leadership and critical role of developing skilled health workers. After all, how can we hope to achieve universal health coverage, combat the next pandemic, or address the health impacts of climate change without them?
Our goal as a country is to build a strong health workforce that is responsive. We know that all the other pillars of the health system are going to rotate on how good the human resources for health are.
You may have the hospitals, the vaccines, but without the health workers, you cannot deliver. SID comes in a very critical role because we train highly skilled health workers. Really, our mission is to advance the health workforce as a global priority.
Similar days unfold across the region, and whether in Malawi, Sierra Leone, Zambia, or Uganda, we are collectively proving the power of our model that training skilled health workers strengthens quality of care and improves health outcomes for millions across the globe. Together, we are building the health workforce of the future, one health worker at a time, because health workers save lives.
Health workers save lives. Health workers save lives. Health workers save lives. Health workers save lives.
Good morning, good afternoon, good evening, everyone. From wherever you're watching us, my name is Enid Kawala, a public health social scientist, senior graduate fellow at Maternal University, and a PhD student at the Clinical Epidemiology Unit at Maternal University. I'm here to bring you some of the things that we realized or we found at the TDA sites as I was trying to conduct a study on traditional birth attendants in eastern Uganda. I delved into the practices, management, and what they use in management of these obstetric complications within the community. And I happened to interact with the traditional birth attendants, the community, but even mothers that have really had their deliveries or even attended any or gotten any services from any of these traditional birth attendants. So while I was moving around, I met this mother who had already sought care from a TBA, and here we find her being examined by the TBA, and she was almost due, almost ready to give birth. So she's there, and the TBA was quite kindly trying to palpate her and examine her. So I moved to another TBA who was called the champion of TBAs. And she is here trying to show us some of the traditional medicines that she uses in management of these obstetric complications, and that is some of the medicines in her jerrycan there, though with the IV testing. She showed us her delivery bed there, and there's another delivery bed there that we found at one of the TBA sites. One of the TBAs showed us her medicine trolley, and that is it. And then there's another medicine trolley there. You can see a fetoscope and other traditional herbs there. So we found another TBA, they are seated with other mothers during antenatal and took us through some of the traditional herbal medicines she uses in management of these complications, like what she uses for obstructed labor, augmentation of labor, and she showed us some of the bottles that she uses to pack this medicine. Those are other trolleys that have some of the modern medicines that they use in management of these complications. Here is a TBA site, and this is one of the TBAs who is taken to be like the Kawempe of TBAs in Mayuge. So you see there's 2 houses or 3 houses there, but one is a delivery room. That is her placenta pit, where it was constructed, and we found some fresh placenta there. But we could pursue after a lot of questions. So after showing us that I had to come there to be examined, and she told me I was 12 weeks pregnant, which was not right. So there's another TBA there trying to show us how she uses the barrier method to dispose of the placentas. Then we found some other TBAs with some mothers, like that one who was taking some traditional herbs to prepare her for delivery, and that is what they called the natural oxytocin. They also took us through some of the delivery rooms, and we saw something that they use, especially in body clamping. You can see a razor blade there. We saw some injections there. And then we also saw a jerry can that was used by one of the TBA to keep her paraffin, and told us this paraffin is mixed with sugar to help in management of preeclampsia. So that is another herbal medicine that they use during pregnancy to avoid vomiting, and that is what we call a mumbwa locally. It has multiple uses, especially stopping vomiting or nausea, but there are also other mumbwa which are used in other conditions. Then those are other traditional herbs that we got. Those are some of the mothers we found who had come for delivery. Then we found some there who had come for antenatal. And they also showed us some of the other herbs that they use. That is a fodo, which had multiple uses, as explained by her. That is how they manage their waste. And you can see that some of the waste was poorly disposed of. And we found this, though she lied to us that they don't use that medicine, but there was evidence that she used that medicine. So I arrived at this TBA site, and I told her to assume I was a patient and let her try to examine me and treat me the way, tell us how she takes care of a mother. So I lied down there. She had to take me through how she manages mothers when they come. That is her delivery point. She puts that white cavera. She told me to put my lesu. I had moved with my lesu there, that blue thing, and I told her to, try to examine me. That time I had, of course, I had a bigger baby because I had just from eating sugar canes in the community with mangoes. So she also assumed I was pregnant, but I was not pregnant. So there I turn around, and then she teaches me, she tells me how she examines the mother, when the mother, the child, when you give her birth, how you put the baby, and that is how she positions her baby, and doing the skin-to-skin thing, and trying to demonstrate how it is done. Then you'll see her trying to show me how she will help me to touch my baby, and then to make sure that my baby doesn't fall off. But if you realize in the corner there is a stool with a glass of water. And that glass of water is ever there for in case any mother comes when she's ready to give birth. In case that mother wants anything to drink, she provides it and the other facilities. So now that I've delivered my baby, she's checking for whether there is any problem, She's trying to check if there is anything, you see. The stomach was full of juice. So we also visited the male TBA, and this TBA was also trying to examine, but check the environment in which the bed is, check the nature of the mattress, check everything was just dirty around. I remember I even had to live when my skirt was dirty, but that is what they do, okay? So he says that he's a TBA and his wife is also a TBA, and they survived, okay, by doing TBA work as them. So him and the wife, that is their work, and they've lived as TBA. He's the one who trained the wife, and now they become TBAs. And they have so many clients. So there's that TBA who's also trying to show us some of the medicines that they use in the community for mothers. If you want to remove, to get, she called it a diarrhea. So for instance, now like there's a common condition called the community. Deni is that is like something like a pseudosciences or post-date. Sorry, pseudoscience is something like that. Okay? You know that you're pregnant, but when you're not pregnant. Then there are also those conditions whereby a mother wants to, is pregnant, but HCG shows that you're not pregnant. Those are the medicines that she uses. Then when you look at those people who have had pregnancies that are post-date, so those are some of the conditions, the medicines that she uses. You are pregnant up to 9-10 months, but you're not giving birth. Then she gives you that. Then she also showed us some other medicines that she uses, especially if you want to change the sex of the baby, you can use that. If you want to conceive and you've never conceived, maybe you want you're yearning for a baby, but you're not in position to, you can't get it or you failed to get it. She has the medications there. Then she also had the other medications for other complications, like obstructed labor, preeclampsia, placenta previa, and the rest. So those are some of the things she uses to pack these medicines after, like especially those that we are meant to drink. Okay? Then it comes, that is her delivery bed, you can see. And on that delivery bed, you see that is the form, those are the papers that she uses to, to write in case there's anything, but she didn't show us. So I laid down to help me and examine me. But then I realized that up there, she had a drip stand, and you can see normal saline up there with the injection. So I was wondering who puts this normal saline. However, she told us she has a referral nurse who keeps checking with her to see if there is if there is anyone who needs to be cannulated, if there is anyone who needs IVs. So she runs the IVs after that nurse helping her to cannulate. So she examined me and told me that my uterus was just ready to receive a child, okay? Which is different from the first TBA who told me that I was 12 weeks pregnant. So that is the environment in which she delivers her patients or her mothers, and those are some of the things that we really noticed at the TBA sites. So these are some of the cases of conditions like PPH, which they tried to manage, and then you can see these mothers who are being examined. Vaginal examinations, she's not a very fast person to use a stick. There's another who told us that she also uses a stick, which is marked, okay, from 1 centimeter, 2 centimeters, and the like. So she inserts it into your vagina to check what, whether you have, how many centimeters you have at that point. So we also noticed other things like how they manage mothers with asphyxia, children who are babies who are asphyxiated, and there's another way they do their neonatal resuscitation, like the way they put the tail of a prolific into a baby's anus and then start blowing it. And then there are these other things whereby they told us, if you really have if you're not getting contractions, they put you on a border and tell that border to pass you in a bumpy road until when you feel like, yes, you get the contractions, then they bring you back. So there's a lot of, there are a lot of things that are being done in this TBA site. And thank you for coming for this wonderful Safe Motherhood Conference. I'll be sharing with you what the lived experiences of mothers are, those who have sought care from TBAs in one of the districts where we are doing our studies, and you will see that mothers have really appreciated these TBAs. However, they have caused more havoc, okay? Because now we have to go into the nitty-gritties of their MPDSR process. How do they do this maternal death response and surveillance? especially one of the TBAs who's taken as a national referral TBA, who had lost like 3 to 4 mothers in just 1 week. What are the challenges that these mothers are really getting, the community that are fostering or talking them to visit the TBAs? All those details we shall share them in our subsequent engagements. So that is all briefly about the TBA studies that we are conducting in the country, and we shall share all this and hope to come up maybe with cost-effective interventions and policy programs that can help us to solve this problem of the TBAs and the maternal and newborn mortality rates that we have in the region.
So this program, the midwife attached to this policy at home. I want to take this opportunity to thank Minister of Health and World Vision for the support given to this Health Center for and the mentorships given to this Health Center for to see that this Health Center for was accredited as a baby-friendly facility. We do health education to mothers about the importance of breastfeeding, the dangers of mixed feeding, and the dangers of formulas. Health education is done on a daily basis. Only when this mother, the baby is delivered from the mother's abdomen and skin is maintained. The mother is encouraged to breastfeed within the first hour of delivery, and the mother is transferred to postnatal where the mother continues with breastfeeding. Before discharge from the facility, baby is immunized, and a mother is attached to the VHT in the village. In case of any problem, VHT can go, or if the problem is beyond the VHT, the mother is referred back to the facility. Thank you.
DHI statistics in 2020 in the Health Center 3. When we came to assessment of establishments, our score was at 25%. We were taken through a training of DHI as staffs. For those who are here, and some staff that were here, but some of them were transferred away. They are no longer here with us. But we went through a training that was supported by World Vision, Uganda branch, and we're given a lot of skills, a lot of experiences, a lot of education took place as far as DHI is concerned. We gained a lot through that training, we applied through, and we happened to get continuous support and supervision from members from the Ministry of Health. In 2013, we went through another assessment. That assessment included 3 facilities in Kampala district, Airport facility, Nani and Center 3, Health Center 4, and the Civil Health Center 3. And the districts, we managed to be number 1 as far as FHI is concerned. DHI has saved us as a health workers because through the trainings that we had, we applied a lot of skills that we didn't have from our training since we are in home. We are now able to take mothers on how to do proper breastfeeding and demonstrate to them how they can do proper breast attachments. We are now able to educate mothers on nutrition.
Francis.
Why on the men? Why on the men?
Hello. Good afternoon. Can we move closer? We are in for breakout session. This is room 1. So I'm requesting that we move towards the front. Nelson and I will coordinate this room this afternoon. Presenters for room 1. Just roll call and make sure you're around. Stephen Mugisha. Present. Dr. Nabo. Okay. Patricia. Period, Patricia. Okay, Mugisha. Yeah. Okay. Please move closer to the front if you're in room 1. Okay, we are going to start off, and at this juncture, allow me to introduce our session chair for this afternoon, who is Benon Mutazzi, maternal newborn and childhood specialist with over 17 years experience working with local and international NGOs. He has provided both technical and leadership services projects with specific focus on MCH, and he's been a champion for family planning, nutrition, and WASH. He's currently the technical program lead on health and nutrition with World Vision. Benon, you're most welcome to chair this session. Thank you.
Yeah. Thank you for the humble Thank you for the humble introduction. Once again, my name is Brendan Sasizi, and I work with World Vision as a technical support lead for health and nutrition. I'm humbled to be here to coordinate our learnings from local maternity and neonatal systems. So maybe allow me to echo why neonatal maternity systems, where the Ministry of Health and the partners decided to come up with the LMNS position, regional referrals, and centers of excellence, and hubs for clinical mentorship, quality of care, maternal and newborn health, and as well strengthen collaborative accountability for RMNC service delivery, improve multi-sectoral coordination and collaboration, and then enable resilient and responsive health system. So we are basically here to take account of what progress that we have registered. I know we've had a number of reports that have indicated to functionality of LMNS and their contribution on maternal, newborn, and child health indicators. So we have about 10 abstracts that were presented to showcase progress that we have registered so far. And allow me to introduce the first 5 presenters. Stephen Wechingo, Gisha, who will be presenting an abstract on decongesting regional referral hospital by patronizing lower level CMOC facilities for improved maternal and newborn health outcome, a case of Soga region. So join me to welcome Stephen. And then allow me to welcome Dr. Nabo, who will be presenting on the impact of specialist phone consultations on maternal survival, a case of Uganda Health Center for Isingio. So allow me to welcome Nabo. Nabo, are you here? Our third presenter, initially it was supposed to be Patricia. Christopher Waswa. Allow me to invite our third presenter, newborns, interfacility and community linkages for preterm babies in Moyo district. You're welcome, Christopher. Our fourth presenter is Mugisha Busharizi Daniela, who will be presenting on reducing maternal mortality through regional local maternal and neonatal system, Lango sub-region. Our fifth presenter is Alan Chiprop, who will be presenting on using digital platforms, phone calls, to mitigate access challenges to high-risk clinics, learning from Kabong district. You're welcome, Alan. Alan, are you here? You're welcome. So we are going to have 8 minutes, and I want to congratulate our presenters for putting together abstracts and enabling us to learn from your experiences. So we shall have 8 minutes for each of the presenters in the interest of time. At 5 minutes, I'll be reminding you, and then we shall have 15 minutes of question and answer. So I will request the audience to be taking notes of the questions or observations that relate to the different presentations. So to ease question and answer and to have close contact, interact freely, I would like to request the participants in-house to come in front so that we are close, utilize the front seats and be able to interact freely. So we are going to have our first presentation from Stephen. And Stephen, you're welcome. You have 8 minutes of presentation. I remind you at 5 minutes of that. Thanks.
Thank you so much. And all protocol observed. Dr. Stephen Kinomudisha. I work on the USAID UHA as technical advisor for maternal and newborn health. And as I begin off, before I share this case study, allow me just 2 seconds to request the LMNS coordinator of the Soga region stand up for recognition together with the whole team from the Soga. Please stand up for recognition. LMNS Secretariat, they are there, and Ginger Regional Referral staff. Thank you so much for coming. I'm presenting this on behalf of what a great work the team is doing and affiliated as you have seen. Many of you know that the Soga region is one of those that have had a high maternal mortality in the country. And we've been doing data analysis, and we realized that around the late 2022, there was a rise in maternal mortality ratio in the region. And so as we started 2023, we did various interventions in order to bring it down. But before we did that, I could share more about the data analysis. We looked at the cesarean section rates at the different levels of facilities, general hospitals, regional referral, health center 4 level, and we realized that the cesarean section rate at the regional referral was rising, whereas at the other levels it was dropping or stagnating. And we also looked at we analyzed the referrals that go to these units. So we looked at the referrals to Ginger Regional Referral, and we noted they were high, over 500, but majority of them, as you can see on the slide, were due to reasons which could be handled from the lower level facilities. The topmost was prolonged labor and obstructed labor, fetal distress. All these are conditions which we know that if you send from a center 4 or elsewhere to a regional referral, you're sending unnecessarily, except in those circumstances where there are other things. So we analyzed further the reasons why these cases were being sent from lower levels to regional referral, yet they could be handled at the lower level smoke facilities. We also looked at the topmost referring facilities, and these included the ones mentioned there, and majority of them, these center 4s are in Ginger, the greater Ginger. And to note is that for the referrals that went to the regional referral, most of them, as you can see, 67% delivered by cesarean section, by normal delivery. Based on this analysis, as we saw the LMNS and stakeholders, we thought through how we can decongest the regional referral, because we saw there were clear unnecessary referrals that were congesting the regional referral hospital, and we know what congestion brings about. In the earlier sessions we talked about it, I won't go back into it. But we know the human resources, issues about supplies, etc. gets affected. So, Busoga LMNs and stakeholders set out a goal of reducing maternal mortality that we had seen had gone up to 116 deaths per 100,000 live births to below 70, and we aimed at doing this through reducing unnecessary referrals from the lower level facilities, especially the SIMO facilities. And the approach we set out to use was we looked at various things that we systems approach, but we looked at various aspects of the health system that we could address. Start with 6 of the CMOP facilities in Greater Jinja were not accredited to do blood transfusion. So later last year, that was one of the first interventions we made. We worked with the blood bank to make sure that these are assessed for blood transfusion services and accredited. We also had the leading, as you saw earlier, the leading referring CMOP facility to Jinja Regional Referral was Munyonyo Health Center 4. And the reason was because the theater was not functioning. So we secured equipment, and also we went to the General Hospital, whereas we needed another hospital within the region that was fully functioning, especially in the greater Jinja area. And so we also supported the Wembley General Hospital with the equipment. Then human resource gaps that we noted at facilities that relate with CMOP functionality, we did advocacy meetings, and then second last was on strengthening leadership. So Ministry of Health organized, working with the Commissioner of Reproductive Health Services, we had a reproductive and child health services. We had a strategic meeting organized with all medical officers in the region and all doctors in the region, together with their supervisors, and we had a candid discussion. And finally, we noted that some of the referrals were due to gaps with the capacity in terms of how to manage certain cases. This is just a pictorial, and I will not talk a lot about it, but just to mention, and I saw the ADHO, some ADHOs were around from the region. Just one picture talk about that first one on the right, on top right. That was after the first exam section at the Munyonyo Health Center 4. And in there we had the DHO, the CHO, the assistant, the LMNS coordinator attended that season, the partners, INABER and UHA, and the doctors who had just been trained in ETO. We also had an ETO training to skill them before they can start the operations. This is just sum up, and as you can see, the Commissioner of Reproductive Health Services has been participating in part of functionalizing the work we are doing. And what are the results? To start with, in terms of functionality of the CMOP facilities, we had 5 of the facilities in Greater Jinja as CMOP facilities accredited to do blood transfusion. And we had recruitments done. I will not mention details, but the human resource through advocacy, we saw districts now and the city recruit critical cadres. And then we had all these skilling activities, on-site skilling done, and in total, we had the functional CMOP facilities move from 83% to 97%. And in terms of cesarean section, the blue one, the dark blue, I don't know what I call it. The dark blue is for health center 4 level. Then the red one is for regional referral, Jinja regional referral. And then the light blue is for general hospital. The cesarean section rates across the quarters from the quarter where we started up to now. And as you can see, starting with the health center 4 level, there is a time when even the cesarean section rates at the center 4 level had dipped towards 10%. Because many of the facilities were referring. But we've seen a steady rise of 17%, and we have seen a drop in cesarean section rates at Jinja regional referral. The congestion has gone down, because remember some of the mothers were delivering by normal delivery, even when they have been referred. And we've seen, as the hospitals became functional, we've also seen general hospitals, like Wembley General Hospital and others, become more functional, and that's why you see their rate also rising. In terms of referrals, this graph is just showing the referrals into Jinja regional referral. And as you can see, there has been a significant drop of the referrals, and majority of these were unnecessary referrals. Okay, thank you, Chair. Majority of these were unnecessary referrals, and we've seen them drop significantly. We've been using a tool to track each of the referrals and where they come from, as I mentioned earlier. And significantly over the period, the institutional maternal mortality ratio in the Busoga region has reduced from 116, and last quarter it's 79. And we think we can go even lower than that. Just to note, as I conclude, we've noted that the quarterly referral tracking was very crucial because it helped us to understand which facilities are referring to the regional referral. The numbers were so huge. Those who would walk into the regional referral, you find it so crowded. So the numbers were so huge. So the tracking of those referrals that go in and understanding what are their outcomes, understanding who is referring and for what, enabled us to be able to target properly. So data-driven support was very crucial. The leadership, we considered it very crucial. And there was regular sharing through the LMNS of the learnings for those center posts. Nanka Head Center Post is here, I saw the in charge. Those are center posts which are now very functional. And we saw their learning being shared through the LMNS platform, and that enabled peer-to-peer learning. And as I conclude, we note that functionalizing center posts and general hospitals is important in the congesting the regional referral for improved outcomes, maternal health outcomes. And this can be done by functionalizing the center, reducing the unnecessary referrals, doing good data analysis, and then continuing to consolidate the gains along the way. And as part of the next steps, we've noted that there are still more community-related delays, and we think once these are addressed, especially to do with TBS, a district like Namayengo has 143 TBS mapped there, so you can see the impact that they still have. So we, as part of next steps, we think that once we address these facility and district-led community interventions, we should be able to see even a further reduction in maternal mortality. I want to end it there by acknowledging those that are listed there, most especially the Ministry of Health. As you can see the picture, we've been with the Commissioner all the time in the joint support supervisions. The Busoga LMNS, Ginger Regional Referral Leadership, and the technical team, the development agencies, the IEPs in the region, Uganda Blood Transfusion Services, and the district teams. Thank you so much. I end it there. God bless you.
Yes, thank you, Dr. Stephen and the team for putting together those experiences that you're sharing with the team here. And probably, I'm hoping you are taking notes. We shall have 15 minutes of Q&A. So observation, questions, please take note. Allow me to acknowledge the presence of our DG, Dr. Mevesa. He's here with us and has blessed this session. We shall move very fast to the next presenter, who is Dr. Naboth, and we will be sharing the impact of specialist phone consultations on maternal survival, a case of Uganda Health Center for the Single District. You're welcome.
I'm called Naboth and Naboth is my name. For Health Center for. Our topic for today is the impact. The title for today is the impact of specialist phone consultations on maternal survival, a case of Uganda Health Center for Single District. Okay, that is the impact of specialist phone consultations on maternal survival, a case of Uganda Health Center for Single District. Organizational affiliations, we have Uganda Health Center for, which is located in Single District, and then by regional referral hospital, and then we say where we have in Uganda health activity. So that is my profile. I'm Naboth Mzara. That was my employment report, Uganda Health Center for local health center for as an in-charge, and then Isinyo district as a local neonatal and maternal district coordinator. So the background, Uganda Health Center for is located in the southwestern region, Isinyo district in Kanga district, with a Catholic population of 20,100 people. Maternal mortality remains a significant challenge in many resource settings, many low-state settings, with Uganda having a mortality rate of 189 per 100,000 live births, and the seniors maternal mortality rate standing at 55 per 100,000. What do I mean when I talk of a low-limited setting? Uganda Health Center is located in a village setting, remote, with poor roads, and when it comes to human resource, at Uganda Health Center 4, I was the only medical officer, one anesthetic officer, and one theater assistant. So you can imagine, immediately after I finished schooling and I finished my bachelor's in medicine and surgery from Macquarie University, where we had enough human resource, where you could find people who call, we had the first doctor who call in case of any challenges in theater, then second and fourth and third. Then during my internship, I was at the biology and first. Still, it was the same thing. First doctor on call in case of any challenges in theater, second on call, and then third and fourth. But when I finished internship, I was posted in a village where I was alone at the health center 4. So you can imagine what used to happen in theater in case of any challenges. So what we are going to concentrate on is a case study overview of a 25-year-old mother with their 2 para 1 plus 0 TRK with one previous strap of 2 years and 9 months who came in at 41 weeks and 3 days. Came in as a referral from within health center presenting with labor pains for 8 hours associated with blood stage shock. So significant on examination, she was experienced, she had
Do we need support of IT? Yes, IT.
That's right. Yeah. So, significant examination Friday, she wasn't there and she had the edema. The blood pressure was 116 up to over 76 milliliters of mercury. The pulse rate was 80 beats per minute and it was good volume. Probably she had a tender start. A tender start that was only significant finding. So the vaginal examination, she was fully dilated with a couple of class 3, moving class 3, and she had an active pelvis. So the focus of this study is aimed at demonstrating the relevance of specialist consultation in managing emergency obstetric cases in limited settings. And then another objective is highlight their role of timely research interventions in preventing maternal and neonatal complications, and then to share the lessons learned from management of high-risk obstetric case and high-risk obstetric case at a low health center. So the case management, the patient was sanctioned for emergency section, performed necessary diagnostic tests and procedures, and then intraoperatively, the patient was given spinal anesthesia. It was delivered and scored very well, 9 out of 10, and then 10 out of 10. Closed the uterus very well in 3 layers. And then on inspecting the posterior aspect of the uterus, we found a large hematoma, which with the dimensions of 10 centimeters by 8, which was increasing in size. So what did we do? As at that time we had planned to do a subtotal hysterectomy, but I decided to call one of our specialists at Mbara Regional Referral Hospital, that is Dr. Ivan and Dr. Washa, who advised that we should dissect that large hematoma. I evacuate the hematoma, identify the bleeders, irrigate them individually, and then we monitor the mother for 2 to 3 hours in the theater. So that is what we did, and it was successful. We dissected, found the 2 bleeders which were bleeding, we irrigated them using vitamin 1, achieved hemostasis, and we didn't have any more bleeding. So the outcomes, we achieved hemostasis as earlier said. There was no need for subtotal hysterectomy as we had earlier decided. There was no need for blood transfusion, much as the patient was blood group O negative and we didn't have the blood in our stock. We didn't have any complication, and the patient was discharged on the first day post-operative. So those are on that table we are seeing the delivery that we had for the first, I think from January up to June this year. The cases that needed specialist consultations in January, there were 2. One important case that we had was a case of gravida 3+2+1 with 2 previous girls who had at 18 weeks who had a ruptured uterus with no EP. She had an unresponding EP. So what did we do? We consulted again before Dr. Ivan and Dr. Waswa, who told us on what to do. They told us to give us oppressors and additives and blood. The patient was transferred to Mbara Regional Referral and she survived. And another case, I think this is the one that I have just described. It was in May. There were 2, but one of them stood out, and this is the case. So recommendations and conclusions. Integrating specialist phone consultations is critical for enhancing maternal and neonatal outcomes, especially in low resource limited settings, as earlier discussed. And then continuous training programs such as emergency, obstetrics, and neonatal care at health facilities are vital for equipping medical officers and other health service providers with the new and necessary knowledge and skills. Encouraging consultation with specialists enables timely and life-saving decisions which help in preventing complications in the maternal and newborn care. So lessons learned in this case, involvement of specialists in management of complicated cases through a phone call or remote consultations play a vital role in improving maternal.
2 minutes.
Involvement of specialists in management of complicated cases through phone call, remote consultations play a vital role in improving maternal and newborn outcomes. As I discussed, then improves and maintains the professional relationships between a senior and junior doctors. Imparts confidence, especially in healthcare workers, health workers working in the resource-limited settings. Then acquisition and maintenance of new skills. Have been able to learn very many and new skills through a phone consultation with my seniors. One more thing, after about the confidence, if in case I get a complicated case now, I just enter the seat and knowing that I'm not one as a person. I have people who are behind me, I have a book, and in case of anything, actually, most of the cases have been handled them just by having a video call. I show them the case, how we are progressing, they direct me, and we have been able to get good outcomes. Thank you so much.
Thank you,
Dr. Naboth for sharing those learnings. We are seeing the regional referrals positioning as centers of excellence, supporting our lower level structures, but also the wisdom consult, and of course the specialists being available to support the others is critical. Thank you. We celebrate to Dr. Waswa. You say Dr. Waswa? Godfrey, are they here? Okay, we shall reach out and we basically celebrate you for supporting our lower level structures. Our third presenter is Henry Waswa, Christopher Waswa, sorry, who will be sharing on post-discharge follow-up for high-risk newborns, inter-facility and community linkages for preterm babies in Munyonyo district. You're welcome.
Thank you so much. My name is Christopher. I'm presenting on the post-discharge follow-up. So I'm a pediatric nurse from Munyonyo Hospital, West Nile. Our presentation is about interfacility community linkage. So a brief profile on Munyonyo district, established in 1980, and 2019 Obonge district was come from Moyo. So Moyo seems to be a refugee hosting facility. It has one general hospital with the 32 other health facilities. However, this didn't stop the lower facilities from referring these babies to Moyo General Hospital. So on average, annually we have 133 preterm admissions, having a percentage of 37.5 per thousand live birth, which is high compared to the national rate of 14%. So Moyo General Hospital has a niche, which is the 7.
Just a minute. I'm informed that there are some people who missed lunch. So if you missed lunch, you can move out where we're getting the codes from, and you'll be able to get a coupon for lunch. Thank you.
So I was saying, Moyo General Hospital Nicho is a 7-bed newborn capacity, which is a level 2. That means we give CPAP, and we'll be able to manage a 300-gram baby. On average, we started with 37 admissions. Currently, we are going to 57 by 2023. And most of our babies are from the general hospital, giving 85%. And 32 of these admissions are refugees. And with this, we had preterm admissions, which rose from 19% to 25%. Survival rates were at 95%, with the extreme low birth weights having the low survival rates. And with this, we had realized that we had low return for post-discharge follow-up. And this was obtained from the settlement coordination meetings that we had, and they were able to give us feedback, identifying that there was a problem of cost of coming to the hospital, and the time was not there for them. So with this, we had to, our objective was to improve, the objective was to reduce newborn mortality and morbidity for Moyo and Ubonge district, since the hospital was based in Moyo district. So our specific objective was to increase the proportion of preterm babies seeking follow-up care from 0% by July 2021 to 98% by July 2023. And also to improve the capacity of lower facilities in managing these babies. So the method we use integrated mentorships and support supervision to build the capacity of the lower facilities. We established the resuscitation corners and KMC corners for 18 facilities, 11 from Moyo and 7 from Ubonge district. So we had also to adopt SOPs for structured follow-up, which included teaching the lower facility staffs on how to calculate weight gain, how to fill the follow-up register. We called it the KMD register, and also how to streamline interfacility communication. That we established a WhatsApp group that every baby we discharge is notified through the WhatsApp group, and we make also direct communication to the lower facilities. We also strengthen health education, mostly for the mothers before we discharge them, and then at the receiving side of the lower facilities. And then we also defined the referral criteria that we were able to make sure that the referral facilities inform us of the babies that are sent to us before they discharge them. And then the other important bit was engaging the VHT, because when we discharge these babies, they are supposed to go to the health facilities, and the VHTs are able to identify where they are going. So these were our results. 99% of the lower units were able to conduct follow-up clinics, and 100% of these deliveries had newborn resuscitation corners that we were able to establish. We were able to establish KMC corners and support KMC post-discharge. And then we were able also to improve our percentage from 19% by 21-22 to 98% for all preterm babies. And with this, we realized that 95% of these follow-ups were conducted at lower facilities. But we thought they would come to hospital, but because of the data we are collecting, we realized most of these babies are from lower facilities. And 100% of these babies were able to receive home visits from the VHTs, and were able to strengthen inter-facility communication. So on that graph you see the blue represented the refugee settlement, the orange were for lower facilities in Moi district, and the gray was Moi General Hospital. With this, we realized that the General Hospital was not able to see most of the preterm babies because most of them were from the far facilities. That would also make sure that our interventions were targeted. So with this, these are pictures of the WhatsApp groups we had, and when we discharged these babies, we were able to do a quarterly follow-up at the lower facilities. And one of those pictures was one of the health center tools that were able to reach out, that we sent a 1,200 gram baby because of the challenges they had, but it was an intervention that was helped. So with this, we were able to realize that most of the deaths in our units were due to prematurity, having the highest number of deaths, and as opposed to birth asphyxia, which is leading. But in our facilities, mostly premature complications with babies who die, contributing around 59% of the death for the previous financial year, followed by birth asphyxia and sepsis, as we were seeing it there. Over the years, we've also been able to track survival rates in our facility, most of the newborn care, and we've realized that sepsis survival rate for the last financial was at 100%, and birth asphyxia and HIE were relatively no significant change, but we've been able to survive. So for the last financial year, we had a lot of referrals from lower facilities, and most of the babies were small. That's why you see the survival rate has really gone a bit down. But for the extreme low birth rates, we've been able to make them survive. Survival rate was at 91%, 51%, which was a good thing as to one level of the facility. So when we look at those admissions, we realize that, as I said, the low birth weight babies were dying more compared to the other birth weights. So with this, we've been able to improve capacity and of the lower facility in managing sepsis, and being able to reduce birth asphyxia, mostly the preventable bits whereby we are focusing on inter-routine resuscitation as one of the game changers in reducing birth asphyxia in our facilities, with the issues of early referral, much as there was also readmissions were there due to sepsis, and we've been able to track that, and most of the babies have been managed with the few deaths identified. So So these are part of the pictures of what we've been doing since our intervention is integrated. We teach the lower facilities how to calculate weight gain, use the SOPs, guidelines, and then calculate weight gain for the next follow-up. So in our discussion, we realized that this is an evidence-based intervention using the data we collect in our niches, and with consultation from lower facilities, we've been able to have support in making sure that we follow up our pregnant babies. 2 minutes. And this has been a simple and feasible solution. And the communication has been a game changer in making sure that we manage the follow-up program. So we've learned that with this we can use the available resources. We didn't need to create something new. We didn't have to have incentives for our VHTs. And we are leveraging on existing systems. So in conclusion, attention to the coverage of skilled birth attendants, and we should also improve on intraprenatal care, talking about emergency resuscitation. And the focus should also go beyond survival. Mostly neurological assessment is one of those aspects that we should look at. And then we should also strengthen capacity with learning services and communication, because most of the communication we're using our personal phone calls to the lower facilities. So I believe if that could also be improved on, we could do better. So this approach is feasible, and we believe similar facilities can use the same approach to extend their services to the small babies that we discharge from. Thank you.
Thank you, Christopher, and the team. I know Dr. Patricia, you must be part of that. So thank you for saving lives. And basically, Christopher speaks to a number of, about 2 critical behaviors for health workers. The communication, interfacility communication. Within the facility, health workers being able to communicate with each other for timely care, but also the linkage between the facility and the community, and building the capacities of community health workers to be able to support newborn care. Thank you so much, and I hope the audience is taking notes and questions and observations. So our next presenter is Mugisha Daniel, and they will be sharing experiences in reducing maternal mortality through regional local maternity and neonatal system experiences from Lamu sub-region. You're welcome.
Thank you, Chair. Good afternoon, ladies and gentlemen. I'm Dr. Daniel Mugisha Busharizi. It's a whole sentence. I've been doing public health work for over 13 years, doing different programming, HIV, malaria programming, and now family health. I'm glad to share with you experience from Lamu region, reducing maternal mortality through the regional local maternity system. And so much has been spoken about the local maternity neonatal system. I joined Lamu last year in April, and it was being spoken about in meetings, and we had not taken off. And this is a regional platform, accountability platform, and premised on regional service delivery frameworks. So we reactivated, there was a group, but it was reactivated in May 2023, and I'd like to thank MCHN activity. The doctor called Arnold is not here today. I called him and asked him what exactly is this and how I was supposed to start. And we started. So what was our objective? To improve timeliness, appropriateness, and coordination of maternal and newborn referral in the region of Lamu, improve staffing and skilling of key maternal and newborn health human resources, to be able to organize, manage, and provide patient-centered care, and also to foster technical support for leadership, professionalism, and accountability within the LMNs. So what did we do? After the phone call from MCHN activity, we had an initial meeting and Dr. Dur is here, our LMNS coordinator, 2 obstetricians from the regional referral hospital, and some few staff from UHA in our little office. And we plan on how to reactivate this, to include all the midwives in the region, medical officers, people from the blood bank, specialists. I found some, actually Dr. Dan was on a meeting, on a platform, and we started having our weekly 1-hour meetings at 7:30. I must admit it's not easy to have weekly meetings, but we started as low as 10 people, but now we have slowly grown. Emergencies now are communicated on WhatsApp platform. If you're stuck, there's no more being stuck like how Dr. was. You can quickly send a message on the group, and whoever is alert will notify the other. So at first, we would have challenges of moving a mother to regional referral, especially blood transfusion. Now, under the guidance of the director of the regional referral, reverse referral can happen. It's the blood which moves, and the mother can be saved from where she is. And it's actually a virtual platform to shout for help. And I'd like to thank Dr. Jackie. One time we were really stuck, and she was able to support a doctor who was in theatre. And Dr. Noe, we really appreciate. Really, the support is it's really great. You can call for help. So what have we seen? In 1 year, Lamu as a region has registered gradual reduction in institutional maternal mortality from where we were to 55 days per 100 live births. This is from Jan last year to June this year, and the source is from DHIS too. But what is very important for us is when the LMNS got reactivated, and the midwives, I really appreciate midwives in Lamu. It's no longer to feel alone, you can call for help, and it is really, really helpful. So what is the conclusion? Reactivated Lamu LMNS platform really contributed to a substantial decline in institutional maternal mortality in 1 year. And we are going, by next year it will be a different figure. And it has been a safe space for health workers to obtain real-time consultations from senior clinicians. One time in a Boke center where the doctor was stuck, practically stuck with a mother who could not be transferred. That's the time we called Jackie. So what happened, the regional referral actually sent a specialist, they packed blood, they packed fluid, and went to the health center for, and the mother made it. So really, LMNS, once well utilized, we can contribute greatly to the reduction of maternal deaths. My recommendations, all sub-regions, let's continue utilizing our LMNS for better maternal outcomes. Weekly meetings should be conducted. Because sometimes the midwife or a doctor may miss this week, but next week you'll be able to catch up. It allows continuous guidelines and best practice to be shared. One time we had a death in a March hospital, it was presented on the LMNS. And the cause of death, we believe it was misuse of misoprostol for induction. And I really appreciate Dr. Sam. He took us through a CME on misoprostol use, how to use it, when to use it. And this happened in our weekly meeting. So thank you so much, maternity. But regional referral hospitals and other hospitals, they really we need toll-free lines in the maternity wards to coordinate and respond in time. Right now, sister, really, please stand up for recognition. We have our senior principal nursing officer of the regional referral. She's our toll-free line for now. Okay, it's not toll-free. Everyone has to call staff, then sister calls the lab, calls the emergency ambulance coordinator. It is really, we are really riding on her goodwill, but I think we need a toll-free line where everybody can call. Sometimes the midwife doesn't have airtime, she's loved, but a person else can call. So we really will need that. Thank you so much. I'd really like to acknowledge the Lira Regional Referral Hospital. We have been supporting the director in Atentia, district local governments. So the doctor in Amalata, his pickup is the ambulance. We really hope these ambulances digital. His car is out, which doesn't, So we really appreciate local governments. The midwives of Lamu sub-region, we have a representation here. The medical doctors and specialists within the region and at national level, we really appreciate you. Commissioner has really supported us. One time we had a bed, was almost on life support, and we were able to get a bed from Gulu Regional Referral to come to Aboke Center for. The implementing partners in the region, we really appreciate. and with great support from USAID. Thank you so much.
Thank you so much, Dr. Dania, and we also appreciate the stakeholders, the partners that have supported the functionality of our LMN LNS. This is the way to go, putting our efforts, our resources together so that we reduce or even end maternal and newborn deaths. And using very simple platforms like WhatsApp, our toll-free sister, but the partners are listening to some of the recommendations and call. And I also want to appreciate Dr. Bagala, who is our national coordinator for LMNS. He's always reaching out to partners to ensure that our regional platforms are functioning. Allow me invite our last presenter for this phase, who is Alan. And Alan will be sharing with us using digital platforms to mitigate access challenges to high-risk clinics and the learnings from Kabong district. You're welcome.
Not giving me time. So, good afternoon, colleagues. Yeah, Alan Kiprop is my name. I work in Karamoja. I sit at the Morocco Regional Park. I'm afraid my presentation is like a repeat of what my colleagues are saying, and I think it will make it short for me. So I'm going to present an experience of the IRR, the famous IRR, that's the high-risk collaborative, identify, retain, and respond. So in Karamoja, we rolled out this high-risk collaborative in conjunction with regional coaches, the LMNS again I mentioned, Dr. Esai is there, the LMNS coordinator for Karamoja, with support from the DHO, ADHO of Kabong is here, I think Patience is here, yes. And even the director regional referral, I think is in attendance. So when we rolled out this IRR, we had hiccups. The first hiccup was issues to do with the referral or something. But before again we did the high risk, we realized that data from MPDSR showed that many maternal and perinatal deaths were occurring because of failure to identify pregnancy-related complications and risks during ANC. We had a confirmation of this through the IRR collaborative, where we had issues like multigravidity, and when you go to the column of the risk factors identified, the risk factors, the column is very empty, nothing is done about any risk. The BP is high, but nothing is done about it. So they were failing, the risk is there, but they are not identified. We also had a lot of malnutrition, but nothing is being done. We have a lot of teenage pregnancy in Karamoja, as you can see. We have a prevalence of about 22%, according to the UDHS. Another thing from the MPDSR issue is that pregnant women with complications were also falling off the health system and only reappear as emergencies. Again, when you looked at appointment keeping in the high-risk collaborative was just at 67%, and the ANC difference with the ANC4 was enormous, 85 compared to 53, and also deliveries were low. So again, these mothers, it means that they are falling off. Again, we also had failure to respond to appropriately to the identified non-identified needs. For example, giving mothers dexamethasone who had premature delivery or premature labor was just at that rigor. People were missing. Also, misdiagnosis from MPDSR was common, and the inappropriate interventions, just as maybe a diagnosis and the rest. So we moved out to support functionalization of high-risk clinics such that these risks can be responded to. So we had to train the coaches, did the mentorship, gave the screening tools, gave people credentials to report in the dashboard, and set up these clinic days and assign people to be in charge of these clinic days. And we realized this thing because of the low staffing pattern. Our high-risk clinics were not run by doctors, they were run by midwives, sometimes not the experienced midwives. And yet the referral success rate was at 27%, which was a big issue. So the other thing we wanted to support now, these midwives and other health workers in managing these risk mothers at the stroke health facilities. How can we support them now that they are not doctors, and even the doctors who are CMOXites are few? So we opted to line list mothers and conduct outreach by medical officers. That was a strategy supported by UHA. It was also supported by the LMN. So we opted that these mothers can be line listed, and once in a month, a doctor can go and see them in those facilities, those difficult facilities. So this again did not yield because we had about only 3 outreaches in 9 months. That means issues related with the cost and the cost-benefit analysis and sustainability was not working. So we again did review mothers on phone monthly by medical officer. So we realized that these line-listed mothers, why can't you call? And then the medical officer can guide the nurse when they are working. So we tried that one, and then this also spilled over to the LMNS to review mothers even when the medical officers had failed to review or they were complicated. And so we also improved referral system due to proper scheduling and sending of ambulances. So when these mothers were line listed and they are connecting with the medical officers and the LMNS, they said, no, this mother, please send her, and maybe tomorrow let her prepare, we are sending you the ambulance. So that collaboration was what was working. So this is just a case report of one mother who was having really preeclampsia and managed until delivery. The other contextual issue for Karamoja is that really sometimes you refer and people don't go. Distance, poverty, and many things. So this mother was referred and could not go. So they managed her using a phone call. A medical officer, Dr. Walter Vidori, is not here. Wakabong Hospital, together with Dr. Esai, managed this mother right from antenatal when they were discovered through labor and the post-natal period. That is in summary. Just prescribing medicines, talking about the supportive care and whatever they needed. And this mother never interacted with them face to face, but only on phone call with the midwife. So, what have we realized? Upon these successes, we realized that now phone calls are coming every other day. From 3 in a month, by July, this doctor, Dr. Walter Vidori, had about 21 phone calls from midwives around Kabong district. So that means that these midwives and the doctors are now having a relationship. And this relationship is what we are actually cultivating. So the discussion is really that the medical officers' contact shared across the district, majorly one officer being conducted. This I put it here because it's a call for medical officers. Some of them don't want to pick phones. So it is majorly the midwives are actually finding it easy to work with one. And yet there could be 3 or 4. So this is very key that the medical officers and the other skilled health workers should accept. So all the 4 collaborative sites call through these midwives, but again, we have realized that it has spilled over beyond the collaborative side. So any midwife, any health worker can call this doctor and get a consultation. So, but the gap really in terms of the IRR is that we do not have the register to track these 1 referrals, which are what we are working on. How do we actually track these 21? How many people call you in a month? They can call you when you're on leave, they can call you when you're there, you have attended to them, but we need some documentation to show that actually you support it, because this is work done by the medical officer who was consulted on the phone. So we don't have that, and we're working out a way that we can do that. So in conclusion, it is possible to support colleagues or health workers in hard to reach and inaccessible places using digital platforms. So without referral, the cost of the ambulance may be high, but some people, even when the ambulance is there, they may not be there for referral. The other thing is these phone consultations and reviews have improved referral as the contact between the high-risk mothers and the medical officer breaks the barrier of uncertainty of who will provide the service. So when you have talked through phone with the doctor that, doctor, it is like this, you come and get me on this day at this time. So that relationship between the patient and the doctor, they are already sure that there is someone waiting for you, so that that relationship is there. So in conclusion, we recommend scale up of phone reviews to hard-to-reach sites, and then we interest more technical officers such as medical officers and specialists to accept remote patient review and support lower cadre staff. That is the end of my presentation. The other second thing is in the QI conference, the other 2 years, I presented again in this platform about WhatsApp, using WhatsApp, and my colleagues have presented a similar thing about phone consultations. So maybe people, we need to adopt this, and it works especially for us in hard-to-reach places. Thank you, Alan.
Thank you, Alan, for sharing that experience. And of course, you point out very critical aspects. Health workers being able to identify high-risk mothers and being able to profile them. The ongoing mentorship that is targeted based on capacities of our lower level health workers, and of course the power of phone calls, and the call that medical officers should pick their calls whenever reach out. I think that is critical. So we are going into the session of Q&A. We are going to allow 6 questions and 1 question per person. Okay? So you need to prioritize who is going to ask the question. So I can start from here.
Thank you so much. All the presenters, very interesting presentations and very good learning. Just an encouragement for Daniel. I hope you have shared this with the NAMA team so that
the presenters take note
how far they have done, basically go down. But my question is to Stephen from Kusoga, which I have interest in, for self-restorations. And you presented something very good. Having worked in Kawempe, looking at cases which come to Kawempe, there are those which are referred, there are those which walk in by themselves. And there's a category which just bypasses all other places and then came to Kawempe. Looking at the theme of this conference, that's strengthening community engagement for sustainable maternal and child health. Is there something you have done to the communities in creating awareness about these services which you are putting in these other facilities? Whom is working, where is working, is there, can we document how many patients are now walking into Ginger Referral Hospital and bypassing Pomude and MPDSR? Thank you.
Okay. Yes, thank you very much. Thank you very much. Thank you, Dr. Daniela, and my friends, especially about the LMNS. I think we could talk the entire week about the good things from this platform. One of the challenges that we are facing is to interest all midwives on this platform. The ones who are on the platform are benefiting so much. When they are stuck, they are helped. How do we interest the midwives on the LMNS? The national meeting has over 900 participants on Thursday morning and Monday morning. But my actual, we can have 50, we started from 20. I think one of the reasons is the CPD points. Could we be allowed to also, I think, accredited to offer CPD points? Because we teach a lot on our regional platforms. Thank you.
Thank you.
Thank you, presenters. I'm by name Sebonga Margaret, MCH, MCH Konamutumba. Mine is to appreciate Dr. Stephen UHA for the time and commitment that has greatly improved our initiative with us. The same application goes to Dr. Mugahi Richard. We always follow him our own. Long live Dr. Mugahi. As so very we are proud of you. Thank you.
Thank you. I've lost track of my... Okay.
Thank you.
Thank you for the presenters. Thank you, Alan. Mine is not a question, but an appreciation for the partners which has helped us to come up to where we are as Karamoja. More specific for Kabul, I have to appreciate the UHA that through the constant mentorship on this formation of the IRIS clinics in the PPH and all the mentorship which they have done for the entire district has made all the midwives in alert despite of distances, insecurity, and then the network problem that 24/7, like me, who's their ADHO, I don't put on my phone in the night. Anytime they call, they know that we are calling and then transport is sent to them. And not forgetting a partner Kua who supports us, though now that contract has ended, they were supporting us in 2 transport voucher system for those mothers who are not able to come timely, and then the fuel to refer from Kabul to Moroto regional referral. Thank you for this local maternity home that we are getting to the climax. However, the last challenge is Dr. Benford just mentioned that midwives are not attending. My dear, even in these national meetings, which runs almost Monday to Friday, sometimes we don't attend all because of the data issue. Resources can make us not to attend 24/7. Thank you.
Thank you. And the last one, maybe you need to come this side. Okay.
Thank you, presenters. My name is Munyonyo Samson. My question goes to Dr. Daniela. I want to thank you for the presentation, first of all. We have seen a lot from the LMNs. In your objectives, you had one that was saying improving the staffing. But in the results, I didn't see the results around the staffing before and after the implementation. Thank you.
Okay. Thank you for the questions, observations, and appreciation. We seem to be doing a good job as LMNS, and I think the audience.
Question from Dr. Chizara.
Okay.
If you allow. Nelson.
The very last one.
The hand refused to go down.
Okay, that should be the last. And I think there is one question to Daniela, Dr. Daniela, and probably Stephen.
Thank you, Dr. Jackie, for recognizing my hand. Chizara Susan Nyende, Oxford from Kamli General Hospital. Thank you, Dr. Stephen, for the work well done. You really did that well. And we welcome Dr. Daniela. in Musaga region we have many challenges, but one of our major challenges has been the TDAs and the support from the political arm. Sometimes you prescribe an intervention and these patients somehow sneak out of the hospital and come back late with complications. We have complained, we have had community dialogues, but the trend is not really decreasing as we expect. We had a discussion in the morning and we were asked or tasked to come up with a solid resolution about TDAs. As implementing partners, what are you going to do about it? As serving officers, we have tried, but sometimes our hands are tied. The other issue has been the cultural beliefs. One of the key indicators in MCH is the timely antenatal, first antenatal. But these people are not coming in time. And you expect us to perform. You go to the villages, sorry, I'm laughing. You go to the villages, you're not getting the numbers. Then the LMS is providing HCG kits, but run out in the first week. And the mothers cannot outsource most of the times. So we are really trying our best, but how can you support us as IPs? Thank you.
Okay, thank you for that question. We shall allow 1 minute to each to respond to a question that applies to you. But I think specifically we have questions going to, we shall start with Daniela, and then Stephen, and then the others will conclude. Thank you.
Thank you, Chair.
Now, one thing I've learned over time, behavior change takes time. Dr. Barbara, when the LMNS concept starts, people may not quickly take it up. Let's not give up. I'll give you an example. I was in a health center 3 in a lecture. I found we had shared on WhatsApp. We usually have our challenges of preeclampsia seasons, and we had shared a chart on how to mix magnesium sulfate depending on the syringe you have. I'm using a 20 ml syringe, a 10 ml syringe, and that table was drawn. I found that table hung in a health center 3 labor suit. I asked sister, where did you get this from? Real drawn with a marker. She said I picked it from the LMNS group. People don't give up. People may not have data to attend morning meetings, but they see those things, because usually after the meeting the slides are posted. People see. Let's not be discouraged. Information is going. Now I can confess, some midwives thought I was working for regional referral. So, have your phone on. When people call, have a safe space. Midwives call. There are some I know by name very well and facility I've never seen them. So let's not give up. Let them have a space knowing, if I call Dr. Baika, if I send her WhatsApp, she's going to respond. If she can't respond, she'll connect me to Dr. Baika. Let people know that I can put my problem there. Somebody will see it. And also, I would like to, this and I'm going to whisper, DGCI. We need support of DHOs and RDHOs. Midwives, in fact, I really commend this maternal outcomes we are seeing. Yes, doctors, with all our due respect, but midwives have struggled and they continue to struggle. But let us support them. I see some internet provision at some health centers. I don't know who funds it, but there's a bit of internet in some facilities. Let people listen in when they can. But our leaders will need you. When a midwife sees her ADHO, when she sees her DHO, when you tell them, let's not give up, they will come. They may not have data now. I think let's continue with this. At least learning is happening, and we have seen that. The issue about improving staffing. The objective, the general LMNS concept, as I got it from Kampala, it is a Ministry of Health concept, and some of the objectives we wanted to do them, we have not achieved. But due to the challenges of referral, some staffing has happened. We had a crisis in Kwanya. 2 medical doctors left, and we were staffed, and we lost a mother actually. But anyway, we were able to, together with DHA and the district local government, Kwanya has advertised 2 doctors are going to be recruited. Some of these things you may not know what is happening at the health center. You just say maternal death, but what is happening? LMNS can alert, and people post their problems are on the group.
As you conclude, Dr. Daniel.
Thank you so much. The issue of TBS, I keep imagining when I see all that is happening. Can we now TBS our main competitors? We are a married woman. If you have a co-wife, you need to know the tricks and try and improve. For me, what I think let us make our facilities attractive. In Lagos region, the whole of Oyam district doesn't have a district hospital as yet. The hospital which is there is a PNFP, a Bell hospital. People pay money, but let me tell you, mothers go. And they are paying. How come people can't pay? People want a service. Let's work on ourselves. Let's make our facilities clean. There are certain washrooms where you go, and even here, the health worker was going for mentorship, you just cannot go there. Anyway, let's make our facilities attractive. TBS are competitors. Let's try and compete them. It's work in progress. Thank you so much.
Thank you. Stephen?
Thank you so much, and thanks for the questions. Start with Dr. Ononge on what we've done in Busoga in relation to community engagements. And I had already asked the LMNS coordinator to stand last time, but these guys you see there, there is a team that is across there, the Busoga team, and across there. They have done immense work when it comes to community engagements. And start with the community dialogue meetings. And one of the things we ask the center force to do, or where the health sub-district is located, is to utilize their funds as the health sub-district in order to invest in their communities. So you find a health sub-district like Chiyunga Health Center has utilized their PHC and RBF to organize across, because the only health center for in the district, to organize community dialogues around the district in order to inform communities on what is going on, what improvements are there, but also to address issues that the community has about our facilities. Then the engagement of RBCs and the health educators, and this is one of the things that our LMNS, by the way, we have, I think, the best LMNS coordinator in the whole country, Dr. Mameka. Stand once again for recognition. That guy has done great work when it comes to engagement of RBCs. Those who know Busoga, I think you see posters around that Umsawa Witness again of Ave Busoga is in Kampala, but he's saying Ave Busoga so as show power. But this guy has done great work with RBCs, getting airtime from them. And every now and then he's going to the radio with them, getting other midwives involved in talking to the community about these services that are going on and improvements that are going on in Busoga. And finally, the utilization of the Ministry of Health events like the PPH Awareness Month. I think Busoga really it was massive. We did a lot of community sensitization through that month, the whole month. We made sure places like Nanka, I haven't seen the in-charge Nanka and Ro, that already organized about 9 community dialogues around her facility. Because the facility had been abandoned, the community was against, there were issues. But when she came in, one of the things she did, and personally she was there with posters and everything, talking about PPH, but also about services that have improved in the facility, and that has brought back people into the facility. So, Dr. Nonge, these are some of the engagements. Dr. Anita, stand up, please, as I talk. And that's the great in-charge there, lastly. And finally, RIMC, Respectful Maternity Care, just responding to one of the inquiries about TBAs. I will use an example of Namayingo district. A third of the district is on the shore, the rest is on the lake. And we mapped 143 TBAs. So one of the things we did was to engage, UHA has contracted a CSO called Busoga Health Forum, because Busoga Health Forum has a connection to the kingdom. And this has, and those who saw Namayingo district last year, in the recently released annual the district league table, they have moved from hundreds to now they are below 50. I don't remember the exact position, but they are significantly, they are among those who have significantly improved, just because the engagement with the Busoga Health Forum has caused them to go in there, utilize the structures, engage communities, and discuss and try to help people understand why they need to deliver and seek services from a health center. And I want to end with Dr. Baifa's inquiry about LMNS. I think it was a general inquiry. But for Busoga, what we did, Dr. Bameka, the LMN's coordinator, discussed with Bruno, and so everyone who posts their name and registration number, they are able to, they can send to the Bruno, and then Ministry of Health is able to secure the points, the CPD points. And I think this has enabled Busoga LMNS is one of those that are well attended. And I can't forget the secretariat led by the team which is across there, Jocelyn and team, and Ganafa. Thank you so much. The midwives in Busoga have done a great job. Thank you, Chair, and thank you, Sister. I think Sister mentioned just an appreciation, the ADHO MCH of Namutumba Segonga. Thank you so much, and I really appreciate Busoga for the great work you've done. The midwives, thank you so much. You've done great work, and I can give it a big clap. Over to you, Chair.
Thank you so much. And in the interest of time, I'm tempted to stop with Daniela and Stephen, because the questions were directed to Daniela and Stephen, and the others with observations and appreciation, unless if there is a burning one that cannot wait. So join me in appreciating our first cohort. Thank you for presenting. And I know we can have more time to engage and learn from the experiences from the field. Thank you so much. Okay. Allow me invite our last cohort. And of course, increasingly, we are becoming very strict on time. So, allow me to invite Sam Cherop, who is going to share with us strengthening linkage and referral towards facility-based deliveries through pregnancy mapping by VHTs. Sam, you're welcome. Are you here? Next is the Hassan Kato, who will be sharing with us experiences for rollout and collaborative high-risk IRR lessons from Elgon Local Maternity and neonatal system. You're welcome, Kato. Allow me to invite Pikiriza Paul Agatha, who is going to share with us enhancing cross-consultation and referral systems in the LMNS care in Shema district. And allow me to invite Nandutu Madina, who is going to share with us improving nutrition deliveries at Busano Health Center 3. Madina? She's coming? Okay. And join me inviting Yo Kevin Sunday, who is going to share with us experiences of pre-referral communication and coordination on the local maternity and neonatal WhatsApp, a savior for near misses in a Acholi sub-region. You're welcome, Kevin. And we are going to reduce on the time, not anymore 10 minutes. We want to use 8 minutes for presentation. And we shall be allotting you 2 minutes to the end of the presentation. So, join me in inviting our first presenter for the second cohort, Alan Kepro. No? Is it Alan? No. Sam Cherop, sorry. Forgive me.
introduction. Dr. Ayo will be presenting on behalf of Sam Cherop. You're welcome, Doctor.
Okay. Okay, thank you very much. Good evening, ladies and gentlemen.
Some help?
A protocol officer, as we are talking about IT issues.
IT?
Yeah. Okay. That is my profile. My name is Dr. Ayu, the District Health Officer, Kwen, and I'm here to stand in for Sam Cherop, with whom we came up with this. That is my brief profile, very mean, but I hope to improve it next time. I'm going to share with us experience in Kwen District Local Government on linkage of mothers through the VHT system to health facilities for deliveries. Those are my co-authors from AMREF and then Kwen District Local Government. You all know that for us to provide healthcare for all, these community structures are indispensable, and that is what we wrote on to ensure that we improve deliveries in some of those facilities in Kwen District Local Government that were badly doing in terms of deliveries. VHTs, as you all know, as we've been hearing from our previous presenters, they form part of the community structures that we have in the country, which was formed way back in 2001, I think. And over the years, many have been enrolled, others have fallen off, which in one way or the other have weakened the healthcare systems, and especially the so-called hard-to-reach districts. In Kwen, these VHTs help us in a number of interventions, among others, health education, referrals, and then linking those clients that are in hard-to-reach to link them to health facilities. So, Kwen being that hard-to-reach, hard-to-stay health district, we utilized this community structure to ensure that we bridge that gap. We have those hard-to-reach health facilities whose indicators were poorly, pretty badly, if I may say. So we had to bring these VHTs on board, build their capacity, and then also build capacity of the health facilities to work with them effectively in order to reach that objective that we are all looking out for. So, with the help of HEROES program, we selected 2020 VHTs in 6 sub-counties where these facilities were formed. And we trained them, we gave them the aid to perform their community work, and we attached them to specific areas that were hard to reach. So their work was majorly to map out, identify, and refer potential clients, and in this context, the pregnant mothers, to health facilities. And these health facilities that are put involved, majority of them were health center tools that were initially not providing female services. So they were trained, they were selected, trained, and then set out in the field to perform their roles. We used to have regular review meetings where we would evaluate their performances in terms of number of referrals, in terms of health education talks provided, the follow-ups, name it. So many of you would ask how they probably get motivated to do this work. Of course, we are looking at having an innovation which is impactful, but also sustainable. So we would not sustainably have them on board with a monthly stipend or something like a monetary incentive. So we had to use other programs available, like the PDA, and then these other small incentives that whenever we have national programs, they are the first priorities to be considered, and then t-shirts, name it, and then some form of recognition. So those ones kept them on board to ensure that we continue working with them without getting involved in financially constraining mechanisms. And all this that we were doing was anchored towards those principles of community engagement, which looks at the community as a unit of identity and identifying communities. Building on the strength of resources which are available in the community and many others. So, as years went by, we found a positive trend, a positive correlation between these referrals that were being made by the VHTs versus the deliveries that were registering. It's unfortunate that the slides were a bit congested, so the slide that showed a trend of deliveries for the 6 facilities was kind of deleted, but this was a district picture, but we also had facility-specific trend. So, in conclusion, we find that utilization of these community structures has gotten a positive impact towards improving some of these struggling indicators. And in this context, I'm talking of health facility deliveries that were able to improve in those hard to reach health facilities requiring district. Those are too many. Thank you very much. I appreciate it.
Yeah, thank you for saving our 2 minutes, Dr. Yu, and for sharing those experiences. We are going to run marathon. Now next is Hassan Ato, who will be sharing on the rollout of IRR collaborative lessons from LMNS. Thank you. Welcome.
Thanks a lot. My name is Hassan Ato. I work for UHA in the region. Just like other colleagues, someone has already presented LNMS IRR. I just wanted to recognize the team that made this work and I'm presenting on their behalf. Dr. Peter, you can put up the hand. Dr. Kenneth is around. I saw Dr. Kenneth around, and the DHOs in the Elder region, they are around, including Dr. Ayub here. So, as you all know, that the way to go was the IRR. And as a region which has around 16 districts and 1 city, those are around a lot of health facilities and a lot of CMOC sites. We have around 30 plus CMOC sites. And when you look at the BMOC sites, they are in hundreds, more than 180. So as a local maternity, when this was brought up, we're like, yes, Peter there and the team were like, how do we really roll this out? We have very many districts. They are very far from each other. So we use the local maternity. The red one. Okay. So yes, these are the teams that were involved, including the Mali region referral. So as I was saying, the team looked at how do we really roll out this? What strategies do we really use to reach out to the very many facilities and the very many districts in the region? We all know that local maternity is a team that is controlled by the regional referral hospitals, and the team there was looking at how we put this across. So we started by having a few sites, and our objective was really to scale up to around 36 CMOC sites and around 191 BMOC facilities in the region. So what do we really do to have this move? As the LNMS, with our regular meetings, we had to sit and find out a way. One of them was, yes, let's do every district specific rollout. This has a curriculum of around 2-3 days per district. How do we package it and it goes into a 1 or 2 days? So we had to have district specific rollout. And who is rolling this out? The local maternity. So we say, where can the local maternity reach? We say they can reach at a district level. We do a centralized district rollout for a day, and then we do another day, which was the second strategy, to look out the champions. We got the CMOC site and look out the champions. Support the district, support us to identify these champions. The district support us to train that one day. So the LMNS does the 2 days. One day is the general rollout, and another day is identifying hub champions and CMOC champions. These hub champions could be midwives, could be doctors at the CMOC site. Now, these hub champions have to roll out at the BMOC sites. Now, these BMOC sites are very many in the district. But how the hub champions roll out depends on how better they can do it according to the facilities they have. Are they going to be just a mentorship? Are they going to be a central rollout? What are they going to do to roll out this? Because the indicators are many. Then after that, you realize that these BMOC sites, you have to keep going there. And the good thing is that when you do use the CMOC site to roll out the BMOC site, it's actually even not expensive because we can integrate in very many of the activities. IRR looks majority at referrals from the lower sites to the CMOC. Referrals that are high risk. How the teams support them, identify them, coordinate them, and to bring them to the CMOC is what these hub champions will always do. And then the last one, which we usually do, is collecting data into that dashboard. Colleagues, you have seen that dashboard, so I will not even go into detail. So the champions coordinate most of the things. Among the indicators that people keep checking are how do we have all mothers have a conflict risk assessment. When you look at the trends, is that regions and CMOC sites and BMOC sites, around 200 of them, 100 BMOC, around 36. Keep collecting data, and you see that most of the sites keep improving. They are starting from red into green. When you look at the number of people who are enrolled, the districts and the facilities keep improving by these hub champions and the BMOC champions. So what the LMS does is to catalyze the learning. 2 minutes. to catalyze the learning and see how do we really improve this kind of sharing, the complete risk. So from the last rollout, you can see that that line, the percentage of women who have a complete risk, we are moving from 52 to around 89. That's 90% of women really assessed. And when you look at the percentage of women who are enrolled into the high-risk clinics and those who are really identified, we are really improving. And key to note is that we are seeing these high-risk clinics being established in the region. Having a region which has around 30 high-risk clinics run by MOs, very committed leaders, something to look at. So going forward, we are saying it is very possible to use the LMNS to roll out this and use the few strategies which are cost-effective, and this IR will really improve that communication bit. So in recommendation, we really need these hub champions and the DMOC champions to keep cascading this. It is something that is continuous. And then we need to use this hub virtual learning in the local maternity to keep improving IRR, because that is the way to go, if I can use Peter's words. You know, IRR, risk identification, is the way to go. Thanks a lot.
Yeah, thank you, Hassan, and UHA for supporting the skilling of health workers. Next will be Kwikiriza Pal Agatha, who will be sharing on experiences on enhancing cross-consultation and referral systems in local maternity and neonatal care Shema district. Thank you.
Thank you so much. Good evening, everyone. My name is Kwikiriza. Hello. My name is Kwikiriza Adam, and I'm a midwife champion. And let me say that I am not trained to be a champion, but I am a self-made midwife champion. And my topic is enhancing cross-consultation and referral systems to improve maternal and newborn care and sharing systems. Everyone has been speaking about midwives not staying empowered, but it's because we are not empowering ourselves. Someone from Kampala will not empower someone from Shema. Someone in Shema can empower a midwife in Shema. And this is what I encourage all of us to do. That when you go back from here, ensure that you have your midwives close to you. Do not keep saying that Paul maybe is inactive. Not keep saying that maybe Jocelyn feels like she's better here. No, she can be better with you because there is something that she lacks and that you have. Let's share the knowledge, let's empower these midwives, and they will do better for us in those communities that they serve. And I want to acknowledge my fellow authors. Thank you so much. I want to acknowledge UHA. Thank you so much for supporting me and empowering me to be a better midwife. This is my profile. The first note that I can talk about my profile is I'm a midwife finance leader. Where I am and where I go, I am a leader. I do not wait for someone to lead me. I rather lead the people that I find. I don't want to talk about much about LMNS. We have all heard about LMNS. And what happens in my region, in my district, is that my midwife would rather call me than posting the cases on the LMNS platform. I understood it. I understood probably they are not able to they feel like they can't be understood outside there. And I was able to lead them. I found God that helped me out, and I was able to cascade LMNS at the district level. I joined this platform with our ADHO, who's also our acting DHO, and she's so helpful that she always replies us when we have cases, and we have always been helped. We also didn't have high-risk clinics. However, the people in health center clinics, the midwives in health center clinics would refer these mothers but there are no specific dates. I had to interact with my maternity in charge at health centers and hospitals. How can we do better this? They provided us with a date and they provided us with their contact number. One of our health center has a phone landline, actually, it has a landline. The hospital has a small phone, and then the other health center actually doesn't have. But we advised them, ensuring that the next quarter they are able to buy a landline for the facility because it will be helpful for us. Looking for individuals may not be well because the maternity in charge cannot be on duty every day, but the midwife on duty can actually pick your call. So I'm so grateful for my fellow midwives in Shema that they are able to help us to be able to manage. We have run 16 months without a maternal death. Unfortunately, in September we got 2, but we are planning to have more months without maternal death. My objectives, one was to facilitate collaboration and information sharing among midwives. Last year I attended training about PPH, the emotive, last year, and I was able to share this information to my fellow midwives without even reaching their facilities. We share the soft copy, they ask you questions, and you direct them this what to do. However, I pray hard that I'm able to fund it and I go to the facilities and do the hands-on for them. We're also to establish high-risk clinics with help of VHF. Our health center force really have functional high-risk clinics. The methods that we did are really already talked about them. I formed the Shema District Local Government Midwife. Most of us have this platform. The word we discuss there, this one has this one has a party, then this is only the information that we give to our fellow midwives. From today onward, let's give the right information that midwives need. Midwives cannot be everywhere, that they will be here to get this information, but when you are empowered, kindly empower the rest. And then slowly, when they realize that you can actually post your challenge on the LMNs and you get a feedback, and you get a feedback, our midwives are able to openly share the information on the LMNs. Those who cannot, I am able to forward their message to the LMNs and we are able to receive the help. And the high-risk clinics were really formed and they are functioning, I would say. These are some of the screenshots. Our health secretary had sent a mother. She was referred to Kabohe, she was worked on, and they even gave us the feedback how the mother is doing. That improvised the high-risk clinic book for Kabohe Health Center. They also gave us the numbers that they had seen for a period of 5 months. And this other is my work. I mark my mothers. If it is a high risk, I will put a rate so that I'm able to come back and follow up this month. If it is not very high, if it is a low risk, I'll come and put a yellow so that I can keep on following up this mother. Referring the mother they reach the facility doesn't mean that they actually stay there. Some of them, they even come back to the facilities, to the villages, they hide, the cost effectiveness of being in the urban facilities is not that good for them. And our results, we really improved. 16 months without a maternal death. That gives me the greatest sleep every time that I could. And the recommendation that I give, teamwork, positive attitude. Everyone here is saying midwife. I was looking at a midwife member of Parliament. I look forward to meeting her in the next IDM of midwife. Because I want you to come and you infect us with a feminine brain MP. Probably our information is not outside there, but midwives, we have issues because you are one. But when you attend the IDM with us, I promise you we can be very many MPs in the Parliament. Yes. You see, we have very many feminists in Uganda. Why? the feminists are effective, the feminists. So what does this mean? That the empowered midwives and actually infect the empowered midwives with the information. Thank you so much for listening.
Thank you so much, Agatha, the self-made champion, and really takes positive attitude to have effective consultations and referrals. And thank you for supporting the rollout of the high-risk clinics and LMNS in Shema. We appreciate it. So we are almost there. 2 more. Our next presenter is Nandutu Madina, and they should be sharing experiences in improving institutional deliveries at Lusano Health Center 3. You're welcome.
Sorry, I think my topic was changed in the labo, but my topic was to improve IPT3 uptake among illegal pregnant mothers at Munyonyo Center 3. I'm Nandutu Madina from Bali Local Government, Munyonyo Center 3, Assistant Nursing Officer in Midwifery. IPT therapy, IPT in pregnant women, it is a strategy recommended by WHO which aims at preventing malaria among pregnant women in malaria and epidemic-prone areas like Uganda. Malaria during pregnancy can be serious consequence for both the mother and the unborn baby during. With unborn baby, including which can cause to anemia, low birth weight, preterm birth, and increased risk of maternal death or infant mortality. IPT3 is designed in mitigating the risks by preventing regular doses of antimalarial drugs during pregnancy, starting from 13 weeks of gestation, monthly until delivery. At Munyonyo Health Center 3, we're at 65% eligible mothers who received their third IPT dose by November 2023. Our objectives were to increase IPT3 uptake among illegal pregnant mothers attending antenatal from 65% in November 2023 to 95% by April 2024 at Munyonyo Center 3. Our numerator was the illegal pregnant mothers attending ANC receiving IPT3. Then our denominator was the number of pregnant women expected per month from our catchment area, and that is 5% of the catchment area. The methods we used was through regular data reviews at the facility, which was that only 65 of the illegal mothers who were given IPT at that time. The facility PY team dived into a root cause analysis using the 5 Ys to understand the contributing factors which were making us to remain at 65%. Our contributing factors were improper documentation of IPT in the ANC registers, whereby you could not tell the number of doses the mother is getting, simply because the registers were just being ticked that form of IPT. Midwives were putting ticks instead of the numbers. The team was taking a longer time to review the data. That is at the end of the month, that's when you go through your data.
the team agreed to start writing IPT3 in numbers. For example, IPT3 followed by data and morning data reviews. We had brought up, I think, of reviewing our data weekly, and we always have it on Monday morning by 8 a.m. So that is the graph showing our data from November 2023. We are at 65. December, we came to 65%. By January, we are at 77%. February, we came to 81%. March, 111. April, we are at 109%. May, 112. So by April, we had hit our target. Then by June, we dropped a bit to 88%, and this was just because of out of stock on 1 week with IPT. In conclusion, the improvements in uptake of IPT3 third dose and above showed decrease in the number of malaria in pregnancy cases in the facility. From about 30 mothers who we used to see those days, we came to 15 cases per month. Our recommendations are to sustain and enhance IPT3 uptake at the National Center 3, regular performance, review and accurate ANC documentation, and direct observation of IPT therapy. IPT3, that goes directly all doses, not only IPT3. Scaling the approach to other facilities and community sensitization can further reduce malaria in pregnancy and improve maternal and child health outcomes. Thank you for listening. Allow me to acknowledge my DHO, Dr. Wangis Jonathan, who is in the house. UHA as our implementing partner, in particular Madam Nambala Esther, Madam Prosi, and ADHO in absentia. Thank you very much.
Thank you, Madina, for sharing experiences on how we can increase IPT3 uptake, and of course the power of regular data reviews at facility level. So now, allow me to invite our last presenter, Ayo Kevin Sunday, who will be sharing with us pre-referral communication and coordination on local maternity and newborn WhatsApp, a savior for near misses in Acholi sub-region. You're welcome.
Good evening, colleagues. My name is Kevin Sandayo, medical officer at Maternal Hospital. I'm going to share with us an abstract. But before I do that, allow me acknowledge UHA. Thank you so much for the support. Allow me also acknowledge the LMNS coordinator for Acholi sub-region, Dr. Baita. Yes, I've been very supportive in this abstract, and I want to say thank you very much. The title of the abstract is Enhancing Pre-Referral Communication and Coordination using the local maternity and newborn system WhatsApp, and thereby reducing near misses in Acholi sub-region. Developing countries like Uganda continue to face the 3 delays in health service delivery. And the third delay at level 3 and 4 health facilities has been partially attributed to inadequate critical staff, medicines and supplies that are needed to offer the comprehensive emergency obstetric and neonatal care services. This gap has led to inevitable patient referrals to higher level facilities at the district and the regional levels. Therefore, pre-referral communication to the referral facilities has been known to better prior emergency preparedness at the receiving hospitals. So what did we do? So we made an observational study on 11 critical cases of mothers who had obstetric complications, and they were posted on the local maternity and newborn system WhatsApp platform prior to their referral to the higher level facilities. And this was done for a period of 4 months, that's from March 2024 to June 2024. Pre-referral communication and coordination on the LMNS platform was tracked to the final clinical decisions, and the outcomes of the mothers was profiled. Colleagues, I want to inform the House that there was 100% survival of all the mothers with obstetric complications. 45% of cases had their referral decisions reversed after technical guidance from the specialists on the WhatsApp platform, and 55% were referred. So, of the 45%, 57% who had PPH had blood products transported to them instead of the patients being referred. Meanwhile, 43% of PPH cases were referred to a higher level, and they were effectively managed. And quality of care was enhanced by the discussion on the LMNS platform. So what were the lessons learned? We learned that pre-referral communication and coordination in the LMNS WhatsApp group helps build capacity and confidence of frontline midwives and doctors, therefore successful management of reverse referral decisions. So we had a case whereby the specialists on the WhatsApp platforms, they would comment on the cases, give pieces of advice and guidance, and this would boost the confidence of the frontline of workers at those sites. Case sharing on the platform enables the region identify staff and health facilities with knowledge and skills gaps as far as CMOC is concerned. So this was also done based on the cases that they would keep sharing on the WhatsApp platform. Then we would identify those gaps and those facilities that were having skills and knowledge gaps in CMOC. We also learned that there was enhanced regional teamwork through the case discussions. Members were very interested in these case discussions going on the WhatsApp platform. Every time they were eager to support, call on a colleague who is not maybe online at the time of when this case has been posted, and there was a lot of regional teamwork. We also learned that private facilities are more emergency ready for blood products compared to the government facilities. And also we learned that in case of an emergency, think outside the box. What were our recommendations? We recommend for on-site support supervision and mentorship on both the basic and the comprehensive emergency obstetric and newborn care services, because we realized that as through the case discussions on the platforms, there were facilities that were identified to be lacking skills and knowledge in offering these BMOC and CMOC services. So these facilities need a lot of support as far as this is concerned. We also recommend for provision of table phones in all the health facilities to coordinate these referrals. Earlier on, someone has spoken about this because it helps save time. Not this issue of calling and then sister is like, no, I'm not the one on duty. Let me mobilize. A lot of time can be wasted. But when we have these on-table phones, it can help save time. Also, we recommend for strengthening the referral system to enable timely intervention. So in conclusion, we are saying pre-referral notifications and consultations taking place in the local maternity and newborn system WhatsApp group facilitates comprehensive technical support from regional specialists, thereby enhancing the quality of maternal and newborn care through capacity strengthening and reducing unnecessary referrals. Thank you for listening.
Thank you, Kevin Sandy, for sharing those experiences, especially the 100% survival of mothers, the obstetric complications was really catching. And of course, interesting us to think about outside the box. That means being innovative about our work and the on-site mentorships for both CMOC and BMOC. So thank you so much, presenters. We are going to have 6 questions from the audience. A question or an observation and directed to the presenters, this specific. So you can start from here.
The first observation is coming from the coordinator. Since all LMNs are shining, allow me also to recognize my own LMNS coordinator, Kampala Metropolitan, where all your referrals end. Dr. Rachel, please stand up. All the recommendations you're making here, that already has been in place. The point of things we're talking about, however, already has been in place. Toll free. So please feel free to come for some notes from Dr. Rachel, the Kampala Metropolitan LMNS coordinator. Thank you.
Thank you so much. Thank you. Thank you so much, all presenters. It was very encouraging to learn from you, particularly Dr. from Kwen district. Your paper speaks very closely to the theme of the event, strengthening community engagement for sustainable maternal and child health. Building on the power of community health workforce, you are able to achieve improvement in institutional deliveries. As a district with its own unique experience in VHD retention through non-monetary like motivations, like your paper speaks, do you have any plan for sustainability? Because a person like me would really want to build on your initiative. Do you have, as a district, a plan for sustaining or scaling up this initiative? Thank you so much.
Good evening, colleagues. My name is Uganda, an athletic officer in Karamoja region. My question goes to specifically to Madina on IPT strategy in reducing the incidence of malaria. In your presentation, in your abstract, you realized that there was an improvement of mothers in uptake of the consider. Was this one only a study done for only the mothers which you have screened using the hem-heredity or which were negative? What about those ones which heredity turned positive? What did you do to them in the aspect of giving the considerator? Because you could have clustered it in the 2 ways. Then drastically, when you lacked the facility, lacked the IPT, we saw the graph growth slowing down to 88%. Which strategy did you take to avoid the replication of that incident in the next year, in the next plan? Thank you.
Yes.
Gentle reminder, one question.
All right. Thank you so much. My question will go to the first presenter, that is Dr. Yu. I would like to know how we factored in the contribution of other community health structures other than the VHTs, because there are structures that work with the VHTs to initiate the referrals to the health facility. Because in your presentation, I overheard the VHT referrals of mothers to the facility. Thank you.
Thank you very much, Dr. Jacqueline. Yeah, I just want to inform the House that Dr. Yo was our intern doctor at Gulu Referral. So what we do in Gulu, every time in my department is given a QI project to work on. So that was her project. And we've carried it out to the affair. Thank you.
Thank you so much, dear presenters. I want to appreciate the midwives in Shema and especially Agatha. Agatha has played a vital role in the WhatsApp groups, for the WhatsApp groups that we are on. She has scaled up maternity care. I really want to appreciate you. Thank you so much.
The last one?
This is Teddy from NEBI, and specifically to Ayo, Dr. Ayo, we are having a recommendation of ensuring a table phone, but I'm talking from experience. Much as we are trying to make the pre-referral communications, the maternity phone exists where I work, but we have these scenarios where as much as we emphasize on pre-referral communications, some midwives from the lower facilities will communicate while others will just send the mothers without communication. So how do we help these midwives? As we talk of getting a phone that is called, let us also think of these midwives in the lower facilities, because some of them give you the challenge that they have no airtime to communicate. Thank you.
Okay, thank you so much, audience. It was lots of learning and appreciations, and I think we have only two speakers that have questions. That is Madina and Dr. Ayu. So, Madina, do you want to go first?
Thank you very much. The first question was about those mothers who have malaria, what happens to them. Then the second one was about the drop of the mothers, whereby we reached 88%, and what are the next plans for this. As I can tell you this, the drop came about because we lacked Fansida for only 1 week. As we here, what we did is to inform the district store personnel to do redistribution of the drugs, and it was gotten within a few days. That's how we managed to do it. And we have also said we are going to be, if at all the thing is getting game in the store, we should not wait for it until the last packet is out. We have endeavored to see that we do, or we notify the district early enough to do redistribution from those facilities having more. About what happens with those ones with malaria, mostly we are using BS, not MRDTs. For those ones who cause to be having malaria cases, we treat them with antimalarials and we give them a review after 1 week. After 1 week, when they come, that's when we give the IPT theory. Thank you. Hope I've answered you.
Thank you. Next, Dr. Ayu.
Thank you very much, and thanks to all colleagues that have asked questions. I think I have only two of them to respond to. The first one, I think, it was asking for sustainability, and during my presentation, I was quick to explain as to why we decided to use the available structures first of all, that's the VHTs, and then also to use non-monetary incentives to appreciate them. This was an initiative that was supported by one of our partners, that is Heroes Program, and I really thank them for this because it has yielded the results. So this concept was, in order to be sustained, we avoided having monetary incentives. So we believe that even if Heroes Program has gone away, we are able to continue leveraging on this structure to improve even other indicators, not only deliveries. Of course, some of the benefits include, but not limited to, those small appreciation, the t-shirts, the certificate of recognition. Of recent, we were conducting revitalization of VHTs, courtesy of Ukraine, and then our district were able to train them, but at the end of the training, we were able to design and issue them certificates. So they are a recognized structure down there with their certificate, though you can't take them anywhere, but at least they have that as something to get pride of. And then we have quite a number of national programs that come to the district, and we pick out these people to be one of the first priorities that we can consider. So that one alone can motivate them to continue working with us. So with all that, you find that we can able sustain them without having serious financial constraint. The other question came from yet another colleague, how we factored in other community structures. Like I said, this was a pilot initiative in 6 sub-counties, but in the rest of the other sub-counties, we are indirectly implementing the same using other structures. The LCs are on board, but we also have, we all know the TBAs, but for us up there, we call them peer mothers, okay? We call them peer mothers. So, other than VHTs, we have these TBAs, or the peer mothers in ports, also having making referrals and helping us to do follow-ups and linking these clients to our health facilities. Thank you.
Yeah, thank you so much. Join me to appreciate our last cohort. Very good experiences. Join me in appreciating ourselves as a whole for being very good participants, but also for being able to take the experiences. And I know, Dr. Wagala, there are so many learnings that probably we need more time for us to reflect and have an engagement with our local maternity and the ecosystems. And of course, join me in appreciating the 15 LMNs, including Kampala. Usually we move to the subnational and we forget our Kampala. And I'm on that platform, I see a lot of activity, coordinating referrals. I think it's very, our coordinator is much appreciated. And of course, from the presentation, we realize we are making a lot of progress, and I think this is a system that we need support. And of course, from our perspective as the stakeholders working with the government, we commit our support. It's very important that we work through a system that is well positioned, and I think we are getting there, positioning our regional referrals as centers of excellence and being in the driving seat to ensure that maternal, newborn, and child health deaths are prevented. So, Dr. Baga, do you want to invite the DG for closing remarks? Since you are our boss at national level, I think I thank you for trusting me to chair the experiences. I remain Benon Misasizi from World Vision. Thank you so much.
Thank you very much indeed, Benon, and Team World Vision for really taking on this powerful panel, and thank you to our very powerful scientists for sharing those very, very phenomenal papers and researches, and to all the LMN coordinators in this room. Now, without any further ado, allow me to welcome the boss of the health sector, the Director General, who we know quite well and who has been very supportive of these powerful mechanisms to close our session today. DG, over to you.
Thank you very much, John Paul. The boss of the health sector, the minister. I'm just a boss of the technical side. So, Honorable Josephine, a woman MP from the region, colleagues, ladies and gentlemen, we agreed from yesterday to observe protocol. First of all, join me to thank Benon again for sharing this session very well, and all the panelists and presenters. I think the 10 of them or something like that. Please join me also to thank Honorable Josephine, who has been here since morning. And even in the morning, she helped us with launching some of the very important documents. We thank you very much, Madam. We don't take that for granted, that you can commit the whole morning and afternoon to be here. But we also know she's our colleague. I hope you know. Yes. She's our colleague and the health worker. I think a midwife by training. Very good. Give her a big clap. So I think I'll thank the panelists as well. Thank you very much. I'll keep this very short. It's exactly 6 o'clock. And people have been here since 9. And I know many of you are tired, including me myself, actually. I started with a meeting at 8:30 with the peers, ended at 10. From there, I went to join JCRC for a board meeting, which ended at 1:30, then rain here, although I was in time for lunch at least. But what I needed to, of course, came to this session. What I liked about this session, it was really a learning session for all of us. I've been in this session and I've been writing, and I think I have about 4 pages. Not for speech, but for my own learning. Because I was also learning, honestly. And I find this very interesting. First of all, I'm very happy that it's the real people, the implementers, the real people who see the mothers, who deliver our mothers there, who see them, who are here now telling us their true story. We are not dealing with people who read from textbooks, people who are here collecting other people's stories in order to make a story. This is a real story from the real people who do the work. And that's the great about it. Because the people are really talking about their life experience, meeting or dealing with our mothers, our children, in those facilities, and not even just in Kampala alone, but as far as even Karamoja. We had presentations from Queen, we had presentations from Navy, and all this. So we are really very impressed by this. Another thing I learned is that actually LMNS is doing a lot. You know, we've been on these WhatsApps, some morning meetings, but listening to the presentations here, you can see it is doing a lot of work, and it is helping to change a lot of indices. You know, like the Lango presentation reduction of maternal institution from 116 to 55, that is significant improvement. And that was presented by Daniel, I think. And even similarly, many people presented very, very significant improvements in indicators because of this LMNS. So, at least something we all learn is that LMNS is making a lot of changes, is improving our indicators, and is reducing maternal mortality in our community. You know, when people, in the last UDHS, when we moved from 336, 100,000 late births, to 189, people had a lot of doubts. Yeah, that's a big jump. That improvement is too good to be believed. But now you can see, I am believing that actually things are improving in this country. I think we should believe in ourselves that things are much better. So, as I said, I don't want to overlay you. One thing I've taken for sure is that we are improving, and this intervention which has been put in place is making significant changes. Somebody raised the issue of TPS. And I think somebody also tried to explain it very well. I think it was again Daniela. You know, we have those TPS there. And Namayingo, you said you even have 143, you have done a study there. But I think Daniela tried to explain it that, you know, the TPS are there. But also, these are service providers we need to compete with. You know, the TPS, there's a way they talk to our mothers. There's a reception they give to our mothers, and therefore become very attractive to our mothers. So if we also improve on the way we talk to our mothers, if we improve on the way we handle our mothers, then why would a mother go to a TPA and avoid a health center which is very near somewhere? You know, 2 weeks ago I was in my village, and then people knew I was there. One of our catechists came and talked to me. DG, we have a good health center here renovated recently, and people had got so excited. And people started coming. Actually, the private facilities in the training center had dried up, because people now had seen a good government facility. They have started coming to the facility, and have been doing very well. But if you go there and see, there have been very significant reduction in mothers coming to that facility. Said what? Our midwives here are abusing mothers, are harassing mothers. The lab person is no longer there. It's actually the askari who takes away blood from mothers. Is the one who does it. So he said, can you imagine? So they said the mothers have run back to the private clinic, and they have run back to the PNSP facility, which is like 6 miles away, 6 kilometers away, leaving hours, which is near. And I really wanted to, I was looking for the DHO of Chendoto. Unfortunately, I was told she's not here today. So, if we are going to be rough to our mothers, and this TBA is so kind and is so good to the mother, so why wouldn't our mothers go to the TTS? Why would they come to be insulted? Why would they come to be abused? Even if it is a very nice facility done by you, we are sending their medicines, we are sending their gloves and whatnot, but the attitude of staff. So let's please change our attitude. Let's be good to our mothers, and then the services will improve. Agatha was concerned about the 2 recent maternal deaths, but I think we'll need a more serious discussion on that. I hope you did the review, and I hope it is not because of the closure of Karboa Health Center 4, but you really need to review the 2 cases, because losses at health, we had for quite some time we have not lost mothers at health centers 3 and 4. Normally we lose them at hospitals because most of complicated cases are sent there and they reach late. But at lower levels, we have not had challenges with that. I was also impressed to see the statistics of VHTs improving referrals, where almost 40–50% of the cases coming to health facilities were by referrals by the VHTs, which indicated very good working relationship between the VHTs and our health facilities. And I think that was presented by Dr. Yu. And that gives us belief that we can still work very closely with the VHTs and the helpers to refer mothers. And maybe also divert those mothers from TPS and bring them to our health facilities. I also wanted to know, because LMNS is attached to regional referral hospitals, and I really want to see more and more involvement of the regional referral hospitals in this LMNS, because that should be the hub. That should be, like you have a wheel, do they call that the hub? Yes. Where everything rotates. And I see Guru here, but all regional referral hospitals, let's try to be the center of this LMNS. We don't leave our staff, don't leave our midwives, we not leave even our health center force and the rest to run LMNS alone, but you give them that necessary support and the necessary technical assistance. The use of photographs, you saw it here yesterday. It didn't sound very well. We didn't have time to discuss it, but let's please try to use photographs. Incidentally, it was reported that photographs are better used at lower levels. The higher you go, the cooler it becomes. So use of photographs should be encouraged from all levels, and they always have a standard answer that the mother arrived in the second, third stage, so we didn't have time to use photographs. Please, let's use photographs. They are very, very important, and let's encourage our staff to use photographs. The pre-referral communication and notifications. I also found that one very important, because if you are going to say, and I saw in the LMS, it is quite a common practice, but even without sending through WhatsApp, it would be very important. If you are sending a mother, let's say from say, which facility can I use? Okay, normally see, Chegekwa there to Mubendi. Why don't you get a call somebody on duty, so that by the time the mother rings, they know, and they know the problem and the complication, so that they are prepared. Let not the ambulance just roll in, and as soon as the ambulance is entering, that's when people are starting to prepare. That's when people are starting to find out what is the problem with this man. So really the pre-referral notification should be a standard practice for all our cases. Finally, I also want to comment on the inadequate staffing, which was raised again by Dr. Kevin, I think. This is true, because in many cases we are short of staff or inadequate staff, but it is also sometimes not very true in some situations because of the apparent absenteeism that we create ourselves. Because sometimes we go to health facilities and you find somebody has offs in many facilities actually. And those are some of the things which put off my PS when we are going for supervision. And the whole day gets spoiled. And if you are unlucky and it is early in the morning, then you know it's going to be a bad day for you that day. Because you reach a facility and you find somebody is off for 15 days in a month. And that's official off, prepared by our in-charge. Out of 30 days, 15 days off, 13 days off, 18 days off. Recently, in one of the districts where we were, somebody is off, including medical officers, clinical officers, midwives, off for 13, 15 days. Surely. That means you are working 2 weeks. So that creates the shortages we are talking about. So let's, as especially the midwives, the in-charges, I had quite a number of in-charges here. As we make our schedules, let's take into account that we do not give people too much off. Otherwise, you will run short of staff. You'll find yourself, you have nobody to cover weekend. You'll find yourself, you have nobody to cover nights. And sometimes the fact that you cover their evenings does not mean that automatically you go off tomorrow. I mean, we are all health workers. We do this. I used to work in Uganda. I would do my night. The next morning you can't go home until you do your ward round. Because my ward was mine. Whether I'm on night or not, I have to do my ward round before I go home. So the fact that you have been on night means that you still have to do your day, and then maybe you can go after lunch. So ladies and gentlemen, let's avoid this authorized absenteeism, which is authorized through duty schedules which have been prepared by ourselves. The clinical officers are the worst. Where you have 4 clinical officers, means one will work 1 week, the other one 2nd week, 3rd week, and 4th week. If there are 2, and the majority usually are 2, one will work week 1, goes away week 2, comes week 3, and then goes away week 4. So literally they are working 2 weeks. So ladies and gentlemen, let's avoid those unauthorized offs. Finally, I want to thank in a special way the midwives who continue to make us proud, who deliver our mothers. And if you look through our annual performance report, actually, Health Center 1, 2, 3, and 4 deliver 72%, I think, of all the mothers in this country. General hospitals and the regional referral hospitals and the national referral hospitals combined, all of them deliver just 28% of the money. And that's a fact. It's not theory. It is in our annual performance report. So, Health Center 4 downwards, we thank you for delivering our mothers. We thank you for improving the quality of health, maternal health in this country. We don't do many remarks. I thought I would use 10 minutes, I've used 20. But I really want to thank you because I felt I was talking to the real people who deliver our mothers, who provide obstetric services in this country. And that's why yesterday I remembered after I was advised that you must recognize the ADHOs specifically and the midwives specifically. Do not take them in the group that you are welcoming people from the districts. No. You have to recognize them in their individual capacity. And I did that wholeheartedly. Thank you very much. And I think the meeting is closed for today till we meet tomorrow.
Thank you, DG. I have the communication from the Secretariat that we have qualified for dinner tomorrow on invitation. And it will be at 5 p.m. So I think you'll be receiving a communication from the Secretariat.
I'm supposed to go for
E-invitation.
Yes.
Yeah. Thank you.